Okay, we are ready to start.
Hello, sir, Dr. Deshpande. Hello, sir.
Hello,
Yes,
Satyanarayan.
yes, sir. Yes, sir, Dr. Rajesh Singham.
Namaskar.
Namaskar, sir. To see you, nice. Singham.
Good morning to all.
Yes, sir, Dr. Anand Jawar.
Yeah, good morning.
Good morning, sir.
Hello,
Good
Ankur.
morning.
Good morning, sir. Good morning, sir.
Good morning, Gaya Ankur.
Ramrajidaya teacher.
Video off చేసి.
Rubina Mudas. Say
Good morning to you all.
Good morning, Dr. Padmini.
Good morning.
Hello, good morning, Kama, Dr. Padmini.
Good morning.
Hello. उसमें नीचे लिंक भी दिया हुआ है. ओके. हाँ, मैंने ईमेल आईडी पे डाला है. ओके, दोबारा बताइए. ओके.
Dr. Wadia, please continue.
Hi.
Yes.
Good morning, everybody. Now, in the morning today, we have got in the first session 4 excellent presentations presented by very excellent speakers, and each speaker has been allotted 20 minutes. I would request all speakers to please stick to the timings. To begin with, we have got the first topic, the female sexual dysfunctions and diabetes. This is being taken by Dr. Archana Deshpande, a very soft-spoken speaker with very hard content. I'm sure she's going to do full justice to the talk. Dr. Archana, before that, can I have her introduction on the slide, please? Am I audible?
Yes, yes.
Can I have her introduction on the slide, please?
Slide is there.
Slide is there. Slide is there.
Yeah, I can see it now. I need not really talk much about her. We all know her very well. To just sum it up, she's an associate professor in the Department of Medicine at GMC Nagpur, and she has many publications to her credit. The rest of the things, her words will speak louder than her introduction. Please go ahead, Archana.
Oh,
Good morning.
good
Good
morning.
morning to all of you from Nagpur. Though virtual conference is the answer or the option for the conference, but we are still missing the physical conference. I hope everything will be all right next year and we can meet. First of all, I'm very much thankful to CSEPI and organizers for giving me the opportunity. Thanks to my husband, whom I owe to everything. And I will be talking on the female sexual dysfunction in type 2 diabetes mellitus. If you see the epidemiology of the diabetes, this is the state which is characterized by the hyperglycemia causing lot of systemic manifestation. Not a single system of the body is spared by this diabetes. It is increasing the day by day. And if we go with the data, 463 million diabetics they are worldwide and expected to reach 700 million by 2045. If you took the Indian scenario, then the 77 million, that is more than 10.4% of the adult population is suffering from the diabetes. And most important thing is it usually affects the very fruitful age or the reproductive age or the middle age. In Asian setting, that is 42.5 years is the average age of onset, which is earlier than the other countries. A lot of things are responsible for this. Most commonly abundance of the food, which was not a thing which is made for us, because we were a very malnourished country and lot of food and everything is available with the lack of exercise, who genetically prone because of visceral body fat. All these factors, they are responsible for the type 2 diabetes. As diabetes affects all the systemic manifestation, or it causes all the system involvement, it also causes the psychological stress. So diabetic-induced end organ damage and the psychological stage, this is the combination which is responsible for the lot of systemic manifestations and hence for the sexual dysfunction also. When you see the definition of the normal health, it's a physical, mental and a social health, and not only merely the absence of the described as a dynamic and a harmonious state, which involves physical, emotional, interpersonal, social, and a spiritual well-being in a freely and responsibly chosen and ethical framework, and not merely the absence of the sexual disorders. So it is not merely the absence, but all these factors should be taken into account when you say that it is a normal sexual health. When diabetes, you think on the affecting the female sexual dysfunction. Otherwise, also female sexual dysfunction is difficult to diagnose because of intricacy of the female response. There is a limited literature and an aspect which is often ignored by the clinician, and a lack of communication. Nobody talks on these issues. If you see the global prevalence of female sexual dysfunction in the diabetes, it ranges from the 20 to 80%. Patients who had a systemic manifestation, macrovascular and a microvascular manifestation like nephropathy and a retinopathy, they have a more prevalence of the diabetes in female sexual dysfunction. Among the premenopausal women, 42.9% is the incidence of this female sexual dysfunction. If you look at the epidemiology of the female sexual dysfunction in the diabetes, the data and the prevalence is scarce and disordered because of lack of standardization and a changing definition what exactly means by the female sexual dysfunction. But all studies, they show higher meta-analysis shows
Others
higher
can mute.
frequency of
All the others can mute, otherwise there is some background noise there.
meta-analysis
જો આપણને જે લોકોએ રિમાઇન્ડર મોકલી છે ને આજે
is there. Meta-analysis shows that higher frequency of female sexual dysfunction in diabetes women than the healthy controls, and with the odds ratio of 2.27 in type 1 diabetes, 2.49 in type 2 diabetes, and 2.20 in any form. So, lot of people are suffering from the sexual dysfunction, but because of communication, nobody comes with these complaints. Recent meta-analysis also shows, which is a 25 studies, and it showed that overall prevalence of the diabetes in female sexual dysfunction in diabetes is 62.6%, so very high prevalence. Meta-regression analysis also shows significant increase in the prevalence over the diabetes duration. So as the duration of the diabetes increases, then its prevalence also increases. It also causes impairment of all phases of the sexual dysfunction: desire, arousal, lubrication, orgasm, and satisfaction. Other colleagues, Meeking and colleagues, they studied 270 women with diabetes ranging from the age group of 21 to 65 years. And they have found that decreased desire was seen in 64%, lubrication problem is 70%, orgasmic difficulty, decrease in the satisfaction 47%, loss of genital sensation because of neuropathy in 36%, and dryness of vagina in 43%. So all phases, they have been affected because of the diabetes. Female sexual dysfunction is a complex psychological and social risk factors. WHO says, definition is that the various ways in which woman is unable to participate in a sexual relationship as she would wish. This is the three-stage model of the sexual response: desire, excitement, and orgasm. Diabetes affects all the three stages. In the female sexual dysfunction, it's characterized by all the three stages abnormalities. FSD is also characterized by the lack of desire, loss or the lack of desire, sexual aversion, vaginal dryness, lack of sexual enjoyment, markedly delayed or a non-existent orgasm, vaginismus, and dyspareunia. Various organic things are responsible, we'll see later on. So how diabetes can affect a woman's sex life? It can be a hypoactive sexual desire because of inadequate vaginal lubrication, that is a painful sex, inability to achieve orgasm, vaginismus, vulvodynia. One cause could be because of the peripheral neuropathy or neuropathy rather, and a non-coital sexual pain disorder. If you see female sexual dysfunction, so all desire disorders, arousal disorder, orgasmic dysfunction, that the lack of lubrication is characterized by in the diabetes. Research finding, they also shows that 58%, different researchers, they almost showed 60 to 70% affection of the female sexual dysfunction in the diabetes. 58% problems in the lubrication, 50% decreased sexual desire, 50% they have a problem with the arousal, 47.3% they have a dyspareunia, 32.7% have orgasmic dysfunction, 42.7% problems in the sexual dysfunction, satisfaction. So almost 50% of the women who are diabetic, they have some or other problems with the female sexual dysfunction. What are the determinants of the female sexual dysfunction? Age. As the age advances, the prevalence is more. Duration of the diabetes illness. As the duration of the diabetes is more, all the complications are more. And so the female sexual dysfunction increases as the age duration increases. Presence of menopause makes the things more worse. Higher BMI, as obesity is also directly correlated with the female dysfunction. So more is the BMI, more is the prevalence of the diabetic female sexual dysfunction. Higher HbA1c, uncontrolled diabetes might be the thing, because all the systemic manifestations, they are responsible for the other dysfunctions. So is the female sexual dysfunction. Higher HbA1c, higher the prevalence. Higher HbA1c, more systemic problems, and more is the prevalence. Associated thyroid disorders. Diabetes is always associated with a lot of hypo or the hyperthyroidism. So exactly, thyroid disorders also causes some dysfunction and the diabetes. Dyslipidemias, which is characterized by the diabetes, high TG and low HDL. Psychological many factors. You can think somebody suffering from the diabetes, which is more fearful. All manifestations or the systemic problems will be there, and so is the fear. Addictions of smoking and alcohol addiction can make the things more worse. So combination of these factors, they are responsible, and they can cause more number of problems, more is the prevalence. And there are physiological mechanisms causing sexual dysfunction in women. Why there is this dysfunctions occur? This is, we know that this is characterized by the hyperglycemia. Hyperglycemia itself reduces the hydration of the genital mucosa. So it causes a poor vaginal lubrication, lubrication is decreased and it can cause dyspareunia. In hyperglycemia is also associated with a lot of vaginal and urinary tract infections, which may be the cause of sexual discomfort. It can lead to itching, burning, irritation, and the genital discomfort is responsible for the female sexual discomfort. Hormonal changes, low estrogen levels, which is seen in the diabetic patients, they affect the lubrication of vagina. It can lead to the lethargy, loss of interest, fatigue, and a depression. Psychological factors, as I told, that diabetes itself causes a depressive state. So depression symptoms, they are more common in the diabetics if you compare with the non-diabetics. Psychological anxiety, stress, low self-esteem, body image disorders, sexual performance anxiety, they are all seen with the diabetes. Depression, as I told, diabetes and depression, they have a bidirectional relationship.
Yeah.
Because a lot of things you have to curtail when you suffer from the diabetes, the lifestyle modification, you have to curtail your diet, you have to change all dietary modifications. You have many restraints over the your normal life. It can also lead to the depression and affecting sexual desire and arousal. Socio-cultural factors, limited social relationship, financial difficulties, lack of exercise can add to the problem. Physiological mechanisms causing sexual dysfunction in women with the diabetes, there are many. Vascular complications can affect the blood supply to the vagina. It causes a lot of vascular complications. Like in male dysfunction, they say that cardiac dysfunction can be because of erectile dysfunction comes before the cardiac dysfunction, but this relationship is not seen with the diabetes, not seen with the female sexual dysfunction. So vascular can affect the blood supply to the vagina, and it can cause problems with the lubrication and painful coitus. Neuropathy and neurological disorders, as it causes the peripheral neuropathy and other neuropathies, it can lead to the vulvodynia. It can lead to the structural and the functional changes in the female genitals, reduced sensitivity and impaired sexual response. As such, no exact treatment for the neuropathy, but vulvodynia can be taken care by if P-GABA can be symptomatically given as for other peripheral neuropathies. Other psychological causes, if they are present, they can add to the things. So anxiety, performance pressure, tiredness, fatigue. Diabetes is most of the time characterized by the fatigue, anger, depression, and mood disorders, and addiction, interpersonal problems, and poor hygiene can add to the problem. Female sexual dysfunction is also correlated with the lower education, lower income, urinary tract symptoms in cancer survivors, history of the sexual abuse, trauma to genitalia, use of antidepressant, and disturbed spousal support. If it is not exactly related with the diabetes, these additional problems, if they are present, they can make the things more problematic. So challenges: inaccessibility of trained female healthcare and medical professionals, lack of privacy and confidence. If you go to the endocrinologist or if you go to the physicians, hundreds of patients they are sitting, even the physicians don't have any time for this detailed history and counseling and all. So lack of privacy and confidence can be the one of the factors to tackle the things. Social taboo attached to the subject of the sexual health and the gender inequity, and a lack of resources of the medical services. Personal taboos regarding the sex. Nobody likes to communicate regarding these issues. Confidentiality. Everybody is afraid of whether somebody may disclose the thing, which may impact our social life. Worries about the potential humiliation. Time constraints, as I told. If diabetes is complicating with the ischemic heart disease, it is causing cellulitis, it is causing peripheral neuropathy, then you don't have this. You don't give importance to the sexual problems or the sexual dysfunctions. Time constraints and a doctor's limited experience in the management of the sexual problems. Even if they disclose to the doctors, the physician, they exactly don't know how to tackle the problem. What physicians can do. Sexual performance is an aspect often neglected in the daily practice, as I told. He should be aware of the possible presence of sexual dysfunction in the female patients. Sexual history has to be a routine part of evaluation in females with the type 2 diabetes mellitus. Identify pertinent pathology and refer them to the appropriate management. Or you can give some tips or you can use some drugs to tackle the things. So there are treatment options which are taken, can be advised to the woman with the diabetes. If there is a problem of the reduced vaginal lubrication, then education regarding need for the adequate stimulation prior to the penetration can be advised. Then lubricants, specifically water-based vaginal lubricants, can be advised. Hormonal replacement whenever is necessary. And arousal enhancement strategies can take the problem or tackle the problem to some extent. Take care of the genital infections. If the patient is complaining of white discharge or patient is complaining of itching or urinary tract infection, then it can be tackled properly with the antibiotics and antifungal agents. Vulvodynia, dyspareunia, you need investigations, or you can put the patient on the lubricants. And as I told that vulvodynia could be the manifestation of the peripheral neuropathy. Some pre-GABA or some neuropathic drugs can be given to take the tackle the things. Reduced focus on the penetrative state till the problem is over. An orgasmic difficulty, penetrative or the non-penetrative vibrating devices can be advised. Clitoral therapy devices can be advised, and a psychosexual support. Reduce libido, review and treat any concurrent illness. You can give the psychosexual support for any self-image. Then supplementation by the DHEA, or you can give advise serotonin receptor antagonist, and a PDE5 inhibitors. Now this is difficult, but this, we'll go to the next slide. Lifestyle interventions. Beneficial effects on sexual functioning, especially among obese women with the diabetes. Healthy diet can be advised. You can advise them how to tackle with the obesity, exercises, and appropriate therapy for the optimum glycemic and the metabolic control. You take diabetes and you take all the complications. The first and the foremost key is the optimum glycemic control, not to the extent of hypoglycemia, but as you control the diabetes or as you control the HbA1c level, you will be postponing the complications. I cannot say that you can avoid the complication. It is a postponement. And with a good control, 10 years postponement of all the complications. So appropriate therapies for the glycemic control, you can advise a good hypertensive control, and also the dyslipidemia, you can advise them the atorvastatin and the statins for the control of dyslipidemia. So controlling all the modifiable risk factors or modifiable factors can be taken care with this lifestyle intervention and can able to some extent improve the problem. Early screening and the diagnosis of diabetes in the female sexual dysfunction in the diabetes. Repeated vulvovaginitis must be suspected in the diabetes. Sex education and counseling is as important as the drugs. Vaginal lubricants and moisturizers for vaginal dryness or dyspareunia in the postmenopausal woman with the diabetes. The willing and interested party. Thanks a lot for giving me the opportunity. Thank you.
Thank you, Archana. You have covered a lot of ground in a very short time. And you have really given the hardcore facts, substantiated it with relevant statistics also. Very easy to understand and assimilate. Before we go to the next speaker, the next talk, would the organizer like to give a memento to the speaker? Or will that come later?
Dr. Wadia, I think we can take the
Paras, there's a lot of disturbance. Can you speak again? Paras, you are not audible. Are you mute?
There's some problem with the network, I think, for Paras. Paras has to unmute.
Dr. Padni,
Can you hear me now?
Yes, yes.
Yeah, now you are audible. Shall we?
So we thank the speaker and felicitate by offering bouquet and the memento. Though it's e-memento, the speaker is just beside me, but I cannot offer her the bouquet and memento because I have not offered to anybody else. So thank you, the speaker. Chairperson can continue.
Sanjay, you can physically offer her the mementos.
Yes.
When you are going to offer physically?
During valedictory, we will do that.
Okay, I'll introduce one more speaker before I request Paras, my co-chairperson, to introduce the next speaker. The next talk is basically female orgasm. During the process of counseling, I always say any gentleman is worth his salt if whether he has the orgasm or not, he always takes his partner to the orgasm. So there's something which is very important. We all know sex is not something which a man does to a woman or a woman does to a man. So the orgasm becomes very, very important. So for this very important subject, the speaker is Dr. Padmini Prasad. I need not really again introduce her. She has been one of the strongest pillars of CSEPI, not only academically brilliant, she's been an author, and if I start talking about her, probably I'll go endlessly. The slide is on your screen. You can have a look at the slide, and let us welcome Dr. Padmini Prasad for this talk.
Thank you very much, Dr. Wadia, for the kind introduction.
I will stop share so that you can share the screen.
Now I'll share the screen. Yeah, I profusely thank CSEPI for giving me this opportunity to be with you all to talk on an important aspect of female sexual functioning. Female sexual functioning is a reality now because with more and more education, employment, economic independence, availability of contraception, and the knowledge, so women have come to know about what is sexual functioning, what she has to expect, what is orgasm, what is climax, whether there is satisfaction or not. So though this is on one side of the spectrum, but on the other side, there are women who just enjoy being with the husband and not even know that itself is their orgasm. They most of the time they do not know what exactly is the orgasm or whatever that they are enjoying is that the orgasm. That also many women do not know. But of late, I have many women coming to me and asking me, doctor, my friend says that you have to have such a good satisfaction and you should have that pleasure, you should get a shock-like feeling and all that. So whatever she describes, I am not getting. Is there something wrong with me, doctor? That is the one which females started asking me. And they have so many times husband brings the wife to say, doctor, she is not enjoying. She says she is not feeling anything. I don't know what is wrong. Either there is anything wrong with me or whether there is anything wrong with her. But there are various reasons why women do not enjoy, they are not getting orgasm. Whether the technique of intercourse is wrong or whether the male is suffering from a problem or there is an interpersonal relationship or the woman herself is having the problem. Because I also get so many cases from family court, just a lack of foreplay, no satisfaction and not enjoying the sexual interrelationship itself has become a problem for them. And so that with the disturbed interpersonal relationship, they can go to the court, family court. And recently Dr. Archana was also explaining how some of the diseases, the diabetes, one of the major causes can be a cause for lack of orgasm. So now, women can have multiple orgasms. This is the other thing. Men cannot. They are actually the sexual athletes, not the men. So that's what is told by Lizzie Kaplan. So PubMed search female orgasm, if you see, there are so many searches on this website mainly for female orgasm. So the sexual response depends on a complex interplay of physical, psychological, and emotional factors between two persons, as you all know. It is coordinated by the neurologic, vascular, endocrine systems and influenced by family, society, and religious beliefs. So sex is not just a simple thing or a straightforward thing. There is the mind, body, and soul attached to it with various external factors. Traditional human sexual response cycle of Masters and Johnson and Kaplan are showing these are the various phases. I don't go into the detail because you're all well aware of it. Desire, arousal, plateau, and orgasm. So that arousal, plateau, orgasm, and resolution was the Masters and Johnson's, and the desire was added by the Kaplan. There is also a description about enhanced and expanded orgasm pattern in expanded sexual response and extended orgasm as defined in various resources recently. They have been explaining or describing there has been an extended orgasm in many women where there is a multiple and prolonged orgasm. There is various pathways for the theory of female orgasm which have been described, though of course everyone knows that it is mainly the clitoris and the abundant nerve supply into the clitoris and extension of the erectile tissue all around. So that is the one which is responsible for orgasm. But there are also different nerve pathways which have been described. At least 6 pathway orgasmic reflex arch systems work during the development of female orgasms. Pudendal, pelvic, hypogastric, intercostal, and vagus nerves constitute the main nerve network system. Also, there are at least 2 oxytocin pathway systems, whereas oxytocin works as a neurotransmitter and as a hormone separately. During expanded orgasms and extended sexual response orgasms, more than one orgasm reflex arch pathway is activated and trigger an expanded orgasm, while many others contribute to the formation of an EO or ESR orgasms. You can see these various pathways which are there and which ultimately lead into the orgasm. Even the other things, stimulation of the nipples, stimulation of the intercostal region, and reflex vagus pathways are being described. So what is female orgasm? 1 minute, I will... The female orgasm itself has been comprehensively defined as a variable, transient peak sensation of intense pleasure, creating an altered state of consciousness, usually accompanied by involuntary rhythmic contractions of the pelvic region, circumvaginal musculature, often with concomitant uterine and anal contractions, and myotonia that resolves the sexually induced vasocongestive mechanism, sometimes only partially, usually with an induction of well-being and contentment. Just a minute, I will go to different... So I want to go into the speaker thing because my part of this slide is getting covered. 1 minute. Okay. So this is what is female orgasm, that is in brief a description. And if effective sexual stimulation continues late in plateau phase, a point may be reached where the body suddenly discharges its accumulated sexual tension in a peak of sexual arousal called orgasm. It is a total body response involving the brain, spinal cord, sympathetic nervous system, peripheral nerves, muscles, cardiovascular system, and genital organs. Orgasm is a brief episode of physical release from the vasocongestive and myotonic increment developed in response to sexual stimuli. Psychologically, it is subjective perception of a peak of physical reaction that was described by Masters in 1966. So this is the briefest phase of sexual response cycle. There has been an intense feeling of physical pleasure at the culmination of sexual stimulation, marked by simultaneous rhythmic muscular contractions of uterus, outer third of vagina, and anal sphincter, around 0.8 seconds per intervals, A mild orgasm can have 3 to 5 contractions, and an intense orgasm can have 10 to 15 contractions or even more if there are extended orgasms. Orgasm is a total body response. Different muscles of the body contract. Sex flush becomes prominent. Women describe orgasm as beginning with a momentary sense of suspension, quickly followed by an intensely pleasurable feeling that begins at the clitoris and rapidly spreads throughout the pelvis. Genital sensations described as warm, tingly, and these spread through the body. Finally, most women feel muscle contractions in their vagina or lower pelvis. This is described as pelvic throbbing, and most women do not ejaculate. Biologically, orgasm is the shortest phase of SRC, usually lasting for only a few seconds, during which time rhythmic muscular contractions produce intense physical sensations followed by rapid relaxation. Psychologically, orgasm is usually a time of pleasure and suspended thought. Mind turns inwards and enjoys the experience. Orgasm can be mild, intense, or absent. Women's orgasmic capacity depends on her age, sexual experience, sexual stimulation she receives, and her relationship with the spouse. So various terminologies which have been described: anorgasmia, where she has not experienced orgasm, or there are multiple orgasm, extended orgasm, pre-orgasm. Many women just fall short of orgasm at the stage of pre-orgasm, unable to go into the orgasmic level. Missed orgasm, just about to get it, but it is missed. Elusive orgasm, faking of orgasm. Many women, just to please the husband, just fake the orgasm so that he should not feel bad. So that if I don't get orgasm, my husband may feel bad. That is the concern of many women for their husband. Simultaneous orgasm. So whether there is the orgasm, both husband and wife get orgasm at the same time, because many think they have to get simultaneous orgasm. So they don't know that the orgasm the timings can vary. They can get it before or after or simultaneously. So different types of female orgasm which have been described. The clitoris orgasm by stimulation of the clitoris. Vaginal orgasm, though we don't really know, could be caused by stimulation of the G-spot, or maybe indirect stimulation of the clitoris, or something else entirely. Exercise-induced orgasm. Exercise, particularly weight training, cardio, and abdominal focused exercise. Orgasm during sleep. We also don't know exactly the cause. Could be caused by sexual dreams, stimulation caused by bedding, or nothing at all. Other orgasm, stimulation of the nipples, anus, and other sensitive areas. Every body is different. A combo organism can be achieved by pleasuring the vagina and clitoris simultaneously. The result will be a powerful climax that one can feel inside and out. Both the hands can be used to double the pleasure or combine fingers and sex toys. This is one rabbit vibrator which can stimulate the clitoris and vagina at the same time and are perfect for mastering the combo orgasm. The cervical stimulation has the potential to lead to a full body orgasm that can send waves of tingly pleasure from head to toes. And this is an orgasm that can keep on giving, lasting quite a while for some. The doggy style position allows for deep penetration to try being on all fours with a penetrative toy or partner. So after hysterectomy, they say some amount of orgasm is reduced because of the absence of cervix. The clitoris contains a bundle of nerve endings and is located in the front of the female vulva and under the clitoral hood. The clitoris, similar to a penis, will swell, enlarge, and become more sensitive as a person becomes more sexually aroused. It is not the simple thing or just what we see externally. It extends all over. It has got such a big tissue, erectile tissue, and the corpora cavernosum crux, and then glans clitoris. That's what. It also surrounds vagina, urethra. That is how the erectile tissue is spread all across in the genital area. Direct or indirect stimulation of the clitoris can lead to clitoral orgasm. The fingers, palm, or a small vibrator can all help to have a clitoral orgasm. Make sure that the clit is wet and begin gently rubbing inside out or up and down. If it is dry, again it can cause irritation. As it begins to feel good, apply faster and harder pressure in a repetitive motion. When one feels pressure intensifies, apply even more pressure, or some ladies do not like once it is very sensitive. Although few people are able to climax with vaginal stimulation alone, it sure can be fun trying. An intense climax can be felt deep inside the body. The front vaginal wall is also home to the anterior fornix or A spot. The A spot also is described in anterior fornix and G spot is described lower down. Older research suggests that stimulating the A spot can result in an intense lubrication and even orgasm. So the pressure has to be, the focus has to be on the anterior vaginal wall. Where is the G spot? The G spot is an area along the front wall of the vagina. For some people, it can produce a very intense and very wet orgasm. Fingers or a curved G spot vibrator are the best way to hit it. The G spot is an area filled through the wall of the vagina, an inch or two behind the back of the pubic bone, near the junction of the bladder and the urethra, and made up of tissues of the clitoris. That is, all these things are the surrounding erectile tissue that is being stimulated. Less than 1 in 5 women reported being able to orgasm through vaginal stimulation without clitoral stimulation. That's why without clitoral stimulation, if it is that, I will be telling the women that only with the intercourse or only with the man's stimulation, you cannot have orgasm. You also have to add up your own fantasies, imaginations, and a clitoral stimulation will definitely take her to orgasm. Even now, there has been doubt about whether the G spot exists at all. There are various erogenous zones all over the body. The body really is a wonderland. The neck, ears, and lower back, for example, are rich in erotically charged nerve endings begging to be touched. We can't say exactly which parts of the body will drive one to the brink, but we can tell that everyone has erogenous zones and finding them is definitely worth the effort. That's how the sensate focus and exploring their own body can teach them or tell them they can understand about their body. Nipples are full of nerve endings that can feel oh so good when played with, when stimulated. They set the genital sensory cortex ablaze. The bum play can be pleasurable for anyone if one has enough lube and take time. Massage the outside and inside of the opening, then slowly and gently insert sex toy or finger into the anus. Try a gentle in and out motion. Exercise-induced orgasm has been described. Exercise, especially weight training, cardio, and abdominal-focused exercise can induce orgasms, which is also known as orgasms in pop science, and other positive genital stimulation. This makes sense biologically as both exercise and sex can stimulate the muscles around the genitals and can lead to increased blood flow to the area of the body. Exercise may also influence the mood via endorphins and other neurotransmitters similar to sex and orgasm. Orgasms during sleep. Many people experience sexual arousal or orgasm during sleep. It is difficult to say what or how exactly this happens because reporting from dreams can be unreliable. It is difficult to say if all arousal and orgasms during sleep are caused by sexual dreams. Similarly, no research has currently looked at whether people were unconsciously stimulating their bodies during sleep or were being stimulated by bedding or other objects. Is female ejaculation a thing? Yes, and it is a fairly common thing. The most recent cross-sectional study on female ejaculation found that more than 69% of participants experienced ejaculation during orgasm. Ejaculation occurs when fluid is expelled from urethral opening during orgasm or sexual arousal. The ejaculate is a thick whitish fluid that resembles watered down milk and contains some of the same components as semen. What makes a female different from the male orgasm? It may be surprising, but they aren't all that different. Both involve increased blood flow to the genitals, faster breathing and heart rate, and muscle contractions. Where they typically differ is in duration and recovery, also known as afterglow. Female orgasm may also last longer, ranging from 13 to 51 seconds on average, while male orgasm often ranges from 10 to 30 seconds. People with vagina can typically have more orgasms if stimulated again. Individuals with a penis typically have a refractory phase. Orgasms aren't possible during this period, which can last from minutes to days. Then there is ejaculation. For a person with penis, contractions force semen into the urethra and out of the penis. So female orgasmic disorder, what is it? Now you understood what is orgasm, whether the varieties of orgasm, how she can be stimulated by various stimulations. Female orgasmic disorder is characterized by a persistent or recurrent distressing compromise of orgasm, frequency, intensity, timing, and or pleasure associated with sexual activity for a minimum of 6 months. Persistent or recurrent delay in or absence of orgasm after a normal excitement phase, causing marked distress or interpersonal difficulty. It can be primary, it can be secondary after experiencing orgasm for some time. It can be situational or global. So the female orgasmic disorder, in the frequency, orgasms occur with reduced frequency or diminished frequency of orgasm, or can be absent. Intensity, if you take it, orgasm occurs with reduced intensity or muted orgasm. Timing, orgasm occurs either too late, delayed orgasm, or too early, spontaneous or premature orgasm than desired by the woman. The pleasure component, orgasm occurs with absent or reduced pleasure. So this is also another condition. Epidemiology, if you take global study of sexual attitudes and behaviors, found that for women aged 40 to 80 years, inability to achieve orgasm varies across world regions, with frequencies ranging from 10% to 34%. There is considerable variation in the prevalence rates of orgasmic dysfunction from 16 to 25% in different parts of the world. These are the various prevalences about desire, arousal, lubrication, orgasm, satisfaction, and pain. So 5 to 10% can have anorgasmia, where any amount of stimulation, any type of stimulation will not allow the woman to have orgasm. This is a condition known as anorgasmia. 90% orgasmic by some means or the other. 50% climax during coitus. What are the risk factors for this orgasmic dysfunction? Temperamental factors includes various psychological factors, including pregnancy concerns and anxiety. Environmental factors, physical and mental health and relationships are strongly associated with it. Socio-cultural factors, genetic and physiological factors like multiple sclerosis, pelvic nerve damage, vulvovaginal atrophy.
Madam, time is over. So
okay, 2 minutes.
okay.
So these are various causes about organic and non-organic causes of orgasmic disorder. So prognosis, little is known about the natural course of female orgasmic disorder or about the prognosis for women with untreated orgasm. So these are the various history, medical history should be taken, relationship history should be taken, along with the general physical examination, laboratory workup, whether there is any hormonal disturbances or vitamins and the other blood sugar and other things, and approach psychotherapy, pharmacotherapy can be used for orgasmic disorder. Dr. Archana also has described about the treatment. So management includes all these: education, counseling, and the various usage of vibrators, clitoral stimulation, sensate focus exercise. A happy sex life, although portrayals of orgasm in media, partners' expectations for our orgasms, and our own interest in experiencing orgasm can make us feel like we need to have an orgasm every time we have sex. A happy sex life doesn't necessarily mean having a mind-blowing orgasm during every sexual experience. Orgasm is just one of many important elements to sexual satisfaction. So many people report that not all orgasms are the same. Minds and bodies are changed. So unrealistic expectations should not be done. But orgasms, it's also difficult to study the orgasm. So Sigmund Freud popularized the clitoral stimulation and vaginal stimulation and about the orgasm. The orgasm is great, but feeling pressure to have an orgasm or a certain type of orgasm at a certain time can make sex stressful and unpleasant. So these are all intimacy, sexual pleasure, sexual satisfaction do not depend on orgasm always. So this is a flow chart. Thank you very much for the patient hearing.
Dr. Padmini, please stop share. Thank you.
Paras is muted. Paras and Vadia both are muted.
Thank you, Dr. Padmini. They say orgasm is like sneeze, easy to experience, difficult to explain.
We
have explained it has
felicitate the speaker by offering the flower and the memento.
Thank you very much.
Please accept that. But you have made the orgasm understand so clearly, and every time we hear you, we have plenty to learn. So I'll now request my co-chairperson, Dr. Paras and Dr. Jolly, if they are available, to please go ahead.
Dr. Saroj is not well, so I request the chairperson to ask the next speaker to come and talk. Dr. Paras, please unmute yourself. Yes, yes.
Just one minute. Yes. Dr. Padmini had covered excellently. As Dr. Vadia said, it's like sneeze. Once you have, then only you know what is a sneeze. Otherwise, it's as difficult to explain rainbow to the blind person. She has covered very simple and simply way each and every point of orgasm. Now we have the one more stalwart speaker who is a pioneer, who is a pillar of the CSEPI. That's none other than the Dr. Raj Brahmbhatt. He's the director of a Kama Institute of Study. He's a consultant at Nanavati Super Speciality Hospital in Department of Sexual Medicine. He's the editor-in-chief of our News and Views bulletin. He is having lots and lots of awards in the sexual medicine. He was awarded Sexual Health CSEPI India in 2014. He had done plenty of workshops, not only in India, but abroad also, like Bangladesh, Nepal, and Sri Lanka. He's going to speak why women should read Kama Sutra. So over to Dr. Raj Brahmbhatt. Sir, only request be on time so we can accommodate other speaker on time. Thank you.
You can share your screen, Dr. Raj.
I'm sharing. Good morning, friends. Can you listen to me? Hello?
Yes, sir.
Yes, sir.
Yes, sir.
Yes, we can
Thank you,
listen to
Paras,
you.
for a nice introduction and nice to see all of you in the morning. Today it was not a good morning for me. I had been recently operated, but whenever CSEPI treatment comes, I always feel better. So with you, right now I am there. So let's begin with Shri Ganeshaya Namaha, Shri Kamdevaya Namaha, and Shri CSEPI Namaha. I start saluting all three of us. My topic today is why women should read a Kama Sutra. I can tell you there are two words, Kama Sutra and Picasso. There are so many myths around them. And if you ask everybody, they say we know about it. But when you go into detail, they know zero about it. Kama Sutra, first time, Dr. Prakash Kothari and myself read at 1983. It was Asia conference. And somehow we did a Jugalbandi. Two people with two podium. I spoke on ancient part, he spoke on a modern part. And from that time onwards, I have been speaking on Kama Sutra. Every time I find something new. And this is today I'm going to talk to you why women should read a Kama Sutra. All of you know 4 pillars of Hindu faith: dharma, that is moral life; artha, income or security, most important; kama, sexual desire or pleasure; and moksha is the last salvation. It may not come in the same way in everybody's life, but these are the 4 pillars which are very, very important for Hindu faith. In the beginning of universe, the God felt, let me be from one to many. And the desire started. Now, once they started multiplying, Brahma, the Prajapati, we call a Prajapati as Kumbhar or a clay maker. What he does, his hand goes on, make something. So Brahma or Prajapati created 1 lakh adhyay. Out of them, Dharma part was separated by Manu, and which is known as the Manusmriti, Artha by Brahaspati, and Kama. When Nandi, the attendant of Shiva, saw Shiva and Parvati in a relationship, from his mouth, the flowers came out, and that is known as Kama Sutra. It was in 1000 Adhyay chapters. Svet Ketu made it 500, Babhravya 150, and then it was divided into 7 parts with the request of other people. They say we want one, others say other, and it was dismantled. It was the Vatsayan who brought all of them together. So 7 books which are written by Charanya, Gotakmukh, Gornadia, Ganika Putra, Suvarnanab, Dattaka, and Kochumaru. And this happened roughly around 300 AD. So you can imagine when world was sleeping, we had, and our Pandits had come out with a complete, total manual on the subject of sexuality. Now, who was Vatsayan? Was he a vagabond? Was he a dojoa? Was he a Casanova? No, friends. He was a religious fellow. Very little is known about him. He was in Banaras, what we know Kashi, what we know Varanasi. He was on the bank of Ganga River. And there, if you read over here, Mali Naga Vatsayana. Mali Nag is surname and Vatsayana is the real name. But the most important part, this Kama Sutra, it would not have come to us or the world. Thanks to Sir Richard Burton, who was a Britisher, who was serving in Indian infantry in India. He was interested in many things in the life. So what he did, from Banaras, Jaipur, Madras, and Kolkata, he got a manuscript. And he got some Pandits who could not speak English, he could not speak Sanskrit, and got some interpreter. And by that, what they prepared, the Kama Sutra of Vatsayan was known to the world for the first time. And what he left the work, his assistant F.F. Arabinot did the work. Now, this Richard Burton, in 1883, can you imagine, established what is called Kama Sutra, Hindu Society of London and Banaras. So he was the person who brought the Kama Sutra to the world. Not only that, Arabian Nights, all of us has read during the childhood. It is translated by him. Vikram and Vaital, translated by him. And he went to Makkah and Medina even, where nobody is allowed. So after Vatsayan, if I have to salute one person, is Richard Burton, and Richard Burton. Because of them, we know many things about Kama Sutra. Question comes, is sex and Kama the same? No, friends. When we say the word sex, we mean male or a female. Genitals, lovemaking, sex act, sexual intercourse, vaginal and anal penetration, and sexual relationship. So it has so many things. When we say what sex, had done a sex, it can be without changing your clothes, there can be a sex over there, over a telephone even. While Kama, there is no parallel word in Sanskrit, let me tell you. It's a delight of body, mind, and soul. All three together. In an exquisite sensation, awakens eyes, nose, tongue, ear, and skin. All five senses. It's not like an animal sex. How many of us have enjoyed with all five senses and our partner getting sensual also? And between sense and sense, the essence of Kama will flower. You all of us been drinking in the party. When we say cheers, we see in the glass the wine, color we see, we bring it to the nose, we smell it, we taste it, and we use the word cheers. And then it goes to the mind. So all five senses are used, and that is what is the calm. Anything which can make you really happy is the calm. Now, is Kama Sutra the only book on Kama? Many a time feel. Childhood, some of the, you might say that you have seen some book on a yellow wrapper called Kok Shastra. Yes, that was another one. But there are many books. Kok Shastra, Kamratna Tantra, Panchasaika, Anangarangar, then Kama Samhita. And I could find, like in Dharma, Manusmriti, Shilpa Shastra, Natya Shastra. So anything in India, we went into the detail of that subject. And I could find 34 books on Kama Shastra in English, Marathi, Gujarati, and various. So you can imagine that it was just not an ordinary thing. It was a pure science. And nowhere in the world you'll find parallel to it. Is it a pornography? The moment you think of Kama Sutra, what we have seen the books in the library, when we go to the airport or other things, we think it's just a pornography. Or we see the sexual positions over there. No, friends. It describes the daily life of a Nagarak. That is a civil person. It shows how to enjoy the life. Festivals like Holi, Vasantotsav, Saradotsav, Navratri. The man can go for shooting outside. The female can take care of the home. In the evening, there is a goshti. There is a discussion going on between man and woman, or man and man, or the Vidwans over there. So it is a real document of that particular era of our life. Does it give a direction for any personal hygiene? Yes. It gives a lot of importance to the personal hygiene. As you enter the temple, you take a bath and you go. Same way, Shringar has been given a lot of importance. All Sola Singar, the looking into the mirror, cleaning up of all the parts of the body, using the sukhad, chandan ointments, and wearing the different types of clothes and the abhushana. This was a part of it. Apart from that, women were asked to sing, they were asked to learn music instrument, they were asked to play various types of game, make various types of food, puzzles, take part into the discussions. So 64 arts. Today what we are seeing, a beauty pageant. She's been given all sorts of things that what are you experts? Same way they were groomed just before the marriage in 64 arts. So it was not only a sex, not only a body, but beauty with the brain, and that is what they had created Kama Sutra. So female was given a lot of importance. Does it describe the size of male and female and sex organ just for the fun? All of you have been practicing as a sexologist, and you know many men comes out with the fear that the size of the penis is small or a large, or somebody's is bigger than that. Now, Kama Sutra has described 3 types of penis, like that of a rabbit, that of a bull, that of a horse. The other is the counterpart, deer, mare, or elephant. What is the meaning of it? Why they have been described? Is it just for the pleasure? No. They say superior one can join to each other, middle one can join to each other, lower type can join to each other. But when there is a incompatibility, how asanas, different asanas can be used. So even an incompatible person can enjoy to the fullest their sexual life. Is it for the man's pleasure? All the time we thought that Kama Sutra is in the hand of a man. You can never find in the hand of a female. No, friends. It is very, very important that it says that the woman should take an active role in the sex. First of all, preparing some sarbats and food and other things, decorating the house, knowing that how her partner will be pleased, starting with the music, wearing the different clothes and abhushan's, learning how to talk with him, and last but not least, when he finds that her husband, either from the beginning of the sex or when he finds that he's tired, like a person in a diabetes or heart patient, she can take up a male above position. So female on the top position, if you ask your client, hardly few of them have done it. This is the most satisfying position for the female. So she rides on the male and enjoys it. In our Vedic period onwards, we have given a concept of Ardhanarishwar. And I think Kama Sutra is really followed. When we say Jai Sitaram, we say Radha Krishna. We never say Krishna Radha. The women important has been always given in our mythology. And Kama Sutra is no exception to it. Should it be read only by the man? No, it was not forbidden for the man. What they say, woman's pleasure is the most important part. She should come first. Kama Sutra urges man to focus on woman and pleasure her before his own. Once the woman comes on pleasure, next time she will be begging for the sex. Otherwise, what happens nowadays today in our social society? The man gets excited. He asks the woman to help out either on a Saturday night or somewhere other odd times. He gets the erection. He penetrates, he ejaculates, and that's an end of it. He does many a man, they do not know where is the clitoris. Many a man, they do not know what is their wife's likes as far as the sex is concerned. Whether they like oral sex, anal sex, whether they like to be touched at some part. It is not even known. So many times. They don't know even that whether their cleanliness of them is a very important. A small little things, like if teeth are not clean, if he's eating tobacco, if it is smelling of alcohol, if there is a dandruff, if there is a perspiration smell, she would not like to enjoy it. Thanks to this lady, Wendy Dozner, also Sandhya Mulchandani and Vinod Verma, they have come out with a beautiful books on Kama Sutra, why women should read it. There is another lady also who is an activist and she has written against it, that women has been given one more work to do. But really speaking, this woman has really brought out that women are very, very important as per the Kama Sutra is concerned. And they also say that apart from that, they say on the first night, failures are occurring. If you ask the Western world, there is hardly a chapter on it. Myself and Dr. Agrawal has written first night failures. First time in this book, Theory of Common Sexual Problem, a handbook edited by me. First night is the worst night. Man is about to show his masculinity. She has to show her virginity. It's a night of a marathon. There's a performance anxiety, fear of failure, and spectating role. So how does the Vasan describe the first night? During those days, they meet for the first time during the marriage. Sometimes in a king, the sword goes and gets married with the Rajkumari. The first time when they are meeting, there is a lot of fear, anxiety. They do not know how their partner looks like, what sort of a person he is. So they say the songs comes up, Gungat Uthalo. So Suhagrat, first night, Madhu Chandrachi Ratri, golden night. It has been described in all languages, all our film and in the novels. If any woman, Vatsan says, taken by force on the first night, she will hate sex. So what is more important? You cannot have sex with somebody unless and until the trust has been developed, unless intimacy has been developed. So what he says, that first 3 nights, they should sleep away from each other, not on the same bed. He should try to talk to her, praise her beauty, talk to her and make her happy, give her some gifts, go to the relatives, take a simple food, and on the 7th day, in the evening, at the twilight, look at the atmosphere he has created. No sun, no moon, in between. Very quiet place. Just near their garden, there is a pond, and in the water, so the texture comes up. Slowly they touch each other, and then the spark starts. So this is how they have described. They talk about only sexual position. Unfortunately, more than 30 years back, when digital camera came, Japanese group had come from Mitsubishi, one of their branch. They wanted to make a film on Kama Sutra. They were doing videos. They say we want to make in Japanese, Spanish, and also in English. They said we'll write it down, even a book of it. But what they were interested, today we have done 26, tomorrow we'll do 62, third day we'll do 8 number. It was just a mechanical. While Kama Sutra is not there, it shows a most beautiful way. Foreplay, play, and after play. Embracing or alingan, kissing or chumban, making with the nail, nakakshatra, bite, danta darshan. Now these are all foreplay. It takes a time. Man can get excited within no time moment he sees the body, but the female takes a line. So she requires an 8 type of embracing, kissing, making, marking with nail and teeth has been shown. Then union of congress, asana, different types of asanas. Then pratihar, striking and crying, the making a sound, biting with each other, hitting with each other. Women above position as I have described. And mukha. It does not stop here. It's just not a mechanical position every time you do it. Every time it is different. It's not a catalog of sexual position. It has been very nice. This poster was there in the era of HIV/AIDS. The more the number of partner, and if you are not protected yourself, there are more chances of HIV/AIDS. So they say rather than going to many partners, many posture with one is better than many. Imagine that in your own life, you have every day, every time you have a sex, different type of sexual atmosphere. You can play a role. You can go to the bathroom. You can go to the bedroom. You can go to the drawing room. Varieties of ways in which you can play, and that will be much better treatment than getting HIV/AIDS. Who should read a Kama Sutra? As I have said that not only a male but female. Can she read before the puberty? Yes, friends. They say a physician without the knowledge of herbs, an accountant without the knowledge of figures, and a married man without the knowledge of sexual science are all worthless creatures. So we must, it's a manual. Read about Kama Sutra, read about that time's atmosphere. Many of things may not be relevant today, but it gives you principles, ideas, the theories, philosophy, which is very important to me. Before marriage, the woman can read it. She can be explained by her elder sister or some respectable relatives, or even the Vaishyas, or during those days, Nagarvadhu. I had seen in Udaipur Palace, beautiful painting, where a Rajkumari, she has been shown with the dildo, that is a ivory penis, and who was teaching her? The courtesan or the Nagarvadhu of the Udaipur. She was teaching her how to have oral sex with that. So before marriage, she can study Kama Sutra. After marriage, she must ask her husband, and sometimes a part can be read. Kama Sutra promotes the woman's right to property. What Supreme Court says now, 200, BC, Kama Sutra describes it. Kama Sutra believes in woman giving a control over household. How to make, room, how to make a garden, what sort of atmosphere, what pet should be there, everything. She has been given an equal right of pleasure. It's not that she's just a passive partner or what we call a lying in a ice piece. And women were given freedom to marry a person of their choice. Only thing that a higher woman cannot marry a lower class person, but lower class woman can marry a higher class person. So these were the things as far as the woman is concerned. And does it only contains the pictures of sexual position? No, friends. This is a picture I got it, which was on the cover page of my book. If you go to Khajuraho, the first temple which is there, small 1 feet by 1.5 feet panel is there. You can see over here. There's an orgy going on. Group sex, oral sex, anal sex, real sex. And what is happening over here? That two people are pondering something. They may be having Shilajit, Musli, some Bhasma or whatnot. Vajikaran. Apart from this, in Ayurveda, very big science is there. That by taking some portion of it, a man acts like a
Dr. Brahma Bhatt.
and they does. Last slide.
Yeah, okay.
And then if ointment and bark which can be applied to contract the yoni of one night. This is, I say, today we are doing a vaginoplasty after the lex vagina. This could be done very easily by applying some barks or some ointments or some leaves. Now, this is a challenge to our pharmaceutical industry. We do not know what is there or not, but the concept which was there, which is a very important. Is it relevant today? Yes, friend. It's the Western scientists like Masters and Johnson who were pioneer in sex therapies, who gave a dual sex therapy and sensate focus. More important is given to sensuality, not the sexuality. So all throughout Kama Sutra, you see, people think it is a position, people think it is an animal sex. No, unless and until two soul, two mind, two people meets, and in a beautiful atmosphere, sex cannot progress. And the greatest thing, I said 3 times, the greatest thing, Vatsayana has said, is an authority. But once the potter's wheel is on, forget the law, forget everything. They say once both of them in their private, if they are enjoying, if they are enhancing, they can do anything what they want to do as far as the sex is concerned. And I tell you, so long as the lips shall kiss, so long as the eyes shall see, so long lives this gives life to thee. The Kama Sutra is eternal. जब तक सूरज चांद रहेगा, तब तक काम सूत्र रहेगा, तब तक सेक्स रहेगा और तब तक हम सेक्सोलॉजिस्ट रहेंगे. I tell you, it's the most important part that every time I go to Kama Sutra, like bringing out some pearls from the sea, I get something entirely different, and I'll request all of you to read apart from your dharmic pustak every day in the morning Kama Sutra. Thank you very much.
Thank you, Dr. Brahma Bhatt. Only please stop this screen share so that I will start.
Okay.
Yes, sir.
Very nice one, sir.
Thank you, sir.
Very good. Excellent.
Informative.
Excellent.
Enjoyed it. Lecture, sir.
Sir, लगता है कि आपको सुनते ही रहे बस.
Sir, we offer you the flowers and the E memento, Dr. Brahma Bhatt. Please accept it.
Thank you.
Your lecture was like that. We should have continued it for hours together.
Honest.
So next time we'll plan some workshop only on Kama Sutra.
Don't ask me to bring
the speaker.
Don't ask me to bring samples also. Kindly bring your own samples. And lastly,
That's great.
You could see I got an energy because I am with CSEPI.
Yes.
In the evening, I may not be there. I had to go to my surgeon right now, and I'll be coming back. If I get a chance, I'll. Thank you very much for giving me
Welcome,
such a
sir.
beautiful opportunity. Take care. Wish you all the best. And I had seen it has been conducted very well. Sanjay and all gang, my heartily congratulations to all of you. Take care.
Thank you.
That's great.
Thank you, sir. Thank you. It was very nice presentation, Dr. Raj Brahma.
Thank you.
Thank you, sir.
Excellent one.
It's very nice.
So
one.
next speaker is Dr. Allas Satyanarayan Reddy. Can I go ahead?
Yes, introduce him and then he will start.
Sure. It's a pleasure to introduce Dr. Reddy. He's a consultant at Leo Institute of Sexual Medicine, Hyderabad. He's a consultant in fertility and sexual medicine of Apollo Fertility, Hyderabad. He's an adjunct professor in reproductive and sexual health, Indian Institute of Public Health, Hyderabad, and the professor of obstetrics and gynecology at Vinayak Mission Medical College, Carmichael, Pondicherry. I request our eminent speaker to give his presentation.
Now you can upload your presentations. Start.
Thank you, Chairperson. My topic for today's discussion is hypersexuality, a little different from the routine things which we talk about. This is uncommon, but more troublesome than all of the things which we do. I am Dr. Satyanarayan Reddy. There is a spectrum of sexuality from asexuality to sex addiction. In between, there is a hypoactive sexual desire disorder, normal sexuality, high sex desire, and hypersexuality. To label somebody as hypersexual, or we should know what is normal sexuality. The frequency of sex changes with age, with health, with situations, life events, and partners also. One man's sex desire in the first year of marriage may be twice a week, whereas other man is having sex times a week. Both these couples are happy with their sexuality. If the husband's sex necessity is twice a day and the wife is happy with twice a week, then the man can be labeled as hypersexual by the wife. The man can label his wife hyposexual. So there is no standard definition of hypersexuality. All men in adolescence, first love, or newly married life, or initial days of a new extramarital affair can have frequent sexual fantasies, sexual urges. He is mad at love. It may impair his social functioning, but he is happy and passionate about it. Some men, for a large part of their lives, have strong, vibrant sexuality, high sex desire, and high frequency of intercourse or masturbation. These men are normal, feel happy, and they have pride over their sexuality. They don't have any psychological disturbance. In contrast, normal sexuality, in contrast, is hypersexuality of Casanova. In pathological hypersexuality, high sexual urges, fantasies, and sexual behavior cause mental distress. The desires are difficult to control and adversely affect their social functioning. When this is associated with the elements of addiction, that is craving, tolerance, dependence, and withdrawal, they can be labeled as having sex addiction. We look into the pathological hypersexuality, not excessive sex desire. Hypersexuality is having many names: satyriasis, Don-Juanism, nymphomania, Messalina complex, sexaholic, erotomania, hypersexuality, problematic hypersexuality, compulsive sexual behavior, sexual compulsivity, out of control sexual behavior, sexual impulsivity, porn addiction, cyber sex addiction, and lastly, compulsive sexual behavior disorder. The last one, that is compulsive sexual behavior disorder, is the official nosology for this condition today. Now, Messalina complex. Now to defining sexual compulsive sexual behavior disorder, Kinsey 70 years ago coined the term total sexual outlet. That is the number of orgasms at masturbation, at intercourse put together. A person experiencing more than 6 orgasms a week is considered hypersexual by Kinsey. Till now, there is no clinical entity called hypersexuality. A proposal was made to in the Diagnostic and Statistical Manual of American Psychiatric Association in 2013 to include it in the DSM-5. The proposed diagnostic criteria are, over a period of 6 months, recurrent and intense sexual fantasies, urges, and sexual behavior unsuccessful efforts to control it, causing clinically significant impairment in the social functioning, and the person is at least of 80 years of age. But this proposal was rejected. International classification of diseases by World Health Organization laid down the criteria for hypersexual disorder. They are a persistent pattern of failure to control intense repetitive sexual impulses or urges, resulting in sexual repetitive behavior over a period of 6 months. The repetitive sexual behavior caused marked distress or significant impairment in personal, family, social, and educational areas of function. This was accepted as a clinical entity by the name compulsive sexual behavior disorder with a code name of ICD-11 6C72. It is categorized as an impulsive control disorder, a psychiatric condition, not a sexual dysfunction. This is going to be implemented, this terminology implemented from January 2022 onwards. Now we go, after knowing what is the definition of a hypersexuality, why people have problematic hypersexuality. It is a common symptom of organic diseases, strokes, Parkinsonism, frontal lobotomy, and can be iatrogenic also. Hypersexuality is having a neurobiological basis and a genetic basis. For the shortage of time, I am skipping all of these ones. Our microRNA 4456, DRD4 gene, reward center, failure of the reward center are known to produce this disease. Bipolar disorder, obsessive compulsive disorder, then attention deficit hyperactive disorder of the adults, substance abuse disorder are all associated with compulsive sexual behaviors. A child abuse need not be sexual. A physical abuse as a child, mental abuse as a child, or a sex abuse can predispose people to develop compulsive sexual behavior in later life. Homosexuals and bisexuals are having increased probability of having increased probability, not always. Paraphilic behaviors are commonly associated with compulsive sexual behaviors, so it can be categorized as paraphilic and non-paraphilic behaviors. Men with sexual dysfunctions like erectile dysfunction and premature ejaculation are more prone to develop compulsive sexual behaviors. This is not because this is a coping mechanism for their failures. Then men with personality traits like shame, loneliness, high religiosity, internalized sexual negativity are all the candidates for the compulsive sexual behavior. In a UK study, half of them in a UK study, 50% have compulsive masturbation. How they present? That is, %51 has pornography dependence, 21% have extramarital affairs, half of them have mental health problems, 40% have experienced emotional abuse, 1/6 have experienced physical abuse, 1/6 have experienced sexual abuse, and 1/4 has sexual dysfunctions. 40% or half of them lost their relationship recently. Put together, more than 2/3 of the men have some psychological disturbance as a cause of the compulsive sexual behavior, as an associated factor also. What are the sexual activities that people with hypersexuality resort to? A solo activity like a compulsive masturbation or a compulsive pornography usage. In a partnered activities, having sexual affairs, sex with strangers, one-night stands, hiring sex services, phone sex, cyber sex, and cruising for sex partners. Thus, in a sex clinic, In a sample of in an outpatient clinic that deals with hypersexuality, 56% have compulsive masturbation, 51 has pornography dependence. I repeat, pornography dependence, and 21% extramarital affairs, and excessive unprotected sex and habitual solicitation of commercial sex workers. What are the consequences of a hypersexual desire disorders? That is loss of a job, financial loss, ending of an ongoing relationship, or separation, or a divorce with the wife, or negative mental health, poor social interactions, or a loss of a public image for the man, emotional hurt of the partner, or a not able to enjoy sex, and development of new sexual dysfunctions, sexually transmitted infections, and ending in legal problems. The sexual addiction saga of Tiger Woods is a classical case study. It is a classical case study of sexual addiction. Tiger Woods, the greatest golfer of all the times, born to Afro-American father and a Thailand mother. He started practicing golf at the age of 2 and reached peak at the age of 20. His father is a golfer for himself, would have sex with blondes in a car parked next to the golf course. Tiger Woods, observing it since childhood. His mother was silent even when aware of his father's sexual behavior. Money and fame unleashed his sexuality. His wife is a model. He had 12 mistresses and 120 women. He used it to solicit the services of high-end commercial sex workers, spending 100,000 rupees on sex services for a day. Former madam who serviced Tiger Woods alleged that every couple of months he requested to have multiple girls. It could be up to 10 girls at a time. He liked young college cutie girls, girls next door, and blondes. He is into role playing. He is dressing in a suit, and the paid girls are like puppets to him. He used drugs at these occasions. He had sleep disturbances, cannot sleep without sex, does sex whole night, multiple times in a night. His sleeping pill is sex. His sleeping pill is sex. When exhausted, he recharges himself with a plug of vagina. He did sex with a whore at a time on the day of his father's death also. He lost money, profession, fame. Wife divorced him. He got treated for sex addiction. Even while going for the sex addiction clinic, his mobile was loaded with XXX movies. After de-addiction therapy, he had a steady relationship, but cheated on her also. This is a classical case of sex addiction, how sex addiction develops. Now, what is the prevalence of hypersexuality? As per the Kinsey study, if you take into consideration 7 orgasms a week, then for 5 years, 7.6% of people had 7 or more orgasms per week. Even now, in the USA, 5% of the high school boys masturbate daily. As per his definition, all of these are hypersexual. No. In Sweden, in a representative sample in Sweden, out of control sexual behavior in the past 1 year is seen in 13% of men and 7% of the men. But when it is associated with a distress, which is the key here, interfering with their lives, 0.8% of men and 0.6% of women are hypersexual. Hypersexuality is common between 20 years to 30 years of age. Men outnumber women by 6:1. Then how to diagnose hypersexuality? How to diagnose? There is a screening test devised by Cornish et al., known with a mnemonic called PATHOS, PATHOS, that is preoccupation with sexual thoughts, ashamed of it, treatment for it, and hurted somebody with his behavior, out of control sexual behavior, and sad afterwards. Once it is screened, then how to diagnose? That is a detailed diagnosis of a problematic hypersexuality is a detailed history of his sexual activities, psychological assessment clinically and by psychometry, substance abuse and iatrogenic causes, history and examination of his sexual dysfunctions, clinical examination, laboratory investigation for his hormones and sexually transmitted diseases, and how to differentiate this from others, that is excessive sex desire, even though the number of sex outlets is same, but there is no distress, there is no dependency, there is no out of control behavior in a increased sexual desire. A primary bipolar disorder, primary OCD, primary ADHD or hypersexuality is one of the symptoms of the disease. It is not the disease. A substance abuse manifests as hypersexuality, and a medical condition and a medications causing compulsive sexual behavior disorder. All of these things, if you rule out, then the person can be labeled as hypersexual desire disorder. Several assessment scales are devised to validate hypersexuality qualitatively and quantitatively also. A word of caution: don't make a diagnosis of compulsive sexual behavior by the moral judgment of the clinician. We too decide about somebody else's sex by our standards. No, it has to be done by the established diagnostic criteria only. Penalizing excessive sex desire of a man and making a diagnostic of compulsive sexual behavior disorder is to be avoided. Just liking a sex a lot does not make you a sex addict, and just cheating or engaging with a prostitute does not make you sex addict. If you are a sex addict, just like you are a heroin addict, you are at the point where you are having sex not because you are deriving pleasure from it, but because you need to do that just to fall asleep, to wake up in the morning, and not to have withdrawal symptoms. So while true sex addiction is rare, but it is a problem of pleasure-seeking behavior. Then we go, what is the treatment for problematic hypersexuality? That is, treat the comorbid psychiatric diseases, treat comorbid paraphilias, treat sexually transmitted infections. Psychotherapy is the mainstay of treatment, pharmacotherapy whenever it is needed. The psychotherapy involves an individual, can be done to an individual alone or in the group of a men having the similar problem, or the couple treatment can be done in the conjoined form. The partner, the family, or somebody who is having a concern over the patient or whom the patient had a faith can be also be included. The client writes his inventory of sexual behavior, autography history, life events which resulted in this maladaptive behavior. He writes everything over a piece of paper. Then he will be able to identify which one is the problematic one and what to be done for behavior therapy for those instances only. Then the pharmacotherapy involves two varieties, a psychotherapeutic drugs and anti-androgens. Naltrexone 50 to 100 milligram daily, SSRIs like sertraline 25 to 150 milligrams daily, or escitalopram 10 to 15 milligrams daily. The androgens are necessary for sex desire and for sexual arousal. Lowering testosterone by anti-androgen makes his sexual desire lesser and subdues his sexual system. Cyproterone acetate 50 to 100 milligrams daily reduces the testosterone. Medroxyprogesterone acetate, a synthetic progesterone, which gynecologists use commonly for a DOB, or injectable medroxyprogesterone acetate called Depo-Provera, used for female contraception, or a leuprolide used for infertility treatments. All of these things, when used in habit, all of these things reduce testosterone or make it almost zero testosterone. Say, sir, half a minute, sir. This is called medical castration when used for a habitual sex offenders. So here, a clinical presentation, when somebody comes with a frequent masturbation, then we can think that he is not having enough of sex. Social skills training. When the relationship discord is there, it is unfulfilling sex. So couple counseling. When there is a midlife crisis having sexual dysfunctions, treat sexual dysfunctions. When it is happening to some context, some context only, or substance abuse, treatment for that one. And lastly, a disinhibition of sex or change in the behavior. He is not having any inhibitions to do in public also. It is too much of sex he is doing as presentation. Look for physiological causes of some disease in the brain. Then these three circles work, that is female hypersexuality is less common. Porn addiction, cyber selection is becoming increasingly common. It leads to sexual dysfunction. Yes, sir. And
sir, please conclude, sir.
Yes, sir. Over, sir. This is a addiction anonymous. Okay. Thank you for your patient listening, sir.
Okay, sir. Thank you. Please, sir, stop your screen share.
Excellent talk, Dr. Reddy. It was marvelous.
I water रहता 9%, so perhaps or
Yeah, we offer the e-flowers and e-memento to Dr. Allah Satyanarayan Reddy. So kindly accept it, being a non-physical conference.
Yes, sir. Thank you very much, sir.
Dr. Padmini, are you there?
Yes, I'm there.
So should we actually?
You want to read the slides?
Yes. Dr. Gumaste's slides. Should I share that?
Yes. You have to move the slides because I am not.
Yes. I will share that. I will stop this share.
Can somebody can
share
introduce
her
her?
Yes.
Let me take the opportunity.
Yes,
Dr. Waze?
jolly, definitely.
And
okay, then I will have to stop this share and I will have to just run that previous slide.
You can read this, the please concentrate.
So what I will do, I will just focus first on the madam's biodata. Sorry for this. Yeah.
okay, I can read now. Okay, can I go ahead?
Yes.
Dr. Suraj Gumsate. She is a consultant in sexual and reproductive health, diplomat of American Board of Sexology, MBA Health. She is running a meditation center for adolescent and other age group, formal consultant to population education at cell of CBSE, Adolescent Reproductive and Sexual Health Ministry of Education and UNFA, Director of Zephyr Medical Services, having chain of medical centers in India and abroad for communicable and sexual transmitted disease. She is ex-honorary Vice President, CSEPI, experience in treating women from most of the countries and most of the walk of life, undertaken extensive research in life skill-based sex education and development of buster and tribal children and adolescents. Recipient of prestigious Golden Lamp Award from CSEPI. I request Dr. Padmini to please continue.
Yeah, you can share screen, Dr. Sanjay. So this is just I am going through the slides for Dr. Saroj Gumaste. So sorry that she is not feeling well and she could not present, but she has requested me to read that. Okay, full screen you can make it. Make it full screen. Can you make it full screen? and come to the first slide.
Once you click on slideshow, it will become full screen.
Yeah, that they are not. No, I'm there only moving the slides. So they have to share screen from there only.
One has to click on the slideshow, and that then it will be full. Please click on slideshow.
I already did it. Can you see, but Dr. Padmini?
Yeah, I can see, but it is not in the full screen forum.
But it is already there.
No, it is there, but not in full screen. Make it
Dr. Sanjay, it is not on full screen.
Slideshow mode. Has to be slideshow mode.
Sanjay put
You
F5. F5.
Yeah, F5.
Yeah.
F5 कौन सा है? F5. Is it? आ गया?
नहीं आया. F5 लगाइए.
No, I am just telling you. You just click on slideshow. On the top, there is a slideshow, and it will ask from beginning. You click on from beginning, and that will be in full
Sir,
screen.
we have done that. I have done everything.
Okay, like that only you
Okay.
can move. That's okay.
Okay, then let us continue
Sanjay
this
sir.
way only.
Share your screen again, sir.
Let it be like that
I
only.
will share my screen again.
Yeah, you share screen, and if it is not possible, you leave it. I'll just go through that. After I finish reading one slide, you can move it.
Is it there now?
Now it's okay. Now it's okay.
Okay.
Now it is there.
So let us begin, Dr. Padmini.
Yes, yes.
Now it's there.
Good morning, good morning, everybody. This is about the importance of testosterone, which he has prepared these slides. Can others please mute it? Because there is some background noise. Yeah. It is crucial for women to maintain a proper balance of testosterone and estrogen levels in the bodies to remain in a positive state of homeostasis. This can be difficult at times as hormone levels fluctuate at various intervals of female life. For example, pregnancy, premenopause, and menopause. Next slide. The synthesis of testosterone and estrogen. Next slide, please. Testosterone and estrogen are naturally produced by ovaries, adrenal glands, and body fat. Natural conversion between testosterone to estrogen takes place. So testosterone is converted to estrogen. Decline in natural production of testosterone to estrogen levels occurs between 40 to 55 years of age. Next slide. Next slide, please. The production of testosterone in women is lower than in men. After puberty, women begin to produce adult level of testosterone. Level of testosterone peaks in early 20s. Contraception suppresses all sex hormone production. At menopause, women may have only half of level of the testosterone. So the average level of testosterone in adult female is 15 to 17 nanogram per dl. Total and free testosterone in women, if you take it, women more than 50 years, women less than 50 years, and women more than 50 years, where it is total and free levels are shown here in nanogram and also in picogram. So next slide, please. Hormonal balance. Whenever there is hormonal imbalance, the perimenopause is a transition period with signs of increase in belly fat, the first sign of hormone decline, irregular periods, vaginal dryness, mood swings, and mental fatigue. Next slide. The benefits of testosterone in women include: testosterone plays a vital role. Women's overall health, physical and emotional well-being, keeping bones strong. With decreased level of testosterone leads to osteoporosis. The maintaining lean muscle mass. Maintaining proper brain function, lower level of testosterone can lead to mental fatigue, poor memory, cognitive decline. Treatment can help reverse these conditions. Benefits of testosterone in women, if you continue, the pain management. Imbalance of testosterone leads to erratic response to pain. Maintaining sex drive, this keeps women feeling enormous. It's responsible for sensitivity of women's nipples and clitoris associated with sexual pleasure. Anti-aging effect, keeps skin supple, liver and blood vessels are protected. Though testosterone contributes to healthy sexual function, but many other factors also play a role in postmenopausal sexual dysfunction. Next, please. Symptoms of low testosterone in women include low libido, vaginal dryness, decreased bone density, muscle weakness and decline, weight gain, depression, and mood swings. Next. So this also can lead to agitation, memory loss, mental fog, hair thinning and loss, poor sleep, heart attack, and Alzheimer's disease. Next. What leads to high testosterone? You know that especially in PCOS, which is very common these days, there is high level of testosterone, which is responsible for various symptoms of the syndrome of PCOD. Ovarian tumors, congenital adrenal hyperplasia, diabetes, obesity, thyroid disorders, disorders of pituitary axis like dwarfism, gigantism, acromegaly, and Cushing syndrome. Next. For what leads to low testosterone? Age more than 40 years, estrogen progesterone therapy for long duration, surgical menopause, that is removing of the ovaries, primary hypogonadism, pituitary gland malfunction. So the high testosterone, that shows the symptoms of high testosterone include acne, hirsutism, excess body hair, loss of scalp hair, drop in HDL, high density lipoprotein. This leads to increase in heart disease. So the investigations include free and total testosterone levels, estrogen and progesterone levels, thyroid function test, serum prolactin to rule out pituitary adenoma, blood sugar levels, ultrasonography pelvis and abdomen, BMI analysis, if indicated, pituitary scan. Replacement therapy. Little bit of testosterone can help in improving looks, figure, energy level, outlook on life, sex appeal, and sexual fulfillment. Using compounded bioidentical cream, gels, patches, or pills with monitoring of blood test, physical examination findings, and symptoms. Testosterone preparations are not approved by FDA for use in women. Long-term safety of testosterone therapy in women is still unknown. Usually prescribed for women who have sufficient estrogen levels. Women who are on HRT, estrogen with or without progesterone can have suppressed residual testosterone production by the ovaries due to pituitary ovarian axis suppression. Next. Common brand names of testosterone preparations include Androderm, Androgel, Dipotestodiol, Dipotestosterone, Estrotestrin, Testoderm, Virilon IM, and Testro-LA. Next. Side effects of topical testosterone include breast enlargement, decreased sexual desire, acne, hair loss, hot flushes, depression, and mood changes. Because still the exact dose, the duration, and still it needs a lot of studies to know which is the safer dose in women. Next. Side effects of topical testosterone also include nervousness, headache, weakness, insomnia, dry skin, changes in ability to taste or smell, skin irritation at site of application. Next. Nausea, vomiting, changes in skin color, ankle swelling, increased calcium in blood, enlarged breasts, deepening of voice, facial hair, acne in women. Especially the facial hair and other side effects they are not reversible and that becomes a major problem with testosterone treatment. So how to treat women with high testosterone? Low dose glucocorticoids daily for 2 to 3 months, prednisone 2.5 milligram in the morning, 5 milligram at night, dexamethasone. It reduces adrenal gland androgen production, acne, improves fertility, mild reduction hirsutism and excess hair. Metformin 250 milligram, 2 grams daily or 500 milligrams PD also. With blood levels of glucose, kidney function and liver function becomes important. Estrogen and progesterone therapy like ethinyl estradiol 20 to 35 microgram and a progesterone decrease acne, helps prevent loss of scalp hair. Spironolactone 25 to 200 milligrams daily improves scalp hair loss. Associated side effects like fatigue, dizziness, headache, reduced sex drive. Next. Can you move this slide? Drug interactions of testosterone include, it may reduce blood sugar and insulin requirement in diabetic patients. So changes in anticoagulant therapy. We have to rule out certain medical conditions before initiating testosterone replacement. That is the breast cancer, sleep apnea, heart problems, diabetes, kidney disease, lung disease, liver disease, pregnancy, or breastfeeding. All these things have to be ruled out and proper investigations have to be done before starting testosterone therapy. The other androgens which have been found to be useful, DHEA, 25 to 75 milligrams daily. It is a weak male hormone and level declines with age. Very few research studies show benefit from replacement. New England Journal of Medicine says DHEA treatment improves sexual function in women who have underactive adrenal glands. Excessive amount of synthetic androgens drives down HDL cholesterol. People who are ill have low DHEA or low testosterone levels. This is a normal physiological response to illness and not the cause of the illness. Next. So in conclusion, to conclude, testosterone is an important hormone for women. Investigate to find cause and treat accordingly. Replacements have to be tailored as per the requirement and titrated as per the blood levels. So one has to be very careful in giving testosterone treatment. Especially this testosterone also is known to be useful in postmenopausal, perimenopausal. Some testosterone patches are being used, but still the exact dose has not been determined and lot of research and further studies are needed before you use testosterone in females. Next. So thank you very much. I thank Dr. Saroj Gumaste for allowing me to read her slides. Thank you very much for the opportunity.
On behalf of Dr. Saroj Gumaste, I thank Dr. Padmini for taking this because she was not able to present here, even online also. So thank you, Dr. Padmini.
Thank you very much.
On behalf of all these chairpersons, myself, Dr. Paras sir, Dr. Vadia sir, and Dr. Jolly sir, I thank CSEPI for giving us this opportunity to chair this session, and Dr. Sanjay Deshpande also very thankful. Now over to Dr. Deshpande.
Yeah, thank you all the chairpersons, Dr. Paras Shah, Dr. Jolly Arora, and Dr. Colonel V.K. Vadia for chairing this session. We offer the e-bouquets to all the chairpersons. Kindly accept it.
Thank you very much.
Thank you, sir.
So we'll move on to our next topic, next session. That is on child sexual abuse, and the second part is sexual medicine from the perspective of a general practitioner. The chairpersons for these are Dr. Raj Singh Sawant and Dr. Ankur Agrawal. Dr. Ankur is here. Welcome, and we thank Dr. Ankur Agrawal and Dr. Raj Singh Sawant for chairing the session. Raj Singh is there? Yes.
Yeah.
Hello. So I hand over the. I offer the flowers to both the chairpersons and then request them to start the session. The first speaker is Dr. Kush Junjunwala.
Thank you. Thank you, Dr. Sanjay Deshpande, sir. Dr. Kush Junjunwala is next speaker. He is a leading pediatrician in Nagpur. He was president of IMA Nagpur for year 2019 to 2020. He is a co-chairperson of IMA MS PPS and he is honorary pediatrician of Nagpur Police. Today he is going to speak on child sexual abuse. I request Dr. Kush Junjunwala to start your presentation.
Thank you, sir, for the kind words. First of all, as part of the organizing committee, I welcome you all to this 37th National Conference of Sexology hosted by CSEPI as well as the Dattamekhi Institute of Medical Sciences, Nagpur. I, on behalf of the organizing chairperson, Dr. Sanjay Deshpande, who is also my mentor, to this 37th Virtual Conference of Sexology. Is the slides visible, sir?
Yeah.
Yeah.
Back at, yeah, now it's okay.
Yeah. So it's very difficult to give a lecture after stalwarts of CSECPI like Dr. Archana Deshpande Madam, Dr. Prasad Ma'am, Dr. Raj Brahmabhat sir, and Dr. Ala Reddy sir. I also welcome the distinguished chairperson for this particular talk, that is Dr. Raj Singh Sawant, as well as Dr. Ankur Agrawal. He's a very good friend of mine. I think you all will be there on the same page with me if I say there is no greater evil than those who willingly hurt an innocent child. You all too are very well versed with this movement, which is known as a Me Too movement. So basically, this was a social movement against the sexual abuse and sexual harassment where people publicizes the allegation of sex crimes. 2018 saw the rise of the Me Too movement in India, and it was inspired by the global campaign against the sexual harassment and assault. Women across the spectrum opened up and shared their stories about abuse by men in position of power. So child sexual abuse is a subject that has received much attention in recent. Historically, it has been there in India, but it was a hidden problem, largely ignored in public discourse and by the criminal justice system. Basically, it was led out by the criminal justice system of India. As you know, India is the second most populous country in the world, and of it, nearly 19% of the world's children, they live in India. So India has one of the largest population of the children in the world that is vulnerable to all the types of abuse, neglect, and exploitation. Of the total population in modern day India, 44% under 18 years of age. So this is a sad part on our side that every hour there are 4 child victims in our country. That means around 4,000 cases in a month and 130 in a day. So India is home to one of the largest number of sexually abused children in the world, but there is a general reluctance to talk about it because of the social stigma which is associated with this problem. The Indian government, or according to the Constitution of India, the protection of children by the state is guaranteed to the Indian citizen by an expensive reading of Article 21 of the Indian Constitution. And it also mandated given India's stature as signatory to the UN Convention on the Rights of the Child. I think you all know this India shame. I will call it as India shame. Kathua rape case, Uno rape case, the infamous Delhi gang rape case, Mumbai gang rape case. In March and April, again, there were repeated cases of gang rape in Kanpur, Meerut, etc. So every day you pick up a paper and you will see lots of news, at least 3 or 4 news regarding child sexual abuse in India. I will just tell you a recent story. Today morning, the Times of India, again, there was an article. It was a massive, there was a school for disabled, that is specially able children. That was a Divyang school in Raipur. Again, Yesterday night, there were multiple cases of gang arrest in that particular school by the caretakers of the school. So what is child sexual abuse? So according to WHO definition, the involvement of a child less than 18 years in a sexual activity that he or she does not fully comprehend, is unable to give informed consent to, or for which the child is not developmentally prepared and cannot give consent, and at the same time, it also violates the law or social taboos of the society. So what are the different types of sexual abuses? It could be sexual assault, exploitation, and grooming. Exploitation is basically, it's a commercial transaction, offenses in which an adult victimizes a minor for advancement, sexual gratification, or profit, for example, prostituting a child. Whereas grooming, generally it means an establishing emotional connection with the child and sometimes with the family to lower the child's inhibition with the object of sexual abuse, and thus to lure the minor into various illicits such as child prostitution, child trafficking, for example, in an online chat group. So, what are the factors that facilitate child sexual abuse? One of the major factors is poverty, but that is also seen in rich families, overcrowding, extension. There are so many causes which can lead to or which facilitate child sexual abuse, but by no means it is exclusive to India. Admittedly, that impact might be exaggerated or intensified given the population density and the size of our country. Thus, a complex mix of individual, ecological, and the situational factors that are said to facilitate the child sexual abuse might account for its prevalence in the Indian context. And I think you should not be surprised if you just look at today's Indian Express. There was an article that since Germany, there are elections which are going to be held in the next 15 days. So one of the major agenda that in their country is to stop child sexual abuse, especially of their athletes. So it is a worldwide phenomenon. So child sexual abuse offenses, they are against children, they are massively underreported due to the culture of shame and silence in our country, which is further intensified by the fact that nearly 95% of the cases involves unknown perpetrators. So it is a unique crime with unique behavior and unique dynamics. Why a child may not disclose abuse? Because what we feel as a pediatrician, what I know is that children, they do not have any language. They feel they are hurt by betrayal. Basically, they are helpless with powerlessness. And at the same time, they are also struggling with stigmatization. The child blames himself or herself and think that abuse is not their fault. So this is classically what goes into the mind of an adolescent, because what he thinks is, if I tell you I was sexually abused, then will you judge me, believe me, see me as less of a man, add to my sense of shame, question my sexuality? But the rape of a child is a violent act of contempt. It is not an expression of sexuality or affection. So as a doctors, believing and supporting the child are two of the best actions to start with the healing process. During the last 30 years, the focus on the extent and the nature of the child sexual abuse and the neglect have been coupled with an increasing interest in the impact on child's development, the health, and the mental well-being. We all know there are long-term side effects of child sexual abuses, which may range from eating disorders, somatic concern, guilt, shame, self-loathing, etc. And after years of negative self-thoughts, survivors have feeling of worthlessness and avoid others because they believe they have nothing to offer. And at times, it can also lead to suicides. They can have irregular nightmares, sleeping difficulties, disruption, aggression, and aggressive in schools, poor school performance, and the problems of sexual desire. They are supposed to be the long-term effects of child sexual abuse on their sexuality. They have difficulty in making romantic or intimate relationships. They have difficulty forming attachments. Because I think you always agree with me that abuse is never contained to a present moment. It lingers across a person's lifetime and has a pervasive long-term ramification. I'm not wrong if I can say we can deny our experience, but our body remembers. So what is the role of mental health professionals like us? Basically, we have a very key role to play in assisting the child as well as his family in the hour of crisis. We have to do an assessment of psychosocial issues. We have assessment of lethargy. We have to do catharsis. Catharsis is basically provide emotional and psychological support to the child. And at the same time, the most important point is we have to install hope, because we have to attempt a positive resolution of the traumatic experience of the child, help in reducing the obsessive deterioration of self-respect when the child comes to believe and trust that change is possible. And for me, hope never dies. So what should be the initial approach? The initial approach to treating a person who has been a victim of child sexualism depends upon several important factors, like age at the time of presentation or the circumstances of presentation for treatment. And the goal of the therapy is not only to treat the current mental health issues and trauma-related symptoms, but also to prevent future ones. There can be family therapy, group therapy, or individual therapy. For example, which course is used depends on the variety of factors that must be assessed on a case-to-case basis. For example, for instance, the treatment of a young child generally requires strong parental involvement and can benefit from family therapy. But at the same time, the other adolescents, they tend to be more independent. They can benefit from individual or group therapy. The government of India legislated various child-centric acts, such as number 1, Commission for Protection of Child Rights Acts, which is known as a CPCR Act 2005. Second one is the Protection of Children from Sexual Offences, that is known as POSCO Act, which came into existence in 2012, and the Juvenile Justice Act, that is also known as a JJ Act, which comes into play in 2015. While the JJ Act, that is the Juvenile Justice Act, it ensures the safety, security, dignity, and the well-being of the children. The POSCO Act is comprehensive law that provides protection to the children from the offense of sexual assault, harassment, as well as pornography. So what are the distinctive features of POSCO Act? The POSCO Act basically was enacted to address the criminalizing a range of acts including child rape, sexual assault, harassment, as well as pornography involving a child under the age of 18 years. The Act has faced unforeseen challenges in its complete implementation. Its implementation is pathetic in the country, and the pace of enforcement is very slow. While the cases registered under POSCO Act are constantly on the rise, including brutal rapes, the rate of conviction is just 4%. The acquittal is 6%. So high dependency of child sexual act cases renders POSCO toothless act or toothless law. And what are the challenges which was faced by enforcement of this particular law? There were some administrative bills, like as per the provision of the POSCO Act, the state government, in consultation with the Honorable Chief Justice of High Court, should have designated a session court as a special court and to try offences to facilitate speedy trial, but that is generally not done. Secondly, there's a lack of expertise to handle such cases among both the honorable judges, lawyers, as well as the associations which deals with such certain cases. And then further, the police and the other officials, they're also not sensitized enough for the crimes such as child sexual abuses. So what is the need of the hour? We should have a multidimensional approach, a speedy trials, and similarly, the doctors has to be trained too. In this regard, I think the onus lies with the state government, police department, judicial system, as well as the medical fraternity to implement the act in letter and spirit, and to respond to these cases with urgency, empathy, as well as compassion. Secondly, understand the integrities and help in a proper scientific collection of various evidences while examining the child who has undergone a sexual abuse. I think this was the time to amend the POSCO Act. According to a report of the National Crime Bureau from 2016, indicates an increase in the number of the cases registered at the SEC Act from 44.47% to 179%. So again, there was a rise in POSCO cases by nearly 45% in the last 3 to 4 years. So overall, the crime against children has increased steadily over 6 times in the last decade. I think this was a time to amend the law, and it was very well said by our Union Minister Smriti Irani, who introduced a bill in the Rajya Sabha on 18th of July 2019 to amend the protection of the child from sexual offences POSCO Act, and to make it a truthful text from a toothless act that aims to make punishment more stringent and even include death penalties for offenders involved in sexual crime against minors. So the Honorable Minister speaks that the POSCO Act was amended, making online pornography and online sexual abuse of the children a penal offence. We now have national database of sexual offenders in our account. So recognizing the fact that justice delayed is justice denied, the government has set up monies as well as access to the justice by ensuring 1,023 fast-track courts that are set across the country in 1 year, so that the cases of the crime against the women and the children can be expedited and access to justice becomes a reality for our citizens. But the reality is, of the 1023 fast track courses that was set up, only 62 has already functional. There is a need to establish all the sanction code quickly, as 89 to 90% of the child sexual cases, they still awaits trial. And this is updated in 12th of August 2021. 5 states like Maharashtra, Madhya Pradesh, Uttar Pradesh, Haryana, and Delhi, they constitute around 51% of the POSO cases in India. So what were the amendments which were made in the POSO Act 2012 to 2019 and 20? There was a section 4 which deals with punishment for penetrative sexual assault. The punishment has increased, including the minimum punishment for penetrative sexual assault from 7 years to 10 years. And at the same time, if the child is below 16 years of age, the minimum punishment has been increased to 20 years. Other amendments includes some of the significant additions: mandatory police verification of the staff in schools and home caretakers, procedures to report sexual abuse material, which includes pornography, imparting an age-appropriate child education, among others. The Act has also removed the word communal or sectarial violence, which has been punished for a person who sexually abuses a child during the course of such violence. The word has been replaced with the violence during any natural calamity or in a similar situation, which is dealt with under Section 5 and Section 9, which counts to aggravated sexual assault. For crackdown on child pornography, the Act has also tightened the provision to counter child pornography. While the earlier Act has punishment for storing child pornography for commercial purpose, the amendments includes punishment for even possessing the pornographic material in any form involving a child. And this is under Section 14 and 15. So there's a zero tolerance to violence against children, periodic training to all the persons in coming in contact with the children. There's a child helpline services through toll-free number, that is 1098, and orientation programs has to be repeatedly taken for the police personnel as well as the forensic experts. The bill has now also introduced administrating or helping and has also included the administrating or helping and assisting in any hormone or any chemical substances to a child for the purpose of attaining early sexual maturity as an aggravated penetrative sexual assault. It has also made reporting of child sexual abuse offences mandatory. In case of failure to report, that person may face imprisonment for 6 months and or a fine under Section 19 and 21 of the POSO Act. The rule for other POSO rules 2020 lays down a detailed procedure regarding care of protection, including counseling and therapy of the victim of the child sexual abuse. And it has also, under Section 6 of the POSO rules, has provisions regarding providing medical aid and care to the victim of the child sexual abuse. But at the same time, there's also provision of special relief, which has been prescribed in the POSO rules 2020 for contingencies such as food, clothes, transport, and other essential needs of the child. One more.
Dr. Kush.
Welcome. Yes, sir. Yes, sir. Just last 2 minutes, sir.
Okay.
One of the welcome change in the POSO Act was the introduction of POSO e-box, which is an online method. It's an easy and direct reporting system for lodging a complaint of the child sexual abuse and POSO Act with the National Commission for Protection of Child Rights, and the identity of the complainant is kept confidential. These are the notable changes which is there in the POSO Act. So what is the role of the doctors in the POSO? They have a dual role. They are in position to detect that the child has been abused, and at the same time, they offer a first point of reference in confirming that the child has indeed been a victim of sexual abuse. How you can prevent? The most important thing is teaching the child about the personal space as well as privacy by the age of 3 years, teaching the child the concept of bouquet, not bouquet teaching. So basically, you have to talk to your child. So parent-child communication can reduce the instances of child sexual abuse, be involved in the child's life, and encourage children to speak up. The most important thing is strengthening community-level child protection system, which is the key to prevention of such abuses. So it's a preventable health problem that has been allowed to spread unabated due to the scientific and the social neglect. There are silver lining. According to the study, status of POSO Act in India in March 2021, conducted by the Kailash Satyarthi Children Foundation, the rising public consciousness and media attention, along with the corrective measures taken by the judiciary in the last few years, is proof that the right of children to live with dignity is finally getting the attention it requires. So much has to be laid because this is a major traumatic problem, but we collectively, we all have a responsibility to break the impenetrable wall of silence around the child sexual abuse. when you feel caught in the web of childhood abuse, find words to describe it. Write them, say them, express them in safe place, safe people. Thank you. Thank you very much.
Thank you, Dr. Kush Zunzunwala, for excellent presentation. Prevention is very important to stop child sexual abuse. Getting the right support when child has been abused is so important. But after sexual abuse, child and their families often struggle to navigate health and social care, therapeutic services, and often criminal justice process by themselves. Thanks again, Dr. Kush Zunzunwala.
Thank you. Thank you, sir.
Yeah, Dr. Kush.
Yes, sir.
Sorry to interrupt you because we had to face with the time.
Yes, sir. Yes, sir.
Kindly accept our memento and bouquet, e-bouquet and e-memento.
Thanks a lot, sir.
Because of this. So thank you very much. We'll move on to the next topic. So the speaker is speaking from the same place.
So now I would like to invite Dr. Vijay Upadhyay, sir, practicing as family physician, Career 2002-2003, and he is a chaired member of many important committees, Office of IMA, CGP, and he's working. Hello. The slide has been gone.
Okay, okay. I will just do that. Can you see the slide now?
Yes, yes, sir. Yes, sir. So, once again, I would like to invite Dr. Vijay Upadhyay, sir. And now the topic is for sexual medicine from the perspective of general practitioner. Vijay Upadhyay, sir. Who do you?
यहाँ से ये पर ये करना होगा मैं करूँगा क्या जरा स्लाइड कैसे आएगा
So, Vijay, sir.
Just a minute.
कौन सी और पीछे जाना है thank you, Chairperson, sir, Dr. Raj Singh. Myself, Dr. Vijay Upadhyay, as Dr. Sawant has already said, this is my photo as I looked 15 years ago. First slide, please. And my topic is sexual health, a family physician's perspective. I am thankful to CSEPI organizing team, and especially Dr. Sanjay Deshpande, for telling me, or to be more precise, for forcing me to take this lecture. Actually, this is a survey. A survey I have taken. I have got something about sexology in my mind, but I wanted to take opinion of my colleagues in general practice, what they think about sexology, what they think about sexual medicine as a specialty. So we chose 100 doctors. We gave questions to 100 doctors. out of which we got reply from 36 doctors, a simple 5-set question. Out of these 36 doctors, 28 are MBBS, 8 non-MBBS, and 27 gender-wise male general practitioner, 9 female general practitioner. And all had practice experience ranging from 5 to 35 years. A simple set of 5 questions were given. This is just to gauge the mood of the general practitioner. This study was carried out in Nagpur urban area. The first question, very simple, history taking. Whenever a doctor or general practitioner sees the patient, he goes for history taking. Patient is suffering from blood pressure, diabetes, thyroid, other things. And I ask the question, whether during history taking, do you ask question regarding sexual problem? And the answer was 31%. And I was surprised, frankly speaking, to be honest. When I was framing this question, I had this impression that I will get this figure of 30% only as 10%. That was my perception, what I thought, or perhaps what I might have been doing, that asking lesser about the sexual medicine. But the good part is that 31% of the doctors who responded, they said that they asked questions regarding sexual problems. The reason maybe why this 10% in my mind has increased to 31% total, maybe the increase in awareness amongst general practitioners also about sexual medicine might have increased since last few years. And some credit goes to Dr. Sanjay Deshpande, who has been taking lectures regularly in Nagpur, writing in media, and also organizations like CSEPI who are increasing awareness among doctors also. And I would like to tell you, this 1/3 of the figure is very constant throughout the survey. The questions were sent to 100 doctors, we received response from 38 doctors. Out of the total doctor surveyed, approximately 1/3 took sexual history. And here also you can get this figure when this question was put. At times, there is inhibition amongst the patient. So they may not give the clue directly. So ask the doctors, do you come across situation in which patient or spouse gives clue of sexual problem indirectly? Again, 33% said yes and 67% no. It very clearly means that the patient may not be open enough to tell his or her general practitioner directly, but there can be clue given indirectly, and it's the job of the family physician to pick up that clue and explore the things in detail. I'll give a simple example. If a male comes to your OPD and he looks at your female attendant or nurse with some inhibition, or he wants to tell you something but is inhibited to the presence of the lady nurse, it very clearly means that he or she wants to, especially comes to general, he wants to tell you something, but which he cannot tell due to the presence of a female attendant or female nurse. That is the point from where you can get the clue. Or spouse, when you completed the taking history of the patient, the wife may tell sometime and tell her husband, in हिंदी में जैसे कहते हैं आपको और कुछ पूछना तो डॉक्टर को पूछ लीजिए. Do you want something more to ask the doctor? At that time, the general practitioner should be able to pick up the clue. There is some problem which the patient is inhibited, but he want to express it. Then it becomes the responsibility of the general practitioner to get into details and get this. So this 67% no and 33% yes, this should change if the general practitioners are more attentive. Now this slide is very important. Again, I have said this 1/3 is constant in every slide. Actually, this is survey of 38 doctors. This 3%, actually this 3% is coming in percentage, but out of 38 doctors I have surveyed, only one doctor in Nagpur urban area, he said that he always treats the patient of sexual problem. Only one doctor. So percentage wise, it has come to 3%. 33% patients, they said that they occasionally treat the patient. Now, this 33% correlates so well with the 31% who take sexual history. And 64% of the doctors say that they never treat the patient of sexual problem. It means that the 31% of the doctor who have included questions in their history taking about the sexual problem, those 33 doctors, percentage of doctors are treating the patients of sexual problem, but that too occasionally. 60% never, they have declined, and 3% only they are treating. So unfortunately, we general practitioners have failed in the exam of sexual medicine. It is unfortunate part, because for medical university, 50% is a passing mark. but we are stuck at 33% or one third. But why we have failed and how we can pass will come to in the next few slides. Now look at this slide. This is encouraging. Though we have failed, we are treating only one third of the patient, occasionally treating. We are taking history only amongst the 31% of the patient, but 58% of the general practitioners want that patients of sexual problems should be treated by the general practitioner. This is encouraging. It means we general practitioners want to pass the exam of the sexual medicine, but we are at present stuck at 30% or around 30%. And what is the reason? Reason will be explained in the next slide. This is the most important slide which I consider. Do you think GPs are inadequately trained, informed about sexual problem? 97%. 97% means out of the 38 respondents, just one doctor said that he finds that he is adequately trained. The remaining 37% said that they are inadequately trained. It very clearly means that we are ready to treat more patients if we are adequately trained. यानी कहीं ना कहीं हमें पढ़ाया कम जाता है. We are not taught well. That's why we are failing in the exam of sexual medicine. This thing has to be changed. It means that a general practitioner or family physician are interested if they are adequately informed or trained. In conclusion, I would like to tell. The first thing is that this is appeal to the CSEPI. We should have the better training program for general practitioners. I have seen it that there are certificate courses given by IMS CGP also. Even CSEPI is running certificate courses, but GPs are not encouraged to take that. What I want, the sexual medicine as a specialty should be established with the general practitioner. They should be given proper training through CME, through study material, or through programs like this. Because I have seen that there is a lot of increased awareness in Nagpur. In Nagpur, there were 2 conferences were held by Dr. Sanjay Deshpande. I saw there's some gross change in the approach of the general practitioner after attending those conferences. So I want to appeal to CCPI or IMA or general practitioner body IMA to involve general practitioner to make them aware of the importance of the sexual medicine as a specialty. Because I have seen many general practitioners, they do certificate courses in diabetes. They are well trained in treating the patient of blood pressure. They are treating patients of thyroid and others so well. Same thing can happen if they are taught properly, as our surveys already said. We means myself and Dr. Deshpande, we have planned program for general practitioner IMA. I am in charge of the IMA CGP body. So we are planning a series of CME for this. So more the general practitioner is trained, more is informed, more he is taught about the importance of sexual medicine in general practice, it will be firm in his mind that as a specialty, sexual medicine is as important as other things. And it will help the patients a lot. Problem is that it is no big secret. As Dr. Ved Prakash Mishra, Chief Guest, has yesterday said, the maximum quackery is seen in the field of sexual medicine, rampant. And if the general practitioner is trained properly, he will be able to stop this a lot. He can help his practitioner to go to rational and scientific doctor. For example, he is able to analyze in his clinic by history taking, proper analysis of the patient, proper investigation. He can come to the conclusion whether the patient will be treated in his clinic, it's well and okay. Or if the patient is some specialist referral, it's a general practitioner who will decide whom the patient should be referred to. Whether the patient should be referred to andrologist, urologist, gynecologist, psychologist, or counselor, or some practicing as pair sexology or Dr. Sanjay Deshpande. If this thing is done at the general practitioner level, it will help the patients a lot and will give a lot of importance to the sexual medicine as a specialty, which is at present being neglected a lot, because we have seen that just 1/3% of the doctors are aware of the importance of this medicine. So this is my appeal. This is my appeal to all the doctors like you, because you are a trained organization of professionals of competent people, and along with the bodies like IMA or CGP or general practitioners, these 2 bodies should come together and train the doctors a lot. And I'm sure after 5 years, if I take this survey, the general practitioner will pass with distinction. Now, since they are stuck at 30%. And I'd like to quote, I'm ending this presentation. मोदी जी जो हमेशा कहते हैं पढ़ेगा इंडिया तो बढ़ेगा इंडिया, पढ़ेगा जनरल प्रैक्टिशनर, पढ़ेगा फैमिली फिजिशियन तो बढ़ेगा सेक्सोलॉजी. And I'm thankful to the CSEPI, Dr. Deshpande and chairperson for allowing me this my presentation. Thanks a lot.
So thank you very much, sir, for your valuable. Hello, are you getting?
I can listen, Raj. I can listen.
Hello, Ankur, yes.
Yes, yes.
Hello.
Dr. Sawant, you can go ahead. We are listening.
Hello. Yeah, we can hear you, Dr.
Raj.
So thank you, Dr. Upadhyay, for giving excellent feedback to us that what is sexual medicine in the perspective of from the perspective of a general practitioner. And in fact, this is very important. And let me tell you, my fellow colleagues in CSEPI also, that we should promote more and more general practitioners so that if they are trained, they can definitely increase the paradigm of sexual medicine. And then more and more people, what yesterday's our chief guest was telling, that sexual medicine is most commonly practiced by quacks. So if general practitioners are enriched, or they are enriched with the knowledge of sexual medicine, at least common people, poor people, illiterate people were free from the clutches of these quacks. So thank you very much, Dr. Upadhyay, my very close friend from 1982. So we offer you flowers and the memento. Kindly accept it, though he is just beside me, but please accept that we are physically here, both of us.
And thanks, Dr. Deshpande. I'm in the war room of CSEPI.
Yes.
Thanks a lot.
Thank you. Thank you. So thank you, chairpersons. We also thank you, both the chairpersons, Dr. Ankur Agrawal and Dr. Raj Singh Sawant. Thank you very much. Our next session is Yoga for Sexual Happiness and Pleasure, New Horizons in Erectile and Endothelial Dysfunction, and Men's Health Care, Caressing in Relationship and Survival. So I invite Dr. Santosh Khadtare and Dr. Suresh Rudrappa to chair this session. Are the chairpersons here? Dr. Suresh Rudrappa, are you here? Dr. Rudrappa, can you hear me? My voice is clear, Dr. Anand Jawar? Dr. Jawar?
Yeah, your voice is very clear.
Voice is coming.
Okay. But I think Dr. Suresh Rudrappa has not joined. So I request Dr. Ajit, are you there?
Dr. Sudhakar is online.
Yes, I am online.
Dr. Ajit Chakravarti and Dr. Sudhakar Babu. Dr. Arvind.
Yes, sir. Yes, sir. Yes, sir. Dr. Sudhakar Babu. Yes,
okay.
Sir.
Sir, I request you to chair this session.
Sir.
Okay. There are three topics.
Yeah.
And I request Dr. Anand Jawar also to chair the session.
Thank you.
Okay, sir.
I thank the organizers, Dr. Sanjay Deshpande especially, for giving me this opportunity. So it's a rarest of the rare topics which are included in the conference. Unusually, everything is. We are very happy to be associated with this conference. The next topic is Yoga for Sexual Happiness and Pleasure, And that will be presented by none other than Dr. Sudhakar Patkar.
Sir, before that, kindly accept the floral welcome from the organizers.
Thank you, sir. Thank you, sir.
Dr. Sudhakar
Thank you,
Babu
sir.
and Dr. Anand Jawar. Yeah.
So
You
nice
can
of you.
proceed.
Thanks a lot.
Thank you, sir. Very nice, sir. Thank you.
Thank you.
You can proceed.
Now, Dr. Sudhakar, the podium is yours. Please take over.
Okay,
Yeah,
both
I'm here.
the Sudhakars are there. Both
Yeah.
the Sudhakars.
Yes, sir. Yes.
Hello, good morning, everybody. Can I start?
Yeah,
Yes,
yeah,
sir. Yes,
sure.
It's a good morning, everybody. And I am really very much happy that Dr. Deshpande gave me a chance to speak in such an online conference. And it's a unique experience also. Now I'm going to speak on this yoga for sexual health and pleasure.
Petkar sir.
Yeah, बोला सर.
मी आता माझा स्टॉप शेअर करतोय, तुम्ही स्क्रीन शेअर करू शकता.
बरं, ठीक आहे. I'm going to speak on this yoga for sexual pleasure and happiness. This sexual pleasure and happiness, it's a very difficult topic, actually speaking, to speak in front of you. Tulip. Hey, Tulip. 1 minute, sir. Where am I? 1 minute, sir. Slide.
हा शेअर झालाय सर.
झालंय ना?
दिसतंय.
ठीक आहे. I'm going to speak on sexual health and yoga and how it is helpful for the pleasure of a human body. This is what is the definition of the sexual health. The sexual health, the World Health Organization, who defines sexual health as a state of physical, mental, and social well-being related with the sexuality. And definition of the sexual disorders. What are the sexual disorders? The sexual disorder or sexual dysfunction or sexual malfunction is defined as a difficulty experienced by an individual or a couple during any stage of a normal sexual activity, including physical pleasure, desire, performance, arousal, or orgasm. Sexual disorders are classified into 4 categories. Sexual desire disorder, that is the loss of libido; arousal disorder, that is frigidity in female; and ED, erectile dysfunction and premature ejaculation and impotency in male. Orgasm disorder, that is orgasm disorder, are delays or absence of orgasm following normal sexual excitement. Pain disorder, it is a very common in female. It is known as dyspareunia or vaginismus. In male sexual disorder, it is estimated that 1 in every 10 men has a problem related to having a sex. Loss of libido, impotency, erectile dysfunction, premature ejaculation, anorgasm, retrograde ejaculation. In female, the female sexual disorders are lack of sexual desire, inability to become aroused, lack of orgasm, painful intercourse, and depression. Now we come to the how it will be helpful to reduce all this, that is through the yoga. Now you must know what is meant by yoga. Yoga is having 2 parts, Ashtanga Yoga, external yoga and internal yoga. Now, what is external yoga? That is abstention, that is also called as yam, that is non-violence, observation of the truth, non-stealing, self-abstinence or celibacy, non-greedy nature. Now, observation, that is also called as a niyamas, that is cleanliness, self-contentment, self-control, study, and devotion. Then comes the yogic postures, that is very important for the happiness of the body and happiness of the sex. Yogic posture, that is yogasanas, yogic breathing exercises, that is pranayam. Now, internal yoga. What is internal yoga? That is concentration, that is called as a pratyahara. Then fixed attention, that is dharana. Then meditation, also called as a dhyan, and absolute contemplation, that is samadhi. Now we have to switch on what type of the yoga we have to do. Before that, we have to start some warm-up exercises. Benefit of this warming up exercises, it prepares the body for yogic exercises. The muscles and the joints of the legs, trunk, and arm are relaxed. Cardiovascular circulation and cardiac efficiency is increased. Systems of the body get energy through the increased cardiac circulation. For that purpose, after doing the warming up exercise, you have to go to the salute to the sun, that is called as a Surya Namaskar. What is Surya Namaskar? That is having 12 poses. Now, the first position is prayer pose. Then comes the second position, that is raised arm pose. After that, you have to do the forward bend posture, that is third position. Then comes the equestrian pose, that is fourth pose. Then come mountain pose, or also called as a Parvatasana, that is the fifth position in the Surya Namaskar. Then salutation of the 8 limbs, that is also called as Ashtanga Namaskar. After that, you have to do the Cobra pose, or which is also called as a Bhujangasana. It is the 7th position in the Surya Namaskar. Then comes the mountain pose, that is Parvatasana, position 8. Then comes the 9th position, that is equestrian pose, Ashwa Sanchalan. After that comes the position, 10th position, that is forward bend posture, or Pad Hastasana, or also called as a Hasta Padasana. Then comes the 11th position, that is a raised arm pose, that is Hasta Uttanasana. And after that, this comes the prayer pose, that is Pranamasana. By that way, the Surya Namaskar constitutes 12 position, and if you do the 12 position regularly for 12 times, you will get a very beneficial effect for the sexual pleasure. This is all are the positions of the variety of the Surya Namaskar. This is a yogic pose, that is forward bend posture, Hasta Padasana. After that comes, you have to do it regularly. That is very important. Then backstretch posture, or which is also called as a Paschim Tanasana, which gives us a body fittingness. Then comes half twist posture, that is Ardha Machandrasana. Then moon pose, that is called as a Shashankasana. After that, gas-free posture, that is called as a Pavan Muktasana. It is energizer to the digestive, excretory, and reproductive system. It is a tone developer of the pelvic floor muscles, which are helpful for the increasing the sexual pleasure. Then reliever of the complaints of the anal region. Then a thunderbolt pose, or also called as a Vajrasana. After that, a supine ankle posture, that is Supta Vajrasana. This Supta Vajrasana, it is better for increasing sexual stamina, better for increasing hardness of the penis, better for increasing pelvic floor muscle tone. Then comes the Cobra posture, which is also called as a Bhujangasana. After that comes the locust pose, Shalbhasana. Then boat pose, which is also called as Naukasana. Then this is bow pose, or also called as Dhanurasana. Stand on shoulder position, that is the Sarvangasana. Then pro posture, which is also called as a Halasana. Stand on head posture, that is a Shirshasana. This is very important for the maintaining of the healthy body. Then comes the yogic breathing exercises. What is this yogic breathing exercises? That is pranayam. It is generally it is includes deep, controlled. These are the very important word: controlled and complete inhalation, breath holding, and slow, complete, and controlled exhalation. This is first comes the nasal cleansing exercise, which is also called as Nasa Marga Shuddhi. It clears the pathway of the respiratory tract, improving the vital capacity of the lungs, and they are very important to control the corona also. It also fights, this pranayama also fights the corona, which is very much helpful. Then alternate nasal breathing, that is called as Anulom Vilom. That means you have to take the breath from one nostril, then stop for few seconds, and then give out from the another nostril, that is Anulom Vilom, and then come take from the one nostril, then stop for some time, and then from the right nostril, like that way. You have to do it. Then forehead brightener, which is also called as a Kapalbhati. Victory yogic breathing exercise, that is Ujjayi Pranayam, easy to follow, blessing to common man. This is Below's yogic breathing exercise, also called as a Bhastrika Pranayam. It is a preventive measure for various respiratory disorder, multiple benefits. B, humming yogic breathing exercise, that is also called as a Brahmari. It is a mood elevator, mental stress and strain remover. Best way to get rest, peace and mental stability to the mind. Then we have to see the yogic gesture. What is the yogic gesture? That is a Mulabandha. It is a contraction of the anal sphincters. Inhale deeply and relax the pelvic floor, and exhale and constrict the anal sphincters. Then comes the Vajrayoli Mudra. This is very important to correct the ED, erectile dysfunction and premature ejaculation. Sit in Padmasana, that is in lotus position, or any other comfortable position. Keep hands on knees. Close the eyes. Relax and breathe through the nose. Take deep inhalation. Hold the breath. Try to draw the sexual organs upward by pulling and tensing the lower abdomen and concentrating the pelvic floor muscles. These contractions are similar to the urge of the passing urine, but try to hold on for some time. Then exhale and relax simultaneously. Repeat it for at least 20 times, 10 to 20 times. It is very useful for the premature ejaculation. Then comes the Ashwini Mudra. Ashwini Mudra, sit in Padmasana or any comfortable asana. Relax the body. Close the eyes. Inhale deeply. Hold the breath. Then bend the head forward and fix the chin in jugular notch. That is called as a Jalandhar Bandh or chin lock position. Then contract and relax the sphincter. Repeat it for 5 to 10 times. These mudras strengthen the muscle tone of anterior and posterior part of the pubococcygeus muscles. Do it 5 to 10 times. Repeat in the morning and evening, and do it for at least 6 to 8 weeks to get the result. It is very useful again for the premature ejaculation. Then meditation. Shavasana, corpse posture. Vipassana means to observe the thing as it is. What is the result of all this? These studies are very encouraging result. It decreases the various sexual problems. For example, erectile dysfunction, premature ejaculation, retarded ejaculation, impotency, etc. Increases sexual desire and increase the duration of the coitus. What the man requires? Man requires the happiness, healthy body. It comes through the yoga. Yoga brings the physical fitness and stabilize the mind by increasing the muscular tone, by mental health, organic vigor. Science stimulates the gonad and genitals, tune up the genital systems, improves the nervous system, tune up the endocrine system, increase the sexual efficiency. What is the conclusion of all this? Yoga is a free of cost medicine. This is very important. It is a free of cost medicine with the effect, but without having any side effect, to keep your body and mind fit and stable. It prevents and to cure the various sexual disorders. But for that, determination of the mind to perform the yoga regularly is very important. For healthy, happy sexual life, yoga should be one's lifestyle. What message you are going to take when you are going back to the home? Don't say that have no time. Spare some time, at least 1 hour, to avoid all these steps of the disorders and to keep your body fit and fine and your mind stable and to have a sexual pleasure and healthy body. So long as the lips shall kiss and eyes shall see, so long life is there. Avoid sexual disorder and enjoy the healthy, happy sex life with yoga as a lifestyle. Thank you very much. Thanks a lot for organizer for giving me a chance to speak in front of you. This is the very important thing, but for that purpose, you have to do it very regularly. Very regularly. It should be a lifestyle. It should be a part of your life. As you are eating, as you are sleeping daily, as you are going to office your daily, like that way, you have to do the exercise. You have to do the yoga for every day for the health and happiness. If you want the happiness, if you want the healthy yoga, sex, then you have to do all these things which I have shown you. Thank you. Thanks a lot.
Thank you, Dr. Petkar. Sir, तुम्ही स्क्रीन शेअर स्टॉप करा म्हणजे मग मी इकडून स्क्रीन शेअर करतो.
हो.
Thank you, sir. Dr. Sudhakar, sir. You have given wonderfully elucidation of the yoga, the union of body and mind, and it is not expired. It is no drug beyond expiry. So whereas yoga is there with you as long as we do it perfectly and regularly. That's what the carry home message you gave. Thank you very much.
Sir, Dr. Sudhakar Petkar kindly accept our e-flowers and e-memento.
Thank you, sir. Thanks a lot.
Thank you for
Thank
the
you.
guidance. And I suggest you
Yes,
that you should take a 2 days workshop on all this yoga,
Yeah.
so that all the sexologists also learn how to do yoga and enhance their sexual activities.
Definitely, sir. Your suggestion is accepted.
Yes, yes.
And
Call us at Ahmednagar.
not in Ahmednagar, Shirdi.
Sangamner.
Okay, Shirdi, that will be the great.
Sangamner. Very nicely.
People will have the darshan of our Sai Baba also.
Yes, definitely, sir.
Okay, thank you.
I will arrange it.
So now I request my co-chairperson, Dr. Anand, to invite the next speaker and throw light on his adventures. Sir, Dr. Anand, sir, please unmute, sir. Dr. Anand, sir. Anand, sir, okay. Sir, please unmute. Please unmute.
Yeah, thanks, Dr. Sudhakar Babu.
Thank you, sir. Welcome.
I am inviting Professor Deepani to speak on new horizons in erectile and endothelial dysfunction. Dr. Deepak K. Jumani doesn't require an introduction. He is an authority in sexology. He is practicing in Bombay, and he is faculty in Indian Medical Association also. I am not wasting much time on his introduction. I am inviting Professor Deepak K. Jumani. Floor is yours, Dr. Jumani.
Dr. Deepak.
Thank you very much. Thank you very much, Dr. Jawar, Dr. Sanjay, Dr. Sudhakar Babu.
I'm stopping this my screen share so that you can start sharing.
Are you able to see my screen?
Yes, yes.
Yeah,
Yes, sir.
I
Yes,
can
sir.
see it. Yeah.
Yes, sir.
Okay. Endothelium, we all are aware, is the innermost monolayer of our vascular system, right from capillaries to the heart and also of the lymphatic systems. The functions of endothelium are all most important functions which prevent most of the diseases of life. These are maintaining the vasomotor tone, homeostasis, coagulation, preventing thrombosis, preventing atherosclerosis. Any dysfunction of this endothelium is a hallmark of all human diseases. And we also know penile erection, which is a neurovascular process, and it depends upon the blood flow, which is again dependent on the endothelium and the penile vasculature, and of course the vascular tone of the penile vasculature and the muscles. In this next 20 minutes, I'm going to give you some potent nuggets of wisdom as to the understanding of what happens to the endothelium in the various diseases, be it aging, be it diabetes, be it hyperhomocystinemia, be it obesity, be it dyslipidemia, and how this can be reversed. Is it a myth or is it a reality that endothelium dysfunctions can be corrected or can be reversed? And if so, this is a mechanism which we have in place, and if we work on it, this will be soon a reality. With pranams to God and thanks to my teacher, Dr. O.P. Kapoor, Prakash Kothari, and Sashank Joshi, I beseech them to bless me always. I have no conflict of interest. This is very important for us to understand that the normal endothelium produces endothelial nitric oxide synthetase and nitric oxide, which is the main chemical signaling molecule or the chemical currency of the cell to initiate the whole erectogenic mechanisms. What happens in diabetes? Friends, hyperglycemia increases the advanced glycated end products, and there is definitely oxidative stress, reduces the enos and nitric oxide, leads to cavernous endothelial dysfunction, there are functional alteration in the endothelial and smooth muscles relaxation of the penis and ultimately leads to erectile dysfunctions. So enough evidence to say that erectile dysfunction and endothelial dysfunction in diabetes, there is definitely a link. And when we give SGLT2 inhibitors to our patients, we have seen the improvement in the cardiomyocyte muscles of the in the cardiorenal symptom. So endothelial dysfunction has been corrected in patients with diabetes after taking SGLT2 inhibitors. Metformin has also been now shown to work on the endothelium, and it can be given to patients who are not even diabetics but as an adjunct to the treatment of erectile dysfunction in men with metabolic syndrome. Chronic treatment with tadalafil improves the endothelial function in men and with increased cardiovascular risk. It is proven beyond doubt. What are the markers of endothelial dysfunction? We have carotid intima, media thickness, flow mediated dilation, arterial stiffness, ankle breakage, and there are so many other biomarkers of this. Enough evidence to prove that endothelium derived nitric oxide is an anti-atherosclerotic molecule and also anti-thrombotic molecule. When we look at the risk factors of cardiovascular disease and erectile dysfunction, aging, hypertension, diabetes, atherosclerosis, they all are because of endothelial dysfunction. So there is a unifying alteration occurring in the pathogenesis of cardiovascular disease, aging and erectile. So when we look at the new horizons, we find whatever are the risk factors of cardiovascular diseases, which is the common cause of global mortality, are also responsible for erectile dysfunction. So the progression of erectile dysfunction can be of prognostic value of cardiovascular diseases. And we have now known that erectile dysfunction is nothing but subclinical cardiovascular disease. So what are the lessons we have learned? We have learned that endothelial dysfunction is the precursor of most of the cardiovascular risk factors and disease. Erectile dysfunction is the earliest marker of endothelial dysfunction. Erectile dysfunction is most common in type 2 diabetes. In vitro, endothelial progenitor cells modification and injection of these cells into coronary arteries is the way forward which they have tried. So the flaccid truth is erectile dysfunction because of endothelial dysfunction also produces emotional dysfunction. But the bitter truth is that these manifestations of aging and age-related complications are nothing but because of endothelial dysfunction. So when we age, we are going to live. So we all are living, we all are aging. Is life which is aging is a disease? No. So when we look at the etiology of whatever diseases we have, erectile dysfunction, the pathophysiological outcomes are excess collagen deposition, endothelial dysfunctions, cavernous fibrosis, and arterial insufficiency. When we look at aging, there are inflammatory markers, antioxidative system tries to take in, and endothelial nitric oxide synthetase reduces, uncoupling of it happens, and there is production of reactive oxygen species, which results in inactivation of the nitric oxide, results in endothelial dysfunction, and produces manifestation as vasomotor smooth muscle cell growth, inflammation, remodeling, apoptosis, and all these are nothing but vascular complications. So aging. Now, is we are aging? Is aging itself is a disease? Then life is solved. No, it's not true. The main feature of aging, which we are all going through, is nothing but chronic progressive increase in the pro-inflammatory status, which we are all in now. And this is controlled by the network of cellular and molecular defense mechanism from our body. Immunosenescence, which is an adaptive net result of our body's defense mechanism, which itself is a dynamic process. So what is nothing? I call aging as inflammaging because it gives rise to all these manifestations, and this is due to various signaling pathways which get activated, ultimately produce inflammation. And friends, diabetes is an inflammaging disease. When we look at the endothelium, when it gets dysfunctions because of various reasons, there is inflammation and fibrosis, there is occlusion, vasoreactivity, atherosclerosis, thrombosis. So many myriad of potential consequences of endothelial dysfunctions have been seen, which manifest as various diseases. Even COVID-19 is an endothelial disease too. So when you look at diabetes, there is hyperglycemia. High inflammatory marker of TNF alpha leads to PKC activation, reduces the endothelial nitric oxide function, produces reactive oxygen species, activates the Rho A activation, which increases the permeability of the endothelium, allows the things to go past the endothelium, produces endothelial dysfunction. Also, there is decrease in the L-arginine and increase in the arginase enzyme, which reduces vascular relaxation and produces endothelial dysfunctions. Even in the red blood cells, patients with type 2 diabetes, they have found that there is arginase activity and arginase 1 protein expression is elevated. So if this could be blocked, definitely the endothelial dysfunction can be reversed. We know what happens during heart attacks, etc. The atherosclerotic plaque formation are initiated through LDL, which is again in the endothelium, increased ROS, decreased L-arginine and BH4. All these happen because of the endothelium, which is not functioning well. Even endothelial dysfunction and angiogenesis is impaired in aging, in atherothrombosis, which is there in hyperhomocystinemia, even in hypertension. So we have seen that endothelial dysfunction is there in all these sort of metabolic disorders which we see in our day-to-day life. Now, what are the causes of erectile dysfunction? We know the common is aging, smoking, hyperhomocystinemia, hyperlipidemia, hypertension, diabetes, and prostate surgery because of the nerve injuries. So we need to look at newer horizons for managing erectile dysfunction and endothelial dysfunction. So what do we do? Do we have something in our life today? Yes, we have something called as pigment epithelium derived factor. Now, what is this pigment epithelium derived factor? It's a secreted glycoprotein that is widely expressed by multiple organs. Numerous functional contributions have been attributed to PEDF, which are anti-angiogenic, anti-tumor, anti-inflammatory, and have neurotropic properties. But these worked only in proliferating cells. It does not work on the resting endothelial cell. And in fact, whatever the stem cells do, differentiations or making different type of, these are nothing but determinant of the stem cells. So we know that endothelial cells will produce, progenitor cells will produce endothelial cells, mesenchymal cells will produce. All these things can be possible with PEDF. PEDF regulates the proliferation and differentiation of multiple tissue-specific stem cells. It's a multifaceted neurotropic factor. Now, one landmark study in the field of diabetes, which will cure erectile dysfunction in diabetics, is this one. So there is something elevation of this pigment which induces diabetic patients erectile dysfunctions. So they found that levels of PEDF were significantly upregulated in individuals with obesity and diabetes. And when this pigment is elevated or upregulated, it produces various angiogenesis inhibition, protease inhibition, and also apoptosis. So plasma levels of PEDF were higher in diabetics compared to non-diabetics and other diabetics without erectile dysfunction. So it is focusing only on diabetics with erectile dysfunction. The plasma levels of PEDF were high, which resulted in all these things. So what PEDF used to do? Overexpression of this PEDF increased the intracavernous pressure and increased the endothelial nitric oxide phosphorylation. So there was less nitric oxide synthetase, less nitric oxide. When they gave PEDF neutralizing antibody and knockout of PEDF, that increased the intracavernous pressure and endothelial nitric oxide. And through various mechanisms, which is HSP90 beta on the cell surface of the endothelium, when they were blocked, and this resulted in down regulating of endothelial nitric oxide phosphorylation and also produced good erections. This was studied for 8 weeks in rats. So they had, when they put the antibodies of PEDF, they found that the max ICP mean arterial pressure increased in both the patients in both the types of rats in 8 weeks and also in 12 weeks time. So the conclusion of this beautiful trial was, which I was also a part of it, these results indicate that elevated PEDF levels contribute to impaired erectile function by suppressing HSP90 beta mediated endothelial nitric oxide phosphorylation. And the PEDF antibody and knockout ameliorated the intracavernous pressure and enos phosphorylation. So mechanistically, this was possible. So the lessons learned were PEDF antibody and PEDF blockade in diabetics with erectile dysfunctions can be restored. The endothelial dysfunctions can be restored and ED can be cured. We have seen PDE5 inhibitors. PDE5 inhibitors produce PGC1 alpha, which increases the antioxidant enzymes, particularly in the mitochondria in diabetic patients, in diabetic hearts, and increase the contractile function and reduces the cell death. So we know PD5 have become a therapeutic in heart disease, diabetes, and cancer. We know about empagliflozin. We have studied that is very good for erectile dysfunction. Metformin also we know improves the endothelial health. Recent direct studies showed that remission of type 2 diabetes, which was the primary target, was achieved in 12 months only with no diabetic anti-diabetic drug or patients who were put on plain diet, uh, which was the anti-diabetic diet. My friend Dr. Paresh Dandona gave testosterone replacement in type 2 diabetic patients with hypogonadism for 2 years, and in 1 year he showed the functional hypogonadism improved, related metabolic, vascular, diabetic, obesity parameters, everything was reduced, and there was a remission of diabetes. So remission of diabetes is not a myth. Again, Dean Ornish clearly said with intensive lifestyle changes, coronary artery diseases can be reversal, which is not a myth, but today a reality. Cleveland Clinic clearly said that it is no point in doing bypass or angioplasty, which is definitely curing him for some time, but that does not prevent atherosclerosis. That does not, halt the whole disease. So nutritional intervention, according to their research, showed that it didn't even halt the coronary artery disease, but even reverse the coronary artery. Look at this perfusion scan. The complete perfusion scan was pre-perfused. Such a huge plaque without stenting has been improved only with nutritional intervention. So lifestyle modification not only improves the inflammatory milieu which we are all in, insulin resistance, oxidative stress, and endothelial dysfunction, ultimately leads to improved well-being and reduced burden of sexual dysfunctions. Does it matter, or is it reversible? Yes, today it is reversible with statins, ACE inhibitors, antioxidants, L-arginine. Just with 4 weeks of therapy, L-arginine, they found improvement in the endothelial dysfunctions which they measured very beautifully. So coronary endothelial functions have been improved in patients who had dyslipidemia by giving statins. Oral administration of vitamin C has been shown to improve the brachial artery endothelial functions, which is another parameter for identifying endothelial dysfunction. A recent study demonstrated improved endothelial dependent dilatation in young dyslipiding patients with oral L-arginine for just 4 weeks, ACE inhibition with quinalalpril, and estrogen therapy in postmenopausal women also improved erectile or endothelial dysfunction. My teacher, Dr. R.D. Lele, published this report way back in 2007 in JAMA and JAPI. He said there are successful strategies for reversal of endothelial dysfunction. PPAR alpha and gamma agonists, which increase nitric oxide, vitamin E and vitamin C, supplementation of L-arginine and tetrahydrobiotin, and selective beta-1 adenoreceptor antagonist like mebivolol, suppression of angiotensin-mediated endothelial product by ACE inhibitors, inhibitors of ATR, cannabinoid receptor blockers, PKC inhibitors, nitric oxide donors, dietary supplements, EPA and DHA, physical exercise and control of all these things can reverse the endothelial dysfunction. So what is the future? Today we are in 2021. What is the future we have? So potentially the most exciting future direction relates to improvement of arterial endothelial function in children and young patients early in their atherogenic process, which intuitively it is at this early stage that arterial wall damage is most likely to be easily reversible. So we have this mechanism if this strategies to protect the endothelium early in life can be defined or are available and applied successfully, this may have an important public health benefits into the next millennium. So in future, we will see that endothelial dysfunctions can be reversed or can be improved considerably with whatever strategies we have just mentioned. So today, we look at the horizons of endothelial dysfunction and erectile dysfunction. Studies prove us that reversal of endothelial dysfunction is not a myth but a reality. My friends, please understand. So it's really nice to know that erectile dysfunction, if it is diagnosed earlier, especially in younger patients at the age of 30 who have a family history of metabolic syndrome, who are smokers, who are alcoholics, if you counsel them and if you treat their metabolic disorder optimally, this will be a blessing in disguise. Reversal of diabetes is not a myth. Lifestyle modification is a choice we have. It should be our first religion. L-arginine, PDF blockers, PD5 inhibitors, statin, antioxidants, all are available to us. We can use them and see that the endothelium gets better. So if we all do this, improve the endothelial dysfunction. Friends, trust me, erectile dysfunction is a correctile dysfunction. This is my book, Sex Has No Expiry Date. My last slide. Friends, endothelium is the brain of the vascular system, is the hallmark of inflammaging diseases which we all are seeing in our day-to-day life. Even some of us are suffering from it. Cardiovascular disease is the highest cause of mortality globally. Erectile dysfunction is subclinical cardiovascular disease, is the earliest marker of coronary artery disease, is the commonest complication of diabetes, and India is the diabetes capital of the world. Erectile dysfunction, we all are aware, is an endothelial dysfunction, and PEDF blockers, lifestyle modification, PD5 inhibitors, statins are a boons which we have, which we can use. Endothelial dysfunction is reversible, and this is not a myth. So if so, erectile dysfunction is a correctile dysfunction, and if so, sex has really no expiry date. Thank you all for your love. I'll be happy to answer any questions you all have. I hope I am in time.
Yes, yes, absolutely.
Thank you.
In time, Deepak. Exactly 20 minutes.
Yesterday also maintained similarly, sir. You have thrown light on the therapy of this erectile dysfunction beyond Avanafil.
Yes.
Next higher level. Thank you for it.
It is
We
curable
look forward.
today. It is
Yeah,
curable.
we'll-
In near future, we will see to it that our
Yes, sir.
patients don't suffer from this symptom. I will not call it a symptom. It is a disease which can be cured.
Yeah. So we will.
That is the best part of it, Dr. Deepak Jumani. So nice
you,
of
sir.
you.
Thank you, sir.
Dr. Jumani, kindly accept our e-flowers and e-memento.
Thank you very much, sir. Thank you
Yes,
for this
yes.
honor. Thank you very much.
Thank you. So we'll move on to the next session. Over to you,
Raj.
chairpersons.
Dr. Raj,
Yeah.
I am
And-
very happy to invite him. He did his MS MCH in urology and 3 times chairman service doctor, cell DMA, and 2 times co-chairman service doctor cell IMA. And in past 30 years, he has been doing this workshop and recipient of more than 100 national, international awards. So we are very delighted to have you, sir, here. Please, the podium is yours.
Yeah, I will add a few more lines.
Yeah. It's very brief.
Dr. Sood is very much associated with CSEPI since last more than 15 years.
Yes, sir. Yes, sir.
We can say he's pioneer of men's health in India, and he has many training activities, workshops and conferences on men's health also, and made most of our CSEPians also participant in that. So his work in men's health is very, very big work, great work. And in 2022, next year in August, is organizing a national conference, 38th National Conference of Sexology at New Delhi. Dr. Sood is Dean of this Ram Manohar Lohia Medical College also. So over to you, sir. Welcome.
Thank you very much. Thank you for your nice words. And can I share my screen also?
Yeah, I will stop my share. You can start.
Okay.
Yes, sir.
Okay. So this is the great occasion, and we are doing this conference in this difficult times, and very well organized. And congratulations to CSEPI and all the partner organizations. Now I'll come straight to my topic. That is the men's health, as has been mentioned by Dr. Deshpande already. That men's health is a new specialty. It is the back integration of all the specialties. We were subspecializing MBBS to specialty to super specialty and all. But now this is the time, as Dr. Deepak Jomani has also mentioned, that there are certain systems which are common, maybe endothelial system, inflammation, which is common in obesity, diabetes, erectile dysfunction, even in corona. So there are certain common things. So we are forced for back integrations, and therefore the Men's Health Committee, Standing Committee has been formed by IMA. Men's Health Society of India has been created, and now National Board of Examination has also is starting. In principle, they have agreed to start fellowship in the andrology and men's health. So coming to the basic issue of men's health, before we become the rich nation, because our economy is boosted, we are becoming the aging nation, and in aging there is feminization. Why feminization? Because the male is dying early, and in some states in India very early, like in Himachal Pradesh, maybe 8 to 9 years earlier than the women counterpart. And we need more attention for men's health, but this is the men's health which is not cared, and it is more and more neglected over last 200 years. In the last 2 millennium, men's health was very well taken care of, and all the testaments and other things, whatever is available, they were connected with the men's health. But in 200 years, we have lagged behind. And what is happening in nutshell, after the age of 80, we have to maintain female-male ratio 1:1, but it is becoming 10:1 in favor of women. There is no central programs. There is actually economic slowdown because of this. Loss of men means loss of economy in the population. GDP depreciation. And we need the men's health, sexual health needs, and therefore the experts and data and research. So what is men's health? It is the science which is catering to diseases specific to men, or cater to the diseases which are more common to men, and why the men is more suffering. This is very clear that right from inception, more and more stillbirths, more and more abortions are of male child. The genes are weaker. Corona is affecting 60 to 70% male and 30% female, and is the other infections, and also the parasitic infections or whatever, tuberculosis infections and all, and also smoking, substance abuse, everything is more in male, and therefore male is suffering. And what is happening in our, how we are caring for the men? What is happening? Women has irregular period, consult medicine. For pap smear, consult medicine, lead to look good, goes to cosmetologist or consult physician. Or there are so many other opportunities like childbirth or menarche, menopause related, or so many things. But for male, only one interaction is there. When he is unable to work, then he thinks that I should consult doctor. No other opportunity to interact with the medical system. Men is the loner. Men is less social. Men, street children are men. Vagabonds are men. So mostly, and therefore men is a loner, and mental health is also suffering. So questions of longevity, when we talk, uniformly all over the world, women outlive men. And same story I was telling in India, there are 8 states in India which are where the man is living less than female, even less than the average of a national average. And the most sufferer states are like Himachal Pradesh, where man is living 9 years shorter than female. And the immune response in women is involved and allows the plasticity, and immune system is stronger in women. It has been proven. The telomeres in chromosomes are longer in women, and they relate directly to the long life. And also the female sex hormones are protective from at least viruses like HIV and hepatitis viruses and many other. And similarly, women overall is resistant to disease, so less morbidity. And there are 3,000 genes on X chromosome and only 50 on Y. And most of the mutations which are transmitted are Y chromosome related. And ultimately, one day it is also quoted that, and it is an endangered sex, and a Y chromosome which is becoming shorter and shorter, one day may disappear. And we will become like those in animal kingdom where male's function is only reproduction, and otherwise even in some of the species, insects and all, the female eats away the men because it is useless. So we have to take care of men's health, and that is the need of understanding that most of the deaths because of CAD, CVA, cancer, COPD, or even infections, trauma, suicide, homicides, all cause deaths are also combinedly more in male than female. You see the last column, and the ratio is 1 is to 1.4. So overall burden, not at specific to any age, maybe younger age 0 to 14, 15 to 59, or more than 60. When we evaluate all ages, you can see that female in blue or red you can see, and men in blue, and men is having more problem at uniformly at all the stages in the continuum of our aging. And men is involved in dangerous occupations, wars, you all know. Men is susceptible to suicide, 3 times more suicidal deaths. Smoking is also more in male, both chewing and non-chewing tobacco. And also it is the only second to China. And population wise, you can understand that we are number 2 in the world in smoking, and also alcohol abuse is more in male compared to female. And now coming to infections, strangely, male and female bacterial infections are more in male. And then you come to parasitic in childhood and otherwise also, they are more in male. And now you come to tuberculosis. You will be surprised to know that tuberculosis burden is also more in male. And Corona, as I was mentioning, and because of the various problems, it has been proved now conclusively that it is more severe diseases in male, more deaths are in male, and recovery is not that good as in female. Long COVID is also more in male. So in Corona also, because of our genes, because of our hormones, and because of our immunity, because of the inflammatory reactions, we are more prone to the long-term effects of also male. And what happens? Diabetes is more, inflammatory disease is more, endothelial dysfunction is more, and black fungus, which was in news, and we studied in our Ram Manohar Lohia Hospital, All India Institute, and global studies are there. Mucormycosis is more in male, and black fungus was more in male, damaging effects were more in male. So cancer, diabetes, everything, whatever metabolic syndrome or the infections, every morbidity condition is more in male. And what is happening? What we are doing for male? We are not caring. There is no organized data. There was no dedicated scientific body. We are trying to create it through Men's Health Society of India, and also now in association with CSEPI, in association with Indian Medical Association, and I am now nominated by Delhi to National Medical Commission also, and I'm trying that like national board, we create this also there, and there is lack of fund. As a whole, the health funding in India is very small. In US also, the fraction which is given to male is very small, and there are many unaddressed questions which are not researched. So men's health ranked 36 even in the US for the health research funding in 2012 data, and a very small funding is there. And like if we compare, breast cancer gets more funding than prostate cancer, and ovarian cancer gets more funding than testicular cancer, and much more funding. And this is the question which is to be cared for men. And then it comes that who should practice men's health? How should expert integrate with the primary care providers in the men's health? And what should be the men's health center offer? So these all issues are there. We have now prepared one template clinics we have created, and there by spending 2 to 3 lakhs, you can boost your practice, and also you can become from general physician to the men's health expert or specialist. And there are modules and training programs are on. They are already formulated. In Delhi, we have conducted many training programs for the general practitioners through Delhi Medical Association. And now IMA recently has given us task to prepare the curriculum for men's health in the IMA college. So this all is going. Now you see the men's health is sitting in the center because it is the back integration, and he is coordinating with all the experts at the periphery. The patient will go to cardiologist, come back to general physician. Patient will go to diabetologist, come back. So it should not be the specialist oriented practice. It should be the general physician or oriented practice, and men's health expert is also the part of that. And we have to create this awareness. We have to create the IEC model, information, education and training, and communication, and also CAP model, that knowledge, attitude and practices. And in these training modules, these are at 3 levels. Module 1 is at the basic level for general physician. Those who are the maybe urologists, maybe cardiologists, maybe diabetologists, they will be at level 2, and then the final will be the module 3, as the person is exclusively doing men's health practice. 10 modules are already prepared. Their questionnaires are there, right from prostate health, sexual health, cancer, diabetes, hypertension, cardiac health, obesity, metabolic syndrome, mental health, infectious diseases also, and data management guideline. And with that only we will understand men's health and equip ourselves with the men's health tools, and also reform our facility. Existing facilities can be modified, and we will be associated for a social cause also, for uplifting our country's economy also, and preventing the feminization of the elderly population of our country. So there are strategies to continue it and establish point of interaction, early checkpoint. Even we can develop the packages for premarital counseling. Before marriage, they come, counsel, early checkups are there. At the time of admission, general admission in the hospital, Paras Hospital in Patna, I inaugurated, and there they segregate the men separately, and they give them questionnaires and all. At the time of parenthood also, another intervention point can be there, and there these all facilities should be health friendly. We have already created the guidelines which are available on net also, men's health guidelines, which are good for each and every specialty, and even the sexual health experts. And these are the guidelines, and at what age which disease is to be in focus. This is to be concentrated. This is a continuum throughout, and the comorbidities are there which are to be addressed, which are hypertension, diabetes, dyslipidemia, and they lead to stroke and mental health also, and ultimately erectile dysfunction. That is the hallmark, and this is the penis is the barometer, and erectile dysfunction is the surrogate marker of the men's health as a whole. So holistic management is the key and all the components, including prostate and hypogonadism, are depicted in this cartoon. Flag signs we should understand. When man has breathlessness, chest pain, dizziness, blackouts, headache, it is a serious thing. Flag sign. Weakness of limbs, myalgia, tiredness, fatigue, or reduced libido, or ultimately erectile dysfunction. So focus should be on sexual health of the men, and along with the all other health, this is at the core, and we should encourage that sexology, andrology, and men's health, these are the different components of men's health, and all the other specialties are also the integral parts, and we should we need the care and caressing and higher threshold, self-reliant perception of invincibility coming from better physique. Don't hear about ill health is the attitude. They don't discuss in groups. Goal-oriented discussion should be there. They fear to share everything linked to livelihood. So serious about their business, and they avoid the health issues. And salient points of men's health strategy are: men don't visit the clinics, they don't interact with the health personnel. Men worries about penis, always they are worried about penis. And beyond health, they affect the gender divide, affect national economics. I have discussed attachment of lifetime should be focus, less intimidating, friendly facility should be there, easy accessibility. We should be open in talking also, and holistic approach, holistic therapy, continuing through ages, testosterone deficiency. Other lectures they have already discussed, and this is the midline crisis where whole of the metabolic syndrome is in focus, and then men, the sexual dysfunction is very important. Men is the least, Indian men is least sexually active male in the world. The studies have shown we need to concentrate, and I have told already, penis is the barometer. At the first point, you see erectile dysfunction is associated with almost all the diseases. And first of all, your erectile dysfunction is going to be affected. We should concentrate on sexual dysfunction. We should concentrate on the myths of the sexuality. For male and female, they should. Most of the causes now are organic causes, and we should know that there are caressing is also important, sex therapy is also important. The sunset focuses are there, which we are discussing in other lectures, and also self-awareness communication is important. You should know that what are the basic things male should know, but the female should know how the intimacy, bonding, physical touch, eye contact, these all important things are there, and we should know that touch is whether it is attracting or it is. We have to treat it. Sex therapy has to be there, and more frequent. This specific question for men are to be focused, and we already are discussing in different lectures the strategies for delayed ejaculation, so that the premature ejaculation and other hesitance, and because of the medicine, if there are delayed ejaculation or an ejaculation, ejaculatory disorders are there, and orgasmic treatment is important. Orgasm is not the goal, but it is important, because orgasm is not essential for the satisfaction, but female orgasm, not male orgasm. Female orgasm is the sentinel marker of sexual health of the couple. If female orgasm is there, then everything female can be male, and therefore it is the hallmark. We should understand care for men. Counseling is important. Wellness tips, nutritional advice. Just now I heard a yoga now. That is important. It is important that you see Baba Ramdev for other issues, but we were mixopathy. So many things we were discussing, but everything is integrated. Everything is essential in this sequence. First of all, lifestyle, that is yoga, and then nutraceuticals, that is your diet and nutrition. Then comes the medicine if you are weak, and you are disease, you have disease, and ultimately surgical intervention. So we should understand that these are complementary to each other. They are not separate to each other. We have created Men's Health Society of India. Dr. Ketan Desai addressed the World Medical Association in 2006 as the president, representing India and president of World Medical Association with the keynote on men's health and present men is more susceptible. But future, we need identification, acceptance, screening, prevention, and integration and specialization in men's health. That is the future when we will. So our future direction is pledged to unite together to establish men's health as integrated specialization, providing men's health friendly men's health experts. Program, health programs, no health program on male. There is no ministry which is dedicated. It is not child and women welfare ministry. No men welfare ministry. While I have tried to explain, men more and let us come together to deliver a continuum of care and build a healthy nation through general practitioner-centric care. Thank you very much. And I invite all of you 6th to 8th August in the Diamond Jubilee celebrations of India. And in Delhi, you can understand it is going to be a huge activity. And you all are visiting Delhi in the 1 week before our 75 years of independence. Thank you.
Thank you, sir, for wonderful.
Thank you, Dr. Sood, for exactly in time, exactly 20 minutes. And I know you are a seasoned speaker, so you know how to be in time. Thank you very much, sir.
Thank you.
Thank you, sir. Rajiv Sood, sir, thank you very much for fascinating delivery of your subject. Thank you very much.
Thanks a lot, Dr. Rajesh Sood. That was a very wonderful presentation.
Thank you. Thank you very much.
Dr. Sood, please accept our e-bouquet and e-memento. Thank you, sir. And next time we will be in Delhi.
Thank you.
I count me as your organizing secretary and you become organizing chairman. We'll do everything. I still remember our 12th conference at Delhi.
Yes.
It was a nice experience. We'll be there.
Thank you.
Okay.
Thank you, sir.
Move on to the next session.
Thank you, sir. Thank you, Dr.
Thanks a lot. Thanks, Dr. Sanjay Deshpande.
Thank you. Thank you all the chairpersons. Floral bouquet to you also.
Thanks a
Sudhakar
lot.
Babu and Dr.
Thank you,
Anand
sir.
Jawar.
Thanks a lot.
Thanks.
Thank you. Thank you.
So this is a very interesting topic today. Debate male sexual problems. We should include partners in the management. And I welcome my co-chairman and my Venkat Garu. Am I correct, Venkat?
Venkat.
Venkat Bhaiya, he is my big brother. Always supporting me every time. Whenever I want help, he always give it. This conference also, we had some technical issues for registering our conference and getting the credit hours for the conference from Maharashtra Medical Council. But Dr. Venkat promptly did it from Telangana State Medical Council. So we have 4 credit hours here. So welcome Dr. Venkat Ramana, and I hand over mic to Dr. Venkat for the further proceedings.
Right. Thank you, Sanjay. Thank you. My dear friends, all the CSEPNs, all the registered delegates, welcome to the important debate whether we include our spouses in the management while treating the male patients. For this, I am proud to introduce our overseas speakers. One, Dr. Shalini Andrews, very great researcher in the sex therapy, and she is holding highest post in the European Sexology Association, and she runs a lot of training programs. and she is a practicing sexologist and heading British Health Association. I welcome her. The next I will invite our brotherly country, the Bangladesh, Dr. Shamsul Hassan, who is father of sexology of Bangladesh. He is a well-known person in the Bangladesh. He started the sex therapy courses, and we are all he invited us. We went there, we trained them, and he is now almost independently running the workshops and training the healthcare professionals of Bangladesh. A senior, well-known person. I welcome you on behalf of CSEPI, Shamsul Bhai. Now both of them are going to speak. One going to speak on pro and one is on the against, whether to include the partner in sex therapy while treating male patients. Over to organizers. Sanjay.
Okay. Mohammed, shall we do the quiz first for the participants? I have one slide. My first slide is a quiz.
Sure, please. Sure.
Yeah, if you could let me share the screen. Sorry to come in. Thank you very much for the kind introduction. So what we'd like to do when we start our thing is have all the participants answer a quiz. So if you go to www.menti.com, it'll come up in my screen. So go to www.menti.com on your telephones, if you have a telephone, and use the code 42373051, which is on the screen, and the question will pop up, and I'd like you all to answer the question before we start the debate. So if you have a second device, like a telephone, go to www.menti.com. And use the code . The question will come up on your screen, and I'd like you to answer. So one person's already answered. Anybody else wants to answer the question from the audience? Yay, one more's answered. Anybody else? We'll give it 1 minute and then we'll... One more. Keep going, keep going.
As a participant, can we answer, Shalini?
Of course, yeah.
Okay. So did you answer your query?
I haven't. I will do. I can do it now. So anybody else in the panelists, let's just do a little bit of fun and interaction, because this is quite, it's quite good fun. And Mohammed and I are good friends. We've known each other for over 10 years. I've spent time in his home in Dhaka. He's the father of sexology in Bangladesh. He's probably the father and mother and guardian of sexology in Bangladesh. And nothing is as much fun as watching a debate between two friends, particularly, a debate on sex. So we hope you'll have a lot of fun doing this. Okay, I think that is everybody who's answered so far. Okay, keep your phones ready for the end of the quiz. One more person's answered. Perfect. And then what I will do is stop sharing now, and then we'll let him talk. Okay. Hold on a second. How do I stop sharing? Stop share. Good. I think my screen is gone. Yeah, over to you, Mohammed. You can start the debate.
Thank you so much, Shalini, for making it very, charismatic, and a lot of tense is there. So, sorry for my ignorance. I'm in the on point or what? Can you see my slides?
Yeah, we can see your screen. You need to start your slides. Yeah.
Okay, let me check it out. Is it audible now? Can you see my slides as well?
Perfect.
Yes, we can see.
Yes.
Thank you so much. Thanks, Shalini, for making it a very charismatic introduction. First of all, it's my privilege to be here. I just like to give my warmest gratitude to the organizers of CSEPI 2021. And I can see many respected figures in the Indian Society of Sexology. And we all know CSEPI is a very prominent and very old organization with lot of, the intellectuals and all the, the dignitaries on board. My thanks to the organizer, Dr. Raj Brahmapat. Sorry for my ignorance if I cannot utter his name properly. Professor Narayana Reddy sir, I have get the chance to come in contact with him. Dr. Sanjay Deshpande, and also I can see my friend Ankur Agarwal there. And also last but not the least, Professor Venkataramana for having us here. Thank you so much. And as you all know, that the British are very strong debater, and it's very difficult to win over them while you are debating against them. But they're also very logical person. And since Shalini is a logical person, she will agree with the initial poll that she already were defeated by 11-3. The most of the audience already have said that they need their partners to be treated. And since Shalini is a legitimate person, she will agree in my cause. So I just want to talk in favor of male sexual disorder. Should we include our partners? My answer is yes. And I strongly support including partner. And let me explain why we need to include the partners. I don't have any conflict of interest. And as you all know that human sexual response by default is a biopsychosocial. And in recent days, it is said that the interpersonal issues, we need to incorporate everything while treating them. We cannot see an elephant like someone who is touching its stump and say that it's like a pillar. Someone is touching his horn, they will say it's like a beagle. So we have to see it in a 360-degree angle, and we need to see it as a holistic perspective. And also, we cannot see a one fragment. And if we want to see the holistic perspective, we need to treat them as a whole. And without wife, without partner, it will be incomplete to assess them. And wife's attitude and understanding of sexuality plays a very crucial part in the relationship. So we need to acknowledge these things in our mind. See what you can see in the picture. There is a guy who is just apparently sleeping. He is an ethnic minority in Bangladesh, in the tribal areas. And you see, he looks like as if he is sleeping. But if you see the broader picture, he's basically pulling one vessel in a tiny river. So picture may be deceptive sometimes, and the full-scale history gives us a better understanding of the situation. And for male sexuality, you need to include the partner. Let me tell you why, of my experience. A 65-year-old senior citizen who came to me saying that I am not satisfied with the sexuality I have. And after assessing his history properly, I thought that having a chat with his partner will be helping me better understand the situation. And he was apparently reacting. When I am done with his assessment, though I could not get the chance to ask his partner, suddenly his wife forcefully came inside the room and said, "Doctor, what are you doing?" I said, "What I'm doing?" He said, "You are treating him, you are fixing him with the pills, and he is just having promiscuous relationship, loitering around different person. I don't need that." And his attitude and the way he is doing his behavior, it is so embarrassing for me at this age. So what I understood from asking him the questions and what I got the picture from wife is completely different. And also another lady who apparently brought his husband, saying that this guy has got PE, if you cannot fix him, his premature ejaculation, I'm going to divorce him. And while seeing the history, I saw that his IELT, intravaginal ejaculatory latency time, was 4 to 5 minutes. And wife had a temperamental issues, and he was frequently very vocally abusive. So husband were always apprehended in the time of sexual intercourse. So on top of that, they never tried clitoral orgasm because the wife was clitoral orgasmic and husband always tried vaginal intercourse. So a detailed history and a proper education for both the partner solve most of the issues without giving much of medication. So these two different cases has given us a idea why we need to address the partner. And in one study, including 3,975, almost 4,000 persons who are attending a male sexual clinic for their sexual dysfunction, we have seen that there is a couple issues and the family issues. 32% had got a problem with the family and 21% had a problem with the couple. So this has a very detrimental effect on the male sexual disorders. And the contextual factors, the relationship with the wife and husband has a very crucial role causing and the consequence of male sexual disease. As you see, the premature ejaculation patients in a slide, that 90% of the partners of premature ejaculate patients are dissatisfied of their sexuality, whereas only 38.3% of the partner of the patients of premature ejaculation were dissatisfied. So largely outnumbered the premature ejaculation patients, they are not happy with the sexuality they have of their partner. So also it happens with the patients with erectile dysfunction because 65% of the partners of men with ED, they have got one or the other form female sexual disorder, like female sexual arousal and interest disorder, female orgasmic disorder. So having said that male sexual disorder has a significant problem, it also creates a significant problem among the female partner as well. There was a very good response of PD5 at the very beginning of its inception. When the PD5 was introduced in the market, people were joyous like anything. But again, we have seen that the dropout rate is very high, almost 50%. The reason is too much of medicalization of the male sexual problem has it doesn't recognize the effect of the patient and the partner. So the dyadic relationship, the relationship between the wife and husband is very crucial. If we don't address that and we are just trying to fix a problem by only giving pills, it's not going to solve all the problem. And so we have to see male sexual disease as a social phenomena. It's possible to get the whole picture by talking to one partner only. Even somebody has got diabetes, dyslipidemia, and testosterone deficiency, it can also have a psychogenic reason why the male and female may not be satisfied. So we need to see the whole picture as a full-scale problem. Partner is very important, and some patients are willing to come with the partner. So it gives us a clue whether it will give us a better result. If the female partner are willing to come to the treatment session, you can expect a good outcome. Some women are reluctant to come to the social stigma. There's a lot of noise. Inclusive the treatment and engagement of the treatment program is very important. So my take is that my friend, my opponent, Dr. Shalini will agree of my cause that we should include the partners and the wives always while we are treating our male sexual disorder clients. It has to be dealt with the biopsychosocial and interpersonal approach. Most prominent male sexual disorder have significant partner dissatisfaction, and it can trigger the partner sexual problem as well. And sometimes a good psychoeducation, including the partner, is sufficient for treating many of the male sexual disorder. And more medicalization of the male sexual disorder creates a therapeutic non-adherence. So, like I said, my partner will agree on my cause. Thank you so much, and thank you for giving me the chance to talk. I will be looking forward to hear more from my partner, how he agrees with my. Thank you.
Thank you, Dr. Shamsul Hassan. This is Dr. Deshpande from Nagpur.
Hello, sir. Nice meeting you again.
Yes, yes. So you can kindly stop the screen share so that Shalini, Dr. Shalini can also share the screen.
I think I'm sharing the screen.
You are not?
Am I not sharing the screen?
Yeah, you are sharing, huh?
Yeah, I'm sharing. Can you see my screen?
Yes, we can see.
Yeah, perfect. Perfect. Can I just request all the panelists to mute? I think there was one quite noisy in the background. Somebody's cooking. So if we could all, other than the speaker, if everyone else could mute, that would be great. So thank you very much, Mohammed. And, you know, as I said, he called me the charismatic speaker, but you can see that he is the charismatic speaker, and he's also a psychologist. And for those of us who do other professions, we know how these psychologists convince us about everything very quickly. And we all listen to them. So I nearly nodded away and I nearly said, yes, of course, he's totally right with everything that he says. But hold on a minute. So hold your horses. Don't make your decisions just yet. Let's listen to the other side of the argument. And if you see this picture, I think some of us, particularly the older generation in India, will remember this lovely cartoonist, R.K. Lakshman. He's a South Indian cartoonist, brother of R.K. Narayan, who did those lovely books like Malgudi Days, which is very psychologically perceptive. And R.K. Lakshman was very good in the sense that, you know, he may not have been the most politically, great artist, but he captured the common man. You see one of his cartoons like this, and you can see, the old man in your street walking down like that. So when you listen to my talk, I'd like you to remember the common man that you see in your practice and what is happening in day-to-day life, not the idealistic ideas, but the common man that we see. So what are the arguments that my esteemed colleague has used for including the wife? So I tried to read his mind. Believe us, we didn't share each other's slides. These are the things I thought he would come up with, and I'm not right. I'm not wrong. We know that this is what we do. So sex is not about one person. Wives often instigate the visit and they want to be involved. Male sexual dysfunction affects the wife. Long-term partners have high prevalence of female sexual dysfunction. So the same Greenstein paper that he quoted is the same one, I think. And finally, the biopsychosocial model of care. So these are the arguments he's used to say we should include the wife. Now I'm going to take each of these arguments and give you a counter argument. So sex is not about one person. It involves more than one person. Now, come on, is it completely true? So the key that I want you to remember is the always. Always an exception to always. So can sex be about just one person? Of course, sex can be about one person. We come from a culture where men get married much later in life, women get married much later in life. My grandmother had her first child age 16 and she had 10 children. She was married at 14. I was married at 23, but we are both working doctors with a very busy career. And it was much later that we chose to have children. We could meet each other and everything else later. So that is the truth of our societies today. And in that society, men and women across the cultures enjoy solo sex. So sex with oneself. And my colleague here again is a psychologist and a sex therapist. I'm sure he recommends solo sex sometimes in the context of, say premature ejaculation. We do the stop, start, squeeze technique, which doesn't involve the partner, it's about the person themselves. And solo sex sometimes substitutes and sometimes complements partnered sex. So if somebody, it's not just, before they find a partner, but also after they find a partner. Say if a woman's heavily pregnant, she's just given birth, or she has menopausal symptoms. Sometimes men, you can all imagine yourselves that solo sex has a part in our sexual life. There are ways of satisfying our sexual needs. And also when it comes to women, orgasmic pleasure so when they interviewed a lot of women and they said, okay, you can orgasm with sex toys or masturbation, you can orgasm with a partner, what do you prefer? Women generally preferred orgasming with a partner, but when there are sexual problems, they value solo sex. So if there's a problem with a partner, a problem with themselves, or there are difficulties in achieving an orgasm, solo sex can be extremely helpful. So the first point, sex is about one person. not about one person. Have a little think. Sometimes sex can be about one person. Now, the second argument was wives would like to be involved in what is happening in the husband's life. Or do all wives want to be involved with what's happening? So I want you all to think in your practice of the common man, what proportion of sexual relationship that they're talking about is within a long-term marriage. So my colleague himself told you about the partner where, do you know he's going off and being promiscuous with lots of women and using things. So that is true. As therapists, as doctors, it's not our position to judge. We are there to help our patients to achieve the happy balance. And what proportion of our patients are seeking help in relation to the wife, or is it about other partners? We know that India has the lowest divorce rate in the world, 0.24%, and we have a very high marriage rate. I idealize India. So particularly if you live outside India, if you're a migrant, to you, home is always the best. Every morning I wake up and say, idli doesn't taste like it did in Madurai, in my hometown. And or particularly for people like me who are migrants, everything about India is beautiful. And then my children make fun of me saying, oh, mom, nothing for you is like it is in India. And so I'd like to think that low divorce rate, high marriage rate means we all get married and we stay happily married ever after. Unfortunately, in the practical world, we know that that is not completely true. And we know that all marriages are not happy and sex has a different meaning in different times in life. So do the wife definitely, do they want to be involved? And the third thing is the Indian culture has traditionally accommodated differences. Our traditional god in South India is Murugan. Murugan, and you'll be familiar with Murugan as Kartikeya in the northern culture, son of Shiva. And he's got two powerful wives, not one, but two, one on either side. My daughter's named after one of his wives, Valli, and the other one is called Devyana. They stand side by side, and that is our culture. In terms of acceptability. We don't say everybody go off and marry two wives or whatever, but there are differences and we have to accommodate differences. We know Dasharatha, Rama's father, had his wives. We know Draupadi, who had 5 husbands. So Indian culture is not so rigid. It's not, when the Western cultures came in, they made it all very, adultery became a criminal offense and according to the English law. Thankfully, the Indian law has now changed it and adultery is no longer a criminal offense. So partner may not always be the wife, and we need to remember that as sex therapists. And finally, this is an app I came across recently. This is for married women who are looking for extramarital sex, and this is an Indian app. This is not from the West. And actually, I've also come across couples where husbands encourage the wife to find relationships outside marriage because they think the balance will be better. So I will leave the thought with you. You may agree with it, you may disagree with it, but this is not about how we practice sex, it's about how our patients practice sex. Now, the third and fourth argument are male problems affects the wife, and wife may also have a problem. And so so the first study I'd like to say is a study by Annie George in Mumbai. She looked at 100 married people in Mumbai and asked them about how they felt about marriage, how the marriage was. So these were people who had an arranged marriage and they were in a long-term arranged marriage. So they didn't plan to get divorced. They were planning to stay together. The men felt it was their right to have sex. So they felt that, oh, if I ask for sex as a man, she must give me sex. The women felt they didn't always feel like having sex. Sometimes, yes, but a lot of other times they felt that they didn't want to. Both felt that as they got older, sex should decrease with time. So they said, oh, we've had a lot of sex when we're younger, but when you're getting older, of course, nobody has sex. And even though their expectations were different, within a marriage, they found ways to negotiate so that they got the right amount of sex that they wanted. So if a man wanted a lot of sex and a woman didn't want to have enough sex, she might say, okay, I've prayed to God this month that I won't have sex at all. And using it as an excuse to get what she wants out of that marriage and out of the sexual life. And men also used similar tactics to get what they want out of their sex life. So we must remember that male sexual problems causes distress in partners, but for some marriages, that may be what restores the desired balance of sex. So say if a woman didn't want to have sex, she doesn't particularly enjoy sex, particularly with that man, he asks for a lot of sex. I'm sure she can't wait for him to get erectile dysfunction or some problem so that they can finally stop having sex that she doesn't enjoy anyway. And finally, the biopsychosocial model. So that's the one where I'd come back to and say, remember, sex can be solo or partnered. Partner can be the wife or partner can be another person. And also we need to remember the cultural aspects. Does the wife want to come and sit in a room and talk to a male doctor about their sex life? It may not be a male doctor, it could be a female doctor, but we have to put it within the cultural context and remember that one size doesn't fit all and it might not apply to everyone. And on that note, I will finish and I will let you take the quiz again. And so I say, while treating male sexual problem, we should include the wife, but not always. So always is the key word. Remember the word always. Remember the common man when you do your voting. So back to voting, Mentimeter, www.menti.com. And I'd like you all to cast your vote. Any other vote casters? We had about 15 last time, I think. Only 5 people want to vote. Excellent. So I think my colleagues won the vote. He's winning and winning. He's getting higher and higher. Excellent. So do we have time for questions or are we going to move on?
Maybe your colleague must have won from the voting. 60%, 6 he has and 2 you have.
Yeah.
I think, but you have won the hearts of all the participants.
Oh, I don't feel bad. I don't feel bad because
no, because you have contested battle very nicely. Very nice presentation and nice, what you can say, contrasting the views of your fellow colleague. So very good presentation, Dr. Shalini. And Dr. Shamsul, you have won. Are you there?
Yes, sir. Yes, sir. I'm there.
Yeah.
See the
Now we know, everybody of us know that it is very important that involvement of the spouse, I will say involvement of the spouse is very important in treating the sexual dysfunction of any person for that sake. I'm making it gender neutral. So many times we have found that in India, when a woman comes for the treatment of sexual dysfunction, it is not compulsory, but it is very mandatory that the sex counselor or a sex therapist has to involve her partner. So it is vice versa also, I can say that either wife and husband both should be the partners in sex therapy. So you also can counter me if you want, Dr. Shalini.
Oh, I absolutely agree. You cannot, you always have to get the bigger picture, the complete picture. So I was just trying to play on words saying, okay, there are all, there's no always in sex therapy, as we know. I think even Mohammed's lovely slides explain that you have to see the bigger picture. You see part of it and actually have to find out whether the wife wants sex or not. And then depending on what the situation is, we've got to work with the situation they present us. So while I can argue that, don't always include the wife or the one partner that you think are the partner, definitely including having a biopsychosocial approach is absolutely important. And that is the most scientific way we know how to manage sex.
Thank you both the speakers, both the debaters rather, I can say. You have put the points very well. And now I will share my screen. So Dr. Shalini and Dr. Shamsul, this is an online conference. So we are presenting the online bouquet and online memento to you. But I can definitely tell you that whenever you come to India, we'll be there to give you this memento in reality. So kindly accept it time being, and come to India to, what you can say, enjoy our hospitality and all the things. I think Dr. Shalini, you are frequent visitor of India or not?
Absolutely, yeah. And not because of, I mean, not now because of COVID, but no, I'm there almost every year. Madurai is my hometown, so
So
yes.
whenever you came to India, whenever you plan to come to India, please tell to Dr. Venkatramana or to me so that we can have a good session here. Even Dr. Shamsul also, we can plan something. Because Bangladesh is very, very near to India. And that is very, very close to our heart. All Bangladeshi, we consider them as our co-patriot only. So come to India and enjoy our hospitality there.
Thank you so much, and thanks for having us. It was wonderful to be here.
Thank you very much.
Thank you.
Thank you very much. So friends, dear delegates, speakers, chairpersons, we'll break for the lunch, though we cannot offer lunch online, but we'll take the lunch and join again at 2 p.m. here. So till that time, will be closed. Okay, but you can continue having your link online, or we can close and again click here and again rejoin. So thank you very much. We'll meet 2 p.m. sharp. Thank you, the chairpersons, Dr. Venkatramana. But Venkatramana, I think, is in travel, so he may not be able to listen to us. But I am very thankful to Dr. Venkat because he only was instrumental in having this debate and make these two international faculties. We could listen to them because of Dr. Venkat. Thank you, Venkat. We'll break for lunch here.
Okay.
मैं तुमको बताता
मी काही सांगितलं सगळे मोठे लावून दिलेले तर ते काय करायचे मला ते नाही सर काय करू जाऊन
काय करणार आहे तू?
ते करणार नाही काम आहे थोडंसं.
काय काम आहे? किती वेळ लागेल तुला?
त्याला जायला चालत जायचं ते नाही सगळे गेले.
काय करायला गेले?
ते कोतवालला गेलेले आहेत.
हा. हॅलो. काय करा?
लोक जाऊन
काही किती वेळा दिवशी?
चालत जायचं चालत जायचं.
हॅलो.
Hi, sir. So there is a lunch break till 2 o'clock.
परत बॉलचं येते तर काही आमचं काम चालू. हा. मम्मीकडे किती वेळा दिवशी? जातात जा ना. कसं काय? सगळे लावून झाले का? सगळे आयवी लावून झाले आणि खाली
खाली पण मोठे शर्ट
लावून टाकले. हा. जाऊ माझं काय हा.
हाँ चल दवा हाँ ठीक है देखो आप आ जाओ हाँ
Good afternoon, Dr. Athole.
Welcome, Dr. Zhodpe and Dr. Arvind Athole. Welcome, Dr. Ajit.
Good afternoon.
Good afternoon, sir.
Yeah.
आज आपला पुढचा आहे.
Good afternoon, sir. Am I audible?
Yes, you are.
Audible.
Can everybody listen to me?
Yes. Yes, Dr.
Am I
Deshpande.
audible? I
Yes,
request
sir.
the chairpersons, Dr. Ajit Chakravarti and Dr. Arvind Athole, to unmute themselves.
Yes, good afternoon, all of you.
Good afternoon, Dr. Athole.
Good afternoon, Dr. Sanjay Zhodpe.
Good afternoon. Are you able to hear me?
Yes, yes.
Yes, sir. Okay.
Thank you.
So it's nice to see all my friends together.
Yes, such a
All
pleasure.
PSM stalwarts, I can say. Because Dr. Ajit Chakravarti is also from community medicine.
Oh, that I didn't know.
Yes, yes, yes.
Yes, sir.
Very good.
So that's why, specifically because Dr. Zhodpe is speaking, I thought that the person from community medicine should be the chairpersons. So Dr. Arvind Athole and Dr. Ajit Chakravarti are chairpersons for today's this new session. So,
Zhodpe sir, Dr. Athole, Dr. Chakravarti, I am to here, though I am not from PSM. But Dr. Zhodpe can recall that I have spoken for PSM in debate many times by feigning to be PG from PSM department, though was not from PSM department. So I can be a virtual PSM department person.
Based on the time that you spent with PSM Fox, you should be awarded honorary doctorate in PSM.
Yes, exactly.
minimum 4 persons. Yourself, mine, then Sanjay Gandhi and Nishikant Rade.
Okay. Continue, Dr. Deshpande.
So welcome to this post-lunch session. I can say that this last session of our 2 days virtual conference. So this session will be having lectures on how to write a research paper, practical approach to premature ejaculation, and male infertility and sexual problems. So the chairpersons for this session are Dr. Ajit Chakravarti from Trivandrum and Dr. Arvind Athole from Bhopal. Dr. Ajit Chakravarti is a sex educator, counselor, and therapist, and a faculty of community medicine at Trivandrum. And Dr. Arvind Athole is professor and head of Chirayu Medical College of the Department of Community Medicine at Bhopal, and a very old member from Council of Sex Education and Parent International. The speaker, Dr. Sanjay Zhodpe, is also a member of CSEPI. So, but the chairperson will introduce Dr. Zhodpe. So I'm not going and introducing him, because if I start introducing him, I will require at least an hour for that, because we are with each other from 1982, 39 long years. And Dr. Zhodpe's statement, I will again repeat here, that whatever our parents and our spouses they know, we know about each other more than them. So it's better not to speak about each other here. So thank you for joining this session. And all the proceedings now I left over to Dr. Athole and Dr. Ajit Chakravarti. So over to you, sir.
So, good afternoon, all of you. Dr. Sanjay Zhodpe. Should I introduce Dr. Sanjay Zhodpe? Yes?
Yes, sir. Yes, sir. You carry on.
Yeah. So, it is my privilege to introduce Dr. Sanjay Zhodpe, who is Vice President at the Public Health Foundation of India and the Director of Indian Institute of Public Health, New Delhi. And he presently works as the Vice President Academics of Public Health Foundation of India. Holds a leadership position as Director at the Indian Institute of Public Health, Delhi. And he also holds joint appointment as an honorary or adjunct professor in 5 international universities. Now, I was fortunate enough in my initial days of my career with actually associated with Dr. Sanjay Zhodpe, and all his teachings and trainings in public health or the community medicine has all been imbibed by all the faculties and public health professionals working in India at various levels and positions. They have many of the times they have taken advices from him and inspiration from him for many of the public health projects and many of the aspects in public health. So I invite Dr. Sanjay Zhodpe for his presentation on how to write a research paper. Dr. Sanjay Zhodpe, please.
Yeah. Thank you, Dr. Athole. Such a generous introduction and such a pleasure to be part of this conference. I'm grateful to Dr. Sanjay Deshpande, who happens to be a very close and dear friend for several years, for inviting me to share my thoughts during this conference. Arvind, can you take out this or somebody from technical side so that I can put my slides on? Yeah.
Yes. I request to take out the slide. Yes. Thank you.
Yeah. Arvind, are you able to see my slide?
Yeah. Yes.
Thank you.
Yes, sir. Yes, sir.
Thank you. So I was mentioning that I'm grateful to Dr. Sanjay Deshpande for inviting me to be part of this conference. It is such a pleasure amongst the galaxy of leadership of CSEPI and the participants who have been participating in this conference. He has requested me to speak to all of you on a topic which is very close to my heart: how to write and publish a research paper. But at the outset, I also wanted to mention very clearly that if you wanted to write and publish a research paper, it can only be done by doing it so. Because listening to such talks would give you an idea about how to go about it. Even you participate in some workshops on manuscript writing and publishing a research paper, that would be a guidance for you. But if somebody really wanted to write a paper and publish in a good journal, then it is to be done. By doing only one can learn how to write and publish a paper. That is the idea that I wanted to bring it at the beginning itself. But let me throw some light on some of the issues in the context of writing and publishing a paper next maybe 20 minutes or so. We all understand that when we are involved in a research, the intended endpoint of any research generally is publication. And I'm sure that several members of the CSEPI, they come from academic background and they would be doing research work and would be publishing also. But even in clinical practice, I'm sure you are confronted with so many patients, and you must be doing certain research and must be contributing to the research. And whenever we do a research, finally, if it is published, then it is widely disseminated. And therefore, it is rightly said that any scientific work that we undertake is not complete until the results are published. Because whatever we do, unless we share the findings, the results with the fraternity, it will not be used. So what is the purpose of the research if it is not used by anybody? If we wanted the findings of our research are to be used by other members of our fraternity, it is important that we publish them. And therefore, the end point of whole research cycle is publication. And therefore, communication of results, because publishing in journals means that's how we communicate the results, is a very much integral part of the research process. When we say somebody that we had undertaken a research, but if it is not published, then we say that it is incomplete process. And that is how the knowledge is stored and presented. Because research is merely a tool. What ultimately benefits to the society is the knowledge. And knowledge generation and knowledge translation are two vital components of any knowledge process. Knowledge generation means through a research which gives you a thrills of discovery. But knowledge translation is basically a purpose being fulfilled, that the research that we have generated, the knowledge that we generated is being widely disseminated and used by fellow researchers, practitioners, and the people who are involved in that fraternity for advancing the science is basically the ultimate purpose. It also gives all of us a professional recognition. Like when you are introduced somewhere, people say that you have so many publications. It is basically a professional recognition. Or if you suppose publish in a particular area, then you are recognized in the area as a leader in that area. That also happens through publications only. Publications also leads to grants, jobs, reputation. These days, like for example, our councils, professional councils, for the positions which are recruited in medical schools, like assistant professor to professor, they also look at what kind of publications do you have. So jobs, it is linked with. If you wanted to write grants and secure funding for research, they would check with you if you are actively publishing in that particular area or not. That also builds you your professional reputation as a scientist and researcher. It is also widely said, either you publish or perish, because that's how it is. And of course, sometimes nowadays, there is a publication cost involved. And when you are conducting a research, you can also actually incorporate the dissemination cost as a journal publication cost also. Now let's understand, and because looking at the heterogeneity of the audience, I kept myself to very basic fundamental principles and very basic things. And so it might happen some of the issues are very well known to you, but I thought that for articulation of thoughts, it would be useful to keep it at the minimum level. So what are the goals in writing papers? Why do we write papers? Why do we want to publish? Of course, in addition to what I have generally said right now, it contributes to the medical knowledge. How the medical knowledge is generated? It is through research. Now, like COVID-19 had come, we didn't know anything about COVID-19. Last 18, 19, 20 months, we had done so much of a research that we understood the whole dynamics of the disease in terms of diagnostics or treatment modalities or preventive strategies, all aspects. And therefore, we need to continue to do a research which would generate medical knowledge. And if we publish, that's how it happens. It contributes to the policy also. If you wanted to take some policy decisions at the programmatic level, then you need information. And from where the information would come? It is through the journals only. It gives you immense personal satisfaction by influencing thinking or a policy in a field. Suppose you are working in the field of early ejaculation, all sexual dysfunction, and then you are doing some research to understand, suppose, the predictors of sexual dysfunction, or what are the risk factors for sexual dysfunction, and then you could find something which is not known to the people, then that's how it gives you personal satisfaction, that you identified certain things which are helpful to the policymakers or to helpful to the science to move forward. And of course, the other practical issue that I talked about, CV building, then promotion and tenure and job work, they are all equally important. But in the context of writing papers, I must mention at the front that there's a debate at times, quantity versus quality. That somebody is introduced, he has 200 papers or 250 papers. Somebody may have 30 papers. But what is more important is quality. And quality is determined by several parameters, whether you are publishing in peer-reviewed journals, whether you are publishing in journals which are widely read, whether you are publishing journals which have very high impact factor. So there are many parameters that we'll not get into, but publishing in a good journal, even few papers, is more important than publishing many papers which are just not read by anybody. So that trade-off one needs to work out when you talk about writing a paper. Now, how is the publication procedure happens? Like, for example, you wanted to write a paper, then how the publication procedure, and I had an opportunity to be on editorial board of several journals, and I was a chief editor. And so I'm aware about what happens at the end of the journal also. So it is important to mention what happens at the journal end also. Paper writing begins with completing and analyzing the study. Unless any research it is not completed or completely analyzed, you cannot begin writing the paper. But my advice is to avoid time lag between completion of study and writing it out. Sometimes because of a procrastination, it happens that you complete the research and then it is pending for 1 year. And then you start writing paper. By the time, probably you would have forgotten what you exactly, what you have done. And therefore, writing a research paper is a continuous process of a research activity. It should not be seen in isolation. It should not be seen in piecemeals also. And therefore, I would suggest that once the study is over, immediately paper should be written up and sent for the journal. Then you have to select the journal, and we'll talk about it, how to select the journal subsequently. Then you have to prepare a manuscript that you wanted to submit. Once the manuscript is prepared, you submit the manuscript to a journal. Then at the journal's end, there is a peer review process. And I will talk about it more detail. Then if sometimes it happens that the article comes back with some revisions, or sometimes they reject it, but there is always a scope for revision and resubmission to the same journal, or sometimes it is rejected, then you can submit it to another journal also. But finally, we have to respect final editorial decision. So this is what actually the publication procedure which is involved when you talk about publishing a paper. Let me tell you, scientific writing is not an easy task. It is a tedious and painstaking process. And we have seen people are quite reluctant and hesitant in writing papers because this has to be built over a period of time. But we have on the other hand seen that some individuals are so expert in writing papers that it becomes habit for them to write papers. And any writing for that matter, why scientific writing, other way around also, you take any piece of writing, it requires continuous strategic and conscious efforts to build writing skills. And that can only be done by practicing. You have to continue to write, and that's how you build the skills. That's the message that I wanted to give at this point in time. But when you write a paper, you ask these 3 questions to yourself, because that would help you to decide where to publish, how to publish a research paper. First, you decide why you want to write. What is the purpose of writing a paper? Then you decide for whom do you want to write? Who is your audience for that matter? And then decide where do you want to publish paper? Because these 3 questions are pretty related to each other. Even for that matter, like suppose you are working in the area of tuberculosis. Now, if you are doing research in the area of tuberculosis, which relates to very clinical aspects of tuberculosis, then probably a Lung India would be a better journal. But suppose you are doing a programmatic work in the area of tuberculosis, then you can also look at from the WHO bulletin and some other journals which are there. But suppose you are doing diagnostic work in the area of tuberculosis, then probably you can look for some another journal which publishes diagnostics related work. So it's not only the disease entity, but it also depends on what aspect of the disease that you are studying. That would help you and guide you to select a proper journal for publishing a paper. And then therefore, that would guide you to even identify journals where do you want to publish your paper. So how do you write a paper? Basically, research paper, and I'm talking about original research paper. Today, I'm restricting myself to the original research paper. I'm not talking about like case reports or systematic reviews or protocols or commentaries or editorials. There are a variety of the aspects that you might be involved in writing. But here today, we are talking about a very standard original research paper that you wanted to talk. And that includes structuring your paper. Structuring your paper is generally in the 4 major domains that you have to write. Introduction, that's called as the IMRAT format also. Introduction, methods, results, and discussion. And then, of course, there is abstract and then title and keywords and then putting references, adding tables. Those are the additional activities that you would be involved into. But these are the 4 major sections that you need to put it into a format. So writing sessions is that basically you begin with introduction, then you move on to write method section. Then in method section, you have to write what you have done. Then you write result sections, which includes your tables and diagrams and figures and description of those findings. And then finally, you have discussion section, which is a bit difficult to write for many people because you have to articulate your thoughts that what do you want to write, pros and cons, and comparing with other studies and putting up the arguments, sometimes theoretical, sometimes practical arguments, coming with implications and recommendations, and then finally putting up the references. I would suggest that you rewrite and rewrite unless you are satisfied. If you have written an introduction, if you're not satisfied, you revisit it, you read it a couple of times, and it requires in initial phase, you have to spend more time, but subsequently it becomes a habit and then you can easily write about it. It is always useful to get it peer reviewed. You can ask your colleague, you can ask your friend to have a look at it. Because what happens is that because we ourselves are involved in piece of research, then we have some ideas or the gaps are filled by our brain when you write. And even if there are gaps when you write, they are not identified by yourself because when you read that, you feel it is continuity there. But those gaps are picked up by some other individual who may not be involved in research. And then submit for publication. And of course, be prepared for consequences. There are only 3 outcomes. Either the paper would be straightforward accepted, or sometimes it comes back with revisions to another opportunity to resubmit it, and otherwise paper is rejected. But you have to be prepared for the consequences that we wanted to do. Now, this is very commonly asked question that how to choose the appropriate journal for publishing a paper. Stop and think who might benefit most from your idea. Because your piece of research is a brilliant idea that you had in mind. You articulated research question, you conducted the study. You know better than anybody else that who would benefit from the research that has been carried out. If it is a clinical aspect of some disease, or it is a programmatic aspect, or a policy related work, or it could be a case study, or it could be a narrative, but you would be a better person to understand that who would benefit from this. And you have to reach to that audience who would benefit from the work that you had conducted. And therefore, you can conduct guideline reviews also. I tell you, more than 40,000 journals related to health are published globally. More than 40,000. If you include some journals which are, I'm not including predatory journals, but if you include that number, then it gets inflated even around 50,000 or so. But even if you count peer-reviewed journals, it's close to 40,000 journals related to health. They are there. Of course, then discipline-wise, and then you have different databases like Embase is there, or Medline is there, or the Scopus is there, and it is variable. And like Medline, for that matter, has close to some 7,000 plus journals being incorporated into the Medline database. So there are many journals globally are published, but you have to conduct a guideline reviews amongst those journals which are more relevant to your work. Then you assess the relevance of your work to a particular journal. Suppose you have done some epidemiological work, you would like to publish it in maybe American Journal of Epidemiology or International Journal of Epidemiology. If it is related to, suppose, something in internal medicine, maybe good journals like New England Journal of Medicine or JAMA, or in India, we have JAPI and other journals which would be keen that your work is published. But even in internal medicine, suppose you have done something which relates to cardiology, then there are specific journals related to cardiology or gastroenterology. So depending on the area of work, you would find that there are many journals available and you have to do a review of that. Then you shortlist the most likely outlet for your research idea. And finally, you can also look at when you decided, suppose you decided that you wanted to publish in Indian Journal of Medical Research, that is ICMR journal. I would recommend that you look at for last 2 to 3 issues of ICMR to see what kind of articles are they publishing, and you confirm the fit, because you know your article better than anybody else. So you have to see that whether similar kind of an articles are published. Recently, somebody checked with me that they had a clinical trial protocol, and they had sent it to some journal, and they said that we sent it to 2 journals and it came back very quickly. And then I said that, you sent it to those 2 journals which do not publish protocols. By policy decision at the editorial board, they don't publish protocols. There are certain journals which are very keen or which are rather dedicated themselves to publishing protocols. So you have to identify where do you fit into. That would help you to choose the journal. But keep in mind, whether it's an indexed or non-indexed journal, I would strongly discourage you from publishing in predatory journals, and they charge some money and they publish it. Not fair, because nobody reads them, and it doesn't add any value. And therefore, I would strongly encourage you to identify good databases like Medline, Embase, and Scopus. If they are there, and then you can blindly go for those journals. You also look at from content and methodology point of view. Sometimes you have a focus on some area, TB, or you have respiratory system related issues, or you have some urology related issues, or methodology, which if it's a clinical trial or a case control study. Sometimes, like as I mentioned, internal medicine would be a general, but cardiology, respiratory medicine would be a specialist. Whether community setting or clinical setting, public health community setting, there are some specific journals, but some journals would only publish clinical background or clinical work only, national, international. And finally, the impact factor is more important, which needs to be considered. But make early decision, because you have to then format your paper according to the journal that you choose to submit for. This is a standard format, IMRAT format. In introduction, sometimes people write stories in introduction. It's not required. Introduction should be not more than maybe 3 paragraphs, at the most 4 paragraphs, small paragraphs. But reading that introduction, we should answer this question: why was this work undertaken? The purpose of your research should be very clearly reflected in introduction. By reading introduction, it should be very clear that why you had undertaken this research. That should be the only answer. That it should not be a very comprehensive literature review, or it should not be very long. It should only tell us that why this research was carried out. In methods, also very straightforward. How was it done? That you selected the study design, then you had sample, your patients being recruited, or cases or controls, eligibility criteria, including criteria, exclusion criteria, how do you do measurement issues, some laboratory testing, statistical analysis. So all those issues, how was it done? And method section is always written in the past tense, please remember, because you had finished everything. When you are publishing, your study is already over. So everything is in past tense. And results, then what did you find? These are the results. Initially, there might be some descriptive tables. It could be some analytical tables. And those tables and diagrams and figures are then described in the form of a text. So what exactly you found is presented in the results. And discussion would have, what does it imply? Basically, focus of discussion should be the implications of the study, in the context that briefly telling us about this is what you have observed, and then looking at those findings of the study from the perspective of what others found, what are the strengths and weaknesses of your study, how it relates to the arguments. It could be sometimes theoretical arguments, some biological plausibility needs to be explained, coherence needs to be explained there. And then finally, if the cost is involved, program is involved, so implications from that perspective is also talked about. And finally, how relevant is this research in the context of advancing science is relevant. And you can also talk about some limitations if they are there, and even future recommendations. Maybe that you have answered some research question and there may be some aspect of the issue that you wanted to further research to be carried out can be recommended. Now, another issue that people confront with is the issues in the authorship. Sometimes it seems to be very simple and straightforward business authorship, but sometimes it's very complicated because there are expectations of the people. If there are 4 people, 6 people are involved, sometimes from other departments, sometimes from other sites also, where you may be doing study where 3 sites at 3 places are carried out, then the issues of authorships becomes more complex. My simple recommendation is you follow International Committee of Medical Journal Editor guidelines on that. Think, plan, and clarify a lot ahead of the time. Because see, once you finalize everything and you submit, and then there's a confusion, then sometimes independently authors writing to the journal saying that my name is on 5th number or 7th number, which is not acceptable to me. And such fights are seen and visible. I was a chief editor of a journal, and we had seen then other authors writing about the sequence of the author and lead author and corresponding author. Therefore, these are important issues needs to be sorted out quite well in advance. Be forthwith and truthful. It is that simple. Who has contributed to the research, who has contributed to the writing, should be the authors, maybe number 1, 2, 3. Those authors who had limited contribution could come later. It is simple. And consider the sequence of authors also. Does it justify the role of every author is also important. And this decision is to be jointly taken by all the authors involved in the whole business. Don't try to answer this question. Don't try to get into this happiness. Because sometimes, is everyone happy? So if you wanted to make people happy, you sell ice cream. You can't write papers because you may be not able to make people happy, because everybody would be wanting first and second author irrespective of their contribution. That doesn't work. And the Pierce episode I wanted to mention in 20 seconds is that this is a challenge that we confronted with this is reported in the British Journal of Obstetrics and Gynecology, where the fraud data was used for cooking up the paper. And then subsequently, it was also realized that, and then this Dr. Pierce was heading the department. And he allowed his name to be used. Rather, he said that you put my name in the paper. And then paper was published and it was identified the data was fraud. And then this Dr. Pierce tells to everybody that, no, I'm the head of the department. I was not involved in research. And then therefore, I cannot be a party to this whole business. But the argument is that you signed and you insisted that you should be author. You have to be accountable and take the responsibility of the work that has been shared. So neither you not take a research authorship gift. Sometimes people say that I write paper, I put your name, or you write paper, put my name. So we multiply in numbers. That doesn't work. And you have to be publicly accountable for the work that we have done. So you have to be careful on that. Unless you are sufficiently participated in a research work to take the public responsibility of that, you should not get into the authorship business. So what is required to be an author on the paper? A substantial contribution to 3 bullets that I'm talking here: conception and design or analysis and interpretation of data, then drafting the article and revising it critically for important intellectual content, and then final approval of the version to be published. So these conditions and all these conditions have to be met. It's not that one condition you have met. So unless you commit to these 3 conditions, paper cannot be published. Like participation in, I got funding for you, suppose, or somebody is involved in only collection of data, or involved as generally a supervision of a research group, like I'm a dean of an institution or head of the department. This does not just justify authorship. They can be acknowledged, like you're head of the department or those research associates who have been helpful to collect the data, or somebody helped you in acquiring funding, but they cannot be, authors. Sometimes you have corporate authorship also, because there are collective authorship, like you as a group is working something, and otherwise you can acknowledge people who are involved in too. Last couple of slides, I wanted to say what happens at the editorial review and at the end of the editorial end. So the first thing happens is that when you submit a paper is that you get acknowledgement receipt. Then there is an in-house evaluation at the end of the journal staff. Generally 2 to 6 referee who would look at your paper. They would critically provide the comments. Generally, if the manuscript is rejected, in maybe around 2 to 3 months, probably you would hear from them. But manuscripts which are acceptable would take some longer duration, maybe sometimes 3 to 4 months also. These days, journals are burdened with so many papers, so it takes sometimes a longer time. Then you get a corrected proof and needs to be returned within 48 hours if paper is accepted. You have to sign copyright transfer forms at that point in time when the paper is likely to be accepted, or accepted rather. Then you can even order reprint original order forms and receiving the reprint, something which can be used for dissemination purposes. But be prepared for consequences. This is the end of this talk. Where suppose you are not accepted, there is a probability that your paper will not be accepted. Accept rejection, cool off. Sometimes we have seen then the researchers and authors get very agitated, and they said that our paper was extremely good and this and that, and then still it is not accepted. So it's fine. It's being reviewed by people. They are independent reviewers. They do not know it was your paper. They would do it independently. And based on certain criteria, your paper is not accepted. So there is no need to be very annoyed. Of course, we would be disheartened, but there is always a way to submit that paper to some another journal. Review referees' comments, because even if they would reject, they would send you comments. Revise your manuscript considering those referees' comments if you see they are adding value to your paper and they are genuine comments, and submit it to some another journal and hope for the best. It's not that the paper is not acceptable. You can submit it to another journal also. And why papers are rejected, this is the last point that I wanted to mention, is that the study does not address an important scientific issue. Why? Because people feel the paper is rejected. These are the reasons. Study is not original. The study does not actually test the author's hypothesis. We have seen sometimes the hypothesis is different and results are different and conclusions are different. Different type of the study could have been done. Study compromises original study protocol. Sometimes the sample size is very inadequate. Statistical analysis is not properly done. There are some systematic errors which are not resolved. Sometimes authors we have seen drawing unjustified conclusions. Study is very simple, but they draw conclusions as if that they are earth-shaking. There is sometimes significant conflict of interest, like supported by pharmaceutical or some other agency. The paper is so badly written that is incomprehensible. Sometimes we receive papers so badly written from language point of view, from the grammar point of view, even from articulation point of view. The flow of thoughts, the information, the way it is presented is these are the common reasons that why papers are not accepted. But I wanted to say that whatever you do, the good kind of research that you would be doing, but you should be able to enjoy research paper writing. It should not be seen as a process. It should be seen as basically a passion for you, that when you write a paper, you should be able to cherish it. That is what I wanted to mention. So thank you so much for this opportunity. And I think I took a few more minutes. Apologies for that. Over to you, organizers. Thank you.
Thank you, Dr. Sanjay Zhodpe, for a very nice presentation, which you are known for always. So I know him from my postgraduate, undergraduate days, so I can take a liberty to say some few words more about him. So thank you very much. Over to the chairpersons.
It was a very nice presentation. I have listened to Dr. Zhodpe's presentation many times at various conferences and forums. But every time it is inspiring, because research is always a research. And every time I have been inspired by some or the other aspect of his research paper presentation. Actually, as far as the all our sexologists family is concerned, we may be having a lot of data, and I hope that they will make use of all the practical aspect that has been targeted by Dr. Zhodpe in his this speech, that will be make use of. Thank you very much, Dr. Sanjay Zhodpe.
Thank you.
Thank you.
Yeah.
So, Dr. Zhodpe, kindly accept our e-bouquet and e-memento to you.
Thank you. Such a pleasure. Thank you.
Thank you. Thank you. So, our next speaker is Dr. A.V. Ravindran. I request Dr. Ajit Chakravarti to introduce him and continue the proceedings.
Yeah. Thank you, Deshpande sir. So it is I'm very much thankful to Deshpande sir as well as for the CSEPI for giving us the opportunity to be the chair. So let me introduce one of my very close friend of mine. So Dr. A.V. Ravindran. So we both work in the medical education of Kerala. Right now he is basically medical college. He worked in various medical college, Kozhikode, Kottayam, Manjeri. Now he is in Sultanate of Oman. Is Badr al Sama, where I also worked a little earlier. So he has published 45 articles in various international and national journals, and he has done more than 100 health education articles in various health magazines. So today I introduce Dr. A.V. Ravindran and invite him to talk on the practical approach to premature ejaculation. Over to you.
You can share your presentation, Dr. Ravindran.
Yes, sir. Yes, sir. Thank you, Dr. Ajit Chakravarti, for the nice words of introduction. And I would like to thank Dr. Sanjay Deshpande sir and Venkatraman sir and all the organizers of CSEPI for giving me this opportunity to present this topic. So a very good afternoon to all. I think my slides are clear now.
Yeah, Dr. Ravindran, make it a PowerPoint show.
Yes,
Just
sir,
at
yes, sir,
the right corner, there is a one.
Yeah, I'm doing that, sir.
Yeah.
Click on slideshow and
yes, sir.
then
Yes, sir.
click on from beginning.
Sir, is it clear now?
Yes, yes.
Yeah,
Clear.
now it's clear.
Okay, very good afternoon to all. I'll be directly going to the topic proper. I'll be talking under the following headings: introduction, diagnosis, pathophysiology, and treatment options. As you all know, premature ejaculation is a common sexual problem. It affects around 20 to 30% of people. PE was reported in the medical literature years back in 1887, but the first acceptable clinical definition was proposed in 1970 by Master and Johnson. Coming to the various definitions, the inability of a man to delay ejaculation long enough for his partner to reach orgasm on 50% of intercourse attempts. This was the definition proposed by Master and Johnson. Subsequently, various professional bodies proposed a definition for premature ejaculation, and the latest ISSM definition includes it's a male sexual dysfunction characterized by ejaculation which is always or nearly always occurs prior to or within about 1 minute of vaginal penetration, most of the time in lifelong PE, or a clinically significant and bothersome reduction in latency time, often to about 3 minutes or less, that is acquired PE, and there is inability to delay ejaculation, and there is negative personal consequences such as distress. And DSM-5 define premature ejaculation as a persistent or recurrent pattern of ejaculation occurring during patterned sexual activity within approximately 1 minute following vaginal penetration or before the individual wishes. The symptom must have been present for at least 6 months and must be experienced in almost all or all occasions of sexual activity, and that cause clinically significant distress in the individual. So coming to the diagnosis of PE, the diagnosis is mainly based on the history. You will get a history of rapid ejaculation in patients with premature ejaculation and ask about the onset of symptom. Is it from the beginning of the sexual life or after some time, so that you can differentiate primary and acquired PE. So is the rapid ejaculation occurring during some special situations or not? That will help you to differentiate situational PE from global PE, and associated erectile dysfunction also has to be addressed. Whether he loses erection before ejaculation, it helps to identify PE secondary to erectile dysfunction, and also assess the partner and the patient's perception regarding the premature ejaculation, the severity and its impact on life, and the perceived degree of control over ejaculation. Also assess the medical history, like history of diabetes, hypertension, history of any intake of medicine, trauma, surgery, or any psychological aspects. Like, as you all know, psychological issues can lead to premature ejaculation, and premature ejaculation can itself lead to psychological distress. So these issues have to be addressed properly. So PE is a self-reported problem. It affects not only the patient, but also the partner. And one more important thing is it also depends on the patient's expectation and belief regarding sexual intercourse. And 30% of the men with premature ejaculation also had erectile dysfunction. The loss of erection before ejaculation helps to differentiate ED from PE. And psychological aspects also have to be considered. And there are a lot of validated questionnaires to help the clinician in diagnosing premature ejaculation. And early ejaculation we can quantify by measuring intravaginal ejaculatory latency time, or IELT, which is the time interval between vaginal penetration and intravaginal ejaculation. And the median IELT is of around 5.4 minutes. Clinical examination include general physical examination and especially abdominal and genital examination. And there we have to do the neurological examination and examination of the lower limb. And those who are having premature ejaculation associated with painful ejaculation, a rectal examination is also needed. But most of the time, the clinical examination will be within normal limits. But the clinical examination will help to reassure the patient that he is anatomically normal. So the diagnosis, as I already told, it's clinical. There are no specific investigation. Investigations are directed to find out the associated contributing factors or secondary causes. But there are a lot of neurological assessment described. These are all mainly for experimental purpose. I'm not going to the details of that. Sexual assessment monitor is a novel portable device helps in the objective measurement of ejaculatory latency time. And these are the various electrophysiological tests, which is mainly carried out in research setting. So PE is a clinical diagnosis. So to diagnose PE, there should be rapid ejaculation, that is short ejaculatory latency time, inability to control ejaculation, and associated psychological distress. These are the three components required for the diagnosis of PE. Waldinger proposed that short ejaculatory latency time for other sexual activities like masturbation, oral sex, and anal sex. But the currently proposed definition focuses only vaginal penetration, and it fails to address the other sexual activities. Coming to the pathophysiology, as you all know, ejaculation is the process by which sperms move from the epididymis via vas deferens to urethra and finally expelled out of the urethral meatus. And a normal ejaculation consists of three components, that is emission, expulsion, and orgasm. And from this table, you can see emission is mainly by the sequential contraction of accessory sexual glands, and expulsion is by the contraction of bulbocavernous and pelvic floor muscles. Coming to the pathology of premature ejaculation, it can be psychorelational issues, neurobiological, urological like prostatic issues, hormonal or andrological like associated with the erectile dysfunction. So oversensitive genital skin, hyperreactive reflexes, genetics, different performance anxiety, and psychological issue, all are described as contributing factors. In patients with psychogenic PE, the causes can be divided into three groups, which belongs to different phases of time, like immediate factors like performance anxiety, antecedent life events from the recent history, developmental vulnerabilities from childhood or adolescence. Coming to the neurobiological issues, as we all know, serotonin inhibits ejaculatory reflex, leading to prolonged ejaculation latency time. So low serotonin level shorten the time to ejaculation, leading to premature ejaculation, and serotonin agonists delay ejaculation. So primary PE is mainly triggered by psychological issues. Secondary PE is diabetes, hypertension, hyperthyroidism. All these can precipitate secondary PE. Coming to the classification, depending upon the time of onset, as I already discussed, it is divided into primary and secondary. The other two classification added later include natural PE or variable PE and subjective PE. Coming to different types of PE, lifelong PE, it's mainly because of the genetic issues, acquired PE due to psychological issues, sexual issues, medical problems, and natural variable PE due to normal variance of sexual performance, and subjective PE is due to patients on concept regarding ejaculation. And in lifelong PE, usually ejaculatory latency time is less than 1 minute. In acquired PE, it's less than 3 minutes. And natural PE or variable PE, it can be sometimes short or normal. And in subjective, it can be normal or even longer. So these are the different types of premature ejaculation. Premature ejaculation is again also classified into generalized and situational. Generalized is not limited to any specific types of stimulation, situation, or partners, and situationally when it is related to specific types. For research purposes, researchers are divided into 4 groups. Premature ejaculation is divided into 4 groups. That is group 1, where there is penile hyperexcitability. Group 2, where there is sympathetic hyperexcitability. In group 1, the local anesthetic agents work better. And group 2, the serotonin agonists or SSRIs work better. And group 3 is the mixed type. And group 4 is others where all these parameters are normal. Coming to the differential diagnosis of premature ejaculation, before diagnosing, always consider adverse effects of psychotropic drugs. Another important factor we have to consider is the sexual history from the female partner. Severely delayed orgasm in female partner can lead to misdiagnosis of premature ejaculation in male partner. Similarly, vaginismus can also misdiagnose as premature ejaculation, especially in severe premature ejaculation where ejaculation occurs prior to vaginal penetration. It can be confused with vaginismus. So proper history is important. What are the complications of premature ejaculation? There will be difficulty in conceiving if the ejaculation does not occur intravaginally. And as we already discussed, it can lead to a lot of psychological issues, depression, anxiety, etc. Coming to the treatment of premature ejaculation, the treatment can be broadly divided into non-pharmacological treatment and pharmacological treatment. Non-pharmacological treatment include psychosexual counseling, psychotherapy, various relaxation techniques, pre-coital masturbation, start and squeeze technique, use of multiple condoms, pelvic floor exercise, extended foreplay, alternative sex position, interval sex, increasing frequency, and other methods like acupuncture, yoga, etc. The pharmacological agents include topical anesthetic cream, various drugs like tricyclic antidepressants, SSRIs, tramadol, and dapagliflozin is the newer drug added to the armamentarium of treatment of premature ejaculation. The emerging treatment include dorsal penile nerve cryoablation therapy, neuromodulation, hyaluronic acid gel glands augmentation, botulinum toxin injection, etc. So coming to the individual drugs, because of the time constraints, I'm not going to the individual drugs. Topical anesthetic agents, it increases the IELT around 4 to 6 times, and tramadol 4 to 7.3 times. Tricyclic antidepressants, SSRI, and dapagliflozin is the newer addition to this armamentarium, and it is found to be very effective in patients with both acquired and lifelong premature ejaculation. Phosphodiesterase inhibitors and alpha blockers are also tried in patients with premature ejaculation. Phosphodiesterase inhibitors are especially important in those who are having combined problem like erectile dysfunction and premature ejaculation. Coming to the practical approach to premature ejaculation. In a patient with history of early ejaculation, ask the detailed history of sexual dysfunction in the partner. And if that is present, the problem can be delayed orgasm in female partner or vaginismus. If there is nothing, ask for associated erectile dysfunction. If that is present, it shows that PE is secondary to erectile dysfunction. And if that is also not there, take a detailed history, assess the severity, ask for the medical and other psychosocial history, do relevant clinical examination. And if IELT is normal or short, it can be variable PE. If normal or long, it can be subjective PE. And if it is short, we have to see the onset of symptom, or the if it beginning from the if it started from the beginning of sexual life or not. So in variable PE, the ejaculatory control is diminished or lacking, and there will be irregular or inconsistent premature ejaculation. Reassurance, behavioral therapy, education, and psychotherapy are the major treatment modalities. In people with subjective PE, Again, ejaculatory control may be diminished, and there is self-perception of rapid ejaculation. Reassurance and psychotherapy are the major modalities of treatment. In those with short IELT, we have to see if it started from the beginning of the life or later. If it is not present from the beginning of sexual life, it is acquired PE. In that case, we have to look for secondary causes. If secondary causes are there, treat the secondary cause. If secondary causes are not there, pharmacotherapy, psychotherapy, and behavioral therapy. And after 6 to 8 weeks, we can try gradual withdrawal of pharmacotherapy. But those who are having sexual, means premature ejaculation from the beginning of their sexual life, psychotherapy and pharmacotherapy are a treatment option. And we can attempt withdrawal in 6 to 8 weeks, but most of the patients may require lifelong treatment in patients with lifelong, or primary premature ejaculation. Coming to the prognosis, various data shows that the success rate is very high, more than 85% with behavioral therapy and pharmacological therapy. But the relapse rate is also high. In patients with lifelong PE, the IELT will return to the pre-treatment level within 1 to 3 weeks after stopping the medicines. But in patients with acquired PE, the treatment of precipitating factors improve IELT even after stopping the medicines like dapagliflozin. So to conclude, premature ejaculation is a common sexual problem. Pathophysiological mechanisms are complex. Diagnosis is mainly by clinical. Behavioral techniques and psychotherapy have been the main modes of therapy for years. Topical anesthetic creams, SSRIs are the main treatment modalities available for years, and development of newer drugs like dapagliflozin have promising role in the management of PE. Thank you for your patient listening.
Thank you, Dr. Ravindran. So it was a very detailed and brilliant speech. So premature ejaculation, as such, is a very common sexual problem. And when it comes to the basic issue in the premature ejaculation is the partner satisfaction. So that is ultimately, so along with the premature ejaculation, it is very necessary to assess the female partner about their orgasm. Regarding that is very, very important. So, premature ejaculation, just diagnosing based on the male perspective alone will not be useful in actually curing the problem. Thank you so much. It is a very detailed and talk. Thank you again, Dr.
Thank you, Dr. Ravindran, for a very nice talk. And I know you are a true researcher doing a lot of research. In fact, I remember we also have one paper together on role of yoga on premature ejaculation. So continue this good work of research in sexual medicine. Yeah, all the best wishes, and kindly accept our e-floral bouquet and the e-memento. Thank you.
Sir. Thank you very much.
So we'll move on to the next topic. Again, Dr. Ajit, I think both the speakers are from Kerala. So introduce Dr. Sam P. Abraham.
Yes, thank you, sir. So let me introduce the next speaker, who is I can say he is very near to my place. He is from Changanaiseri. So let me introduce Dr. Sam P. Abraham. He is a state rank holder in SSLC examination and did pre-degree from SB College, and he has a 15 years experience in treating infertile couple and pioneered in laparoscopy, hysteroscopy, sperm banking, doing aspiration, IVF, ICSI. So he has presented papers in infertility and gynecology in state and national conferences. Participated as faculty in endoscopic and ultrasound workshops, and Millennium Excellent Award for Excellence in Work, and so again Adurva Seva Award for Patient Care. So sexual problems is a very common issue in male infertility. So I invite Dr. Sampi Abraham to talk on the male infertility and sexual problem topic. Over to you, sir.
Thank you, Dr. Ajit Chakravarti. I'm grateful to Dr. Venkat Ramana and other office bearers of CSEPI for giving me a chance to present on this occasion.
I will stop sharing, so then you will be able to share the screen. Yeah, now you can share the screen.
Yeah. Now, here I am to deal with male infertility and sexual problems. We know that infertility affects about 12% of all men, and sexual dysfunction occurs frequently in men of reproductive age. So, it causes infertility in some cases. So, what are the problems with infertile men in relation to sexual problems? They face two major problems. One is they have got a hyperactive sexual desire, and there is a lack of sexual satisfaction. So we know that already they are coupled with that they don't have a child. Along with, once there is an hyperactive sexual desire and a lack of sexual satisfaction, we can know that their quality of life comes down. So the commonest problem they face is two problems. One is erectile dysfunction and premature ejaculation. We have to understand that 1 in 6 infertile men is having this problem, and orgasmic dysfunction has a prevalence of 1 in 10. So this is a very high incidence. Erectile dysfunction, premature ejaculation, 1 in 6 persons with infertility are having that problem, and orgasmic dysfunction, 1 in 10 infertile men, that makes their life more horrible. We know that they have an heavy psychological burden. Why? Because infertility and there is associated psychological concerns can underlie sexual dysfunction. So they can have general health problems leading to male infertility and sexual dysfunction. So it could be that the sexual dysfunction is a part of their general health problem, which leads to male infertility and sexual dysfunction. So erectile dysfunction and male infertility are considered proxies of general health. So erectile dysfunction could be that they may have an underlying cardiovascular problem. A person with a male infertility can have a cancerous or a non-cancerous condition. What I will make it more clear. Certain conditions of severe oligospermia, they may have some associated testicular precancerous lesion. So we have to be very clear that erectile dysfunction in an infertile man is an early marker of poor general health. So medications used for general health problems can cause form abnormalities and sexual dysfunction. So both ways they are related. So treatment of some causes of male infertility might improve semen quality and reverse the infertility-related sexual dysfunction. So treatment of male infertility alone may improve their sexual problems to a certain extent. So what I mean to say is that in an infertile man, you should have an investigation of sexual, general, psychological health status to improve the reproductive problems and general health. So infertility affects about 12% of all men, and sexual dysfunction occurs more frequently in men of reproductive age, causing infertility in some instances. So we know that infertility affects about 12% of all men, and sexual dysfunction occurs more frequently in men of reproductive age. So they have an heavy psychological burden. Infertility and its associated psychological concerns can underlie sexual dysfunction. So infertility alone can lead to sexual dysfunction because they are under a heavy psychological burden. And I already told general health problems I have already cleared. So what I mean to say is that a person with male infertility should have an investigation of sexual, general, and psychological health status, which a busy infertility practitioners may not be able to provide. So all infertile men, you should take few minutes to investigate about their sexual, general, and psychological aspects which helps to improve their reproductive problem and general health. So interaction between infertility and sexual problems are numerous and they are very complex. Infertile men may suffer from sexual dysfunction when undergoing an assisted reproductive technology program. The sexual health is directly associated with the psychological well-being and quality life of each individual. This has been our mind of every infertility practitioner. Because why the patient wants? Because you are always concerned about the psychological well-being and quality of life of each individual. Once the sexual health is defective, the psychological well-being and quality of life of individual comes down. So sexuality is inherent to human beings and is intimately related to their reproduction. So there is always an interconnection between the unfulfilled desire for a child and sexual disorders which can be observed in infertile couples. Indeed, sexual intercourse itself will be less spontaneous. Why? Because you are asking them to have relations during the fertile window period. So there is no recreational and erotic activities. It is only for procreation. So sexual intercourse for many men, it becomes an obligatory, it becomes repetitive, it becomes mechanical. They have got very few emotional components in their sexual life. So interaction between infertility and sexuality are complex. Organic causes of sexual dysfunction are not the main cause of male infertility. The organic cause of sexual dysfunction may be the cause of infertility only in 5% of cases. Erectile dysfunction and ejaculatory disorders are associated with increasing difficulty in conceiving. The classical picture of sex for reproduction and non-conceptual sex will be withdrawn. So medical procedures and requirements always alter the sexual behavior and sexual intimacy. So medical terms can be perceived as hostile. It causes anxiety in infertile men, which could ultimately lead to temporary sexual dysfunction. Infertility is, we know that infertility in the general population is considered as a loss of masculinity and virility and may suffer from a feeling of low esteem and depression in infertile men. The necessity to identify sexual dysfunction and their severity is crucial before getting to an individual infertility treatment. This is something I want to tell every infertility practitioner because we have to identify whether an underlying sexual dysfunction is there in every male infertility patient. Sexological and psychological consultation should be seriously considered during the diagnostic and therapeutic phases. So you know that azoospermia is a very mind-blowing thing. One of the worst news they can receive in their lifetime, like having a cancer, it's like that. Now you tell the couple that you are azoospermic. So it can be obstructive or non-obstructive. In obstructive, as we know, spermatozoa are produced but not delivered. In non-obstructive, it is not produced at all. Obstructive azoospermia could be congenital, where there is an absence of wasp, or it could be an idiopathic epididymal obstruction, or it could be an acquired infection. It could be from vasectomy or other iatrogenic injuries to the male tract. So you know that we all know that infertile men will be stigmatized because they are perceived as being deficient in a specific component of their masculinity. So it is great interest to detect these issues. They can be tackled with appropriate therapy like sexological and psychological management. So they have a doubt about their fertility. Emotions trying to conceive can be more challenging than the treatment for infertility alone. So they have got difficulties than women to enter the ART process because they feel that it is a loss of virility and masculinity. So they don't want ART techniques. They think that ART techniques, once they take, the society may say that this man was defective and they conceived with ART, which they don't want to hear. So they are reluctant to talk about their fertility issues than women do. So during the ART process, medical team expectations, medical investigations, and the female expectations can lead to sexual dysfunction because the medical team says you bring this sample, which you may not be able to produce. He says the sample is not good, and investigation, semen analysis, and hormone analysis, which tell that his male component is defective, is challenging, and the female wants pregnancy results to be soon, or if she wants the results of the semen parameters to be improved soon, which can lead to sexual dysfunction in the man. As a part of infertility workup, patient will have to produce semen sample in the laboratory. Producing semen sample in the IVF clinic is stressful because on demand it is something that could not be given like that. So they may get problems in erection because of situational problems. and trying
Sir,
to
just to interrupt, sir, do you have slides to share or?
No, I'm sharing the slides, Dr. Chakravarti.
Sir, it is not seen. So I think.
We can't see the slide.
Okay, sorry. I thought it was shared.
Yeah.
Can you see?
Yes, yes, sir. It is.
Masturbation is common in all societies. So you know that there are certain religious which consider it as an immorality. So masturbation will be perceived differently by individuals according to their cultural and religious belonging. So on masturbation to get the semen sample itself can be distressing to the couple. So the impact of cultural myths associated with masturbation can lead to masturbatory guilt when they are undergoing ART. So conflation with fertility, potency, masculinity has consequence for infertile men. Fathering a child, as we know, is a proof of masculinity, and in consequence, not fathering is a failure of masculinity. Therefore, infertile men have that stigma with them. Sexual dysfunction is a rare cause of male. It has been shown that in fertile population, interconnection between virility and fertility exists. So high prevalence of erectile dysfunction in male compared to infertile people. So they may have feel a temporary impotency when diagnosed with azoospermia. So non-obstetric azoospermia, you can have semen samples from the testes. So they may face premature ejaculation, which has been detailedly evaluated just now. So it is more common in infertile men compared to general population. So psychogenic anejaculation could be observed in these patients. They may have failure to get orgasm, so they say they don't get semen samples. They have got orgasmic dysfunction. So sexual desire disorder will be low in them because their intravaginal ejaculation time may be either early or they may not ejaculate at all. These extremes could be seen. So the treatments and medical requirements leading with infertility for the inhibition of sexual desire. So sex is something that, so what happens? It becomes impersonal. It is driven by medical procedure. So they feel low libido and sexual dissatisfaction, which causes further problems in them. So association between sexual dysfunction and psychological burden is reported in many studies. They feel impotency following their diagnosis of azoospermia. So ICSI has enabled many azoospermic men to become a biological father, but which leads to a sense of redress after the previous feeling of inadequacy. So a literature on the sexual dysfunction in non-obstetric azoospermia related to genetic abnormalities led to publications on Klinefelter syndrome. Hyperactive sexual disorder, eventually present in Klinefelter subjects, is related to the testosterone deficiency than due to a genetic abnormality. For example, in Klinefelter, they have low testicular volume, so their testosterone is defective. That also could lead to their sexual dysfunction.
Sir, last 2 minutes, please.
Pardon?
Sir, last 2 minutes, please.
Last minute?
Yeah.
Yeah. So what I mean to say is that it could be very useful to evaluate sexual health in all infertile patients and refer them to a specific medical provider. The global management through a health network where a biologist, andrologist, and sexologist and psychologist will allow us to consider infertility and its subsequent sexual disorders as a whole matter. So practically, my advice to every infertility specialist that you may be very busy with your own work, but make it a point to go to their psychological and sexual health. That is going to carry a long way in the management of the patient, where you are able to improve the psychological well-being of the patient. Thank you.
Thank you, sir, for an excellent and informative lecture. So I request you kindly stop your screen sharing. Thank you, sir.
Thank you.
Over to chairpersons, please.
Yeah. Thank you, Sam sir. So it was a very excellent presentation. So the sexual problems that can lead to infertility, that is connected to infertility. So to get pregnant, getting pregnant, you need to deposit sperms inside the vagina. So the sexual dysfunctions can lead to cause problems in that. That was a very very excellent presentation. Thank you so much for the very important presentation.
Thank you, Dr. Shivaji. Thank you.
So thanks to Dr. Sam Ibrahim for an excellent lecture. So on behalf of organizing committee, kindly accept our e-book as well as e-memento.
Thank you, sir. Thank you.
Thank you. And thanks to both the chairpersons, Dr. Ajit Chakravarti as well as Dr. Arvind Athawale, sir, for managing the session in a very professional manner. Thank you. Thank you, sir.
Thank you. Thank you.
So now we move on to the next agenda. There will be 3 lectures: the IT mantra for sexual dysfunction, why people enjoy sex, as well as sex and obesity. And I request Dr. Yera Nageshwar Rao as well as Dr. Sudhakar Babu to kindly chair the session. So over to the chairpersons, please. Dr. Nageshwar Rao sir and Dr. Sudhakar Babu sir. What is it?
Dr. Sudhakar Babu, are you there?
Sorry, unmuted. Yeah. Thank you
Sir.
for this opportunity, Dr. Sanjay Deshpande and other team members, Dr. Venkatramana. So I would like to congratulate the organizing team for selecting beautiful topics, very rare topics discussed, these 3 topics, rather they're pearls of the problems of the day today. So Dr. DVR Pusha is known to me. He has been backbone and some of the conferences, especially Vizag conference where I met him. Through him only we reached that registration, this thing process. So he is known to me very well. He has been the editor of Abhisarika, and which was a very popular magazine, and innovative methods were adopted by him. Local areas in and around the sculptures were discovered, and then they were published, and a lot of literature has been collected, and he propagated the knowledge. He is a consultant in psychosexual medicine, and apart from being sexologist and counselor and sex therapist, he is practicing at Samarlakota near Kakinada and also Hyderabad since 1990, along with the footsteps of his parents. The pioneer community sex educators, Ramsha and Sirisha. The editor has been since 1949, this Sexology magazine in Telugu language he has been publishing. He is also a PhD holder in human genetics from Andhra University, Andhra Pradesh. Published several research papers in international journals, and is a life member fellow of CSEPI and AASECT. So now I request him to present, go ahead with the presentation. The floor is all yours, sir. Dr. Pusha, sir.
Can I share my screen? Yeah. Good evening, one and all, and thank you very much for this opportunity, especially to the chairman, Dr. Sanjay, and the scientific committee. And respected dignitaries, before we talk about anything about this IT mantra and sexual dysfunction, it's probably worthwhile. Yeah, it's worthwhile discussing how the understanding about sexual difficulties has evolved over the last 1.25 centuries, and what knowledge we have gained and how it has influenced our thinking about the resolution and treatment of these sexual difficulties, and how much of the knowledge we have absorbed and incorporated into our therapy systems. If we take the beginning of 20th century, it has entire 20th century has witnessed huge strides in our knowledge of sexual difficulties. Obviously, treatment modalities were developed based on whatever understanding we have from that knowledge. And early 20th century is one part. Up to the time of Kinsey and Masters and Johnson, that is about 1950, we can treat this as a pre-sex therapy era or psychoanalytic era. And from 1950 to 1998, we can call this as a pre-Viagra era, which has changed a lot. And then up to from 1998 onwards, it is a post-Viagra era. Let's call it that way. And in the early 20th century, the root of sexual problems were attributed to deep-seated anxiety and internal conflict by Sigmund Freud. Sexual problems are the result of guilt and unconscious anxiety. Many neuroses also were attributed to these unresolved internal sexual conflicts. Therefore, the treatment consisted of the ruling therapeutic process at that time, that is psychoanalysis, to get to those depths and discover the conflicts. An understanding of the root cause was perceived to resolve the conflict and therefore the sexual problem, resolve the sexual problem. And then came the era, then came the time of Alfred Kinsey, who has published a massive findings on the human sexual behavior in the male and female, and it was both a sensation and a commotion at that time. And probably it also created an environment for further research, which was rightly grabbed by Masters and Johnson, who had done physiological experiments at that time. And they have formulated what is called normal human sexual response, consisting of excitement, plateau, orgasm, and resolution phases. Deviations from any one or more of these stages was considered a sexual dysfunction. Masters and Johnson wrote a book on, called Human Sexual Inadequacy, which described sexual disorders based on the normal sexual response cycle, and also described the way of treating those disorders. And this has essentially created the new field of sex therapy. The Masters and Johnson sex therapy model was a brief behaviorally oriented couples therapy with a strong educational component. Individual, interpersonal, contextual factors were taken into consideration during the therapy. The sex therapy model primarily works with couples, and Masters and Johnson observed that no such thing as uninvolved partner in a sexual dysfunction in a committed relationship. So therefore, they insisted that even for the sexual dysfunction of a male or a female, both the partners should be present. So the partner may or may not be the cause, but obviously they are affected. And Masters and Johnson model also consisted of another concept called the male and female co-therapy team, so that the patient couple will build confidence and the couple therapy team will receive cooperation from both. And also the therapeutic team will be able to demonstrate effective communication skills to both of the couple in the therapy. The therapy is individualized. It is tailor-made to every single couple, taking into the account the values and objectives of the couple. The other features of this model included that the fear of performance and spectating are considered central to the sexual dysfunctions. A prescription of sensate-focused home exercises were given to work in a non-demanding environment so that the anxiety is resolved. So pressures to perform are removed by banning direct sexual contact initially, and so on and so forth. The Masters and Johnson model, its disadvantage is that it is they have viewed it as a biological model. So sex is viewed as a biological function as much as urination or defecation or respiration. The sex therapy aimed at alleviating psychologically imposed obstacles like ignorance, fear, anxiety, guilt, shame, etc. If they are alleviated, then the natural biological functioning will automatically be restored. That was the premise. And thus, here in this case, in this sex therapy model, the presenting sexual complaint was directly attacked and targeted by modifying maladaptive sexual behaviors. It rather did not delve into the deep-rooted causes as in the past era of psychoanalysis. Interestingly, there is no active effort to change the attitude or sexual value system of the client. A change in the behavior is expected to bring a change in the attitudes and emotions. And Masterson Johnson stated that 90% of sexual problems are of psychogenic etiology and only 10% organic. Masterson Johnson's sex therapy model caught up with the sexology community very fast. For the next 2 decades or so, it has been the mainstay of sexual disorders treatment. So it not only formed the foundation for numerous treatment models that developed later, but also formed the basis for the DSM's classification of sexual dysfunctions. Next came Helen Singer Kaplan, a psychoanalyst and psychiatrist. Her new sex therapy model incorporated both behavioral strategies of Masters and Johnson that were meant for the couple, and also she included the resolution of deeper causes of sexual dysfunction such as guilt, past sexual trauma, and other any deep causes of anxiety, which were the hypothesis of the Freudian times. So for this, she has engaged in individual therapy for the person concerned within the couple. And later on, lots of adjuvants came up. Behavior therapy and cognitive restructuring was introduced. And as we heard yesterday's Dr. Barry McCarthy's speech, his biopsychosocial model was initially primed. It was started with the cognitive behavioral therapy or CBT. And this model CBT was adopted by Gagnon, Sandra Lieblum and Rosen, Barry McCarthy, Wingsy and Carey and such other people have used this model to resolve sexual dysfunctions. And then the most popular Jack Annan's model, which we all be using knowingly or unknowingly. And it consists of permission, limited information, specific suggestions. These three aspects consist of a brief therapy for any sexual dysfunction initially. And if these are not resolved by any of these 3 methods, then the couple will be put into intensive therapy. So this part, most of the clinicians will be doing along with pharmacotherapy these days. Okay, intensive therapeutic models from psychotherapy also emerged parallelly during the 1960s, 70s. And rational emotive therapy, for example, by, I forgot its name, rational emotive therapy, humanistic sex therapy, systemic
Albert Ellis.
Yes, Albert. Yeah, thank you, Albert Ellis. Rational emotive therapy by Albert Ellis, humanistic sex therapy, systemic sex therapy, existential or experiential sex therapy, somatic experiential or gestalt therapy, emotionally focused therapy by Stu Johnson of Canada, solution-centered therapy, and so on and so forth. Women's group therapy by Lonnie Barbach for anorgasmia in women. So lots of psychologically oriented models were built up, and these were addressing the intrapsychic and interpersonal and emotional aspects of the sexual interrelations, which will be causing or perpetuating or even precipitating the sexual dysfunctions. Later, during the 1980s, a lot of medicalization has taken place. There was a progress, because of the understanding that is increasing about the cause of the sexual dysfunctions, the medical modalities were introduced. There was a progressive shift towards surgical and predominantly pharmaceutical treatments. Initially, this was called the biomedical approach. So surgical therapy, for example, consisted of penile implants, vascular surgeries for venous leakage and arterial insufficiency. And then there were mechanical devices for erection, for example, vacuum erection devices, VEDs, and Eros CTD for clitoral stimulation, and dildos, etc. And then pharmacological agents also came into picture, and they dominated for about a decade or more. Vasoactive agents like papaverine, phentolamine, and PG are a trimix of them for erectile dysfunction. Alprostadil through medicated urethral system for erection, that is Muse, testosterone and bromocriptine therapy for hypoactive sexual desire disorder, SSRIs for premature ejaculation, and many more medicines that are sublingual epimorphine or pibenserin for female desire disorder, so on and so forth. So the entire decade was almost dominated by these medicines and also vasoactive agents. Then finally, in 1998, came this Viagra. With the advent of Viagra, the change in the entire landscape of PD treatment took place. 90% of erectile dysfunction cases are now treated with PDE5 inhibitors. SSRIs stopped the stop-start technique and squeezed the behavior methods out of the PE management regimen. Other off-label medications for male and female sexual problems increased. Pharmacotherapy took the front seat. With availability of newer diagnostic tools, urologists claim that 90% of sexual problems are organic. During the 1990s, the dominance was by the urologists and their theories. And later on, in the current 1 or 2 decades, we have been seeing other newer techniques like platelet-rich plasma infusion, genetic engineering techniques, the stem cell therapy, shockwave therapy, and so on and so forth. Ultimately, the past 20 years or so, sex therapy, even by from 1980s onwards, sex therapy started taking backseat, and now it is totally confined to the backseat. But what surprised many, however, was the large percentage of patients who discontinued pharmacotherapy, a phenomenon not easily explained by the robust efficacy and safety of these interventions. This was said by Stanley Althoff. What could be the reasons? Probably pharmacotherapy alters the sexual script, as per Barry McCarthy. The patterns of lovemaking are disrupted. For example, who initiates sex and at what time, these were depending on the therapeutic options. There was a window of opportunity issue. For example, shorter windows increase pressure to perform. For example, sildenafil has a window of about 2.5 to 3 hours, versus the tadalafil, which has about 36 hours of window of opportunity. So depending on that, the couple were under pressure to have sexual sexual intercourse during that window, and this has created additional anxiety. And topical anesthetic creams in the case of PE also of the same kind. So partners and patients may be concerned about health hazards of medication and monitor their physical reactions than focusing on their own sensations or pleasure. This was one problem with pharmacotherapy. Partners may resent men using medications. Many complain of mechanical sexual activity devoid of love and caring. Sometimes pharmacological agents may negatively alter the couple equilibrium. For example, a patient on PDE5 inhibitor became sexually more demanding, to which the wife objected. The patient started insisting on wife taking medication to match his desire. These are observations by Barry McCarthy. And patients and clinicians naively hoped that robust efficacy of these compounds will resolve the concerned sexual dysfunction in toto. But this has not happened. These sildenafil, vardenafil, tadalafil, whatever the fills may have filled the cavernous tissues, but they failed to address the emotional issues. That's why there were lots of relapses of the conditions. And there were also a lot of disappointment with the patients, and there was a lot of high percentage of discontinuance. SSRIs, for example, were discontinued by patients despite 6 to 8-fold increase in the intravaginal ejaculatory latency time on a long-term use. 60% men discontinued intracavernous injections or vacuum erection devices because of fear, pain, side effects, or because they look like artificial things. 50% dropped out of PDE5 therapy despite robust efficiency and extreme simplicity of use. This is probably because of actual or perceived side effects, or perceived fear of dependency, unrealistic expectations of the patient, partner needing progressively increasing doses, or partner being viewed as drug dependent. Several studies corroborated these deficits in the pharmacotherapy-only approaches and stressed the need to incorporate modalities addressing other factors like psychological, socio-cultural, relational, and contextual. So there was a need to return to some form of sex therapy. This has become more and more evident as the pharmacological interventions are only working temporarily, and there was a relapse of the symptoms or the relapse of the condition. So Melnick and Abdo in 2005 observed that patients receiving psychotherapy plus sildenafil achieved statistically significant improvement over sildenafil-only group of patients. Similarly, Phelps and others have observed that patients on sildenafil plus one session of psychoeducation exhibited greater treatment satisfaction over sildenafil-only group. Similarly, Lotman et al. Compared men receiving ICI, that is intracavernosal injection, plus 3 counseling sessions with ICI-only group. And at the end of 6 months, 60% of the ICI-only group discontinued the therapy, while no one dropped out of the group receiving counseling also. So similar findings with vacuum erection therapy were also reported by Wiley et al. 84% satisfied with 85% versus 60% improvement. Similarly, relapse of the presenting problems is very common in pharmacotherapy. Such studies suggest that combining therapy models incorporating psychosocial factors with the medical treatments improves sexual dysfunction substantially. Psychologically based therapies are now staging a comeback. For example, take the case of a 54-year-old man who is a married one with a presenting complaint of erectile dysfunction. He suffers from type 2 diabetes, hypertension, and obesity and requires 5 medications for his medical problems. He reports poor morning erections and weak erections with masturbation and foreplay. No intercourse for the past 8 months. His sexual interest has decreased. In this case, it is easy to observe and explain that the predisposing and precipitating. In 1 minute, I can do that. 1.5 minutes.
Sir, last 2 minutes, sir. Please.
Yeah, thank you. Thank you. And precipitating factors for the ED are entirely medical, namely diabetes, hypertension, hyperlipidemia, and even possibly his medications also. However, what is not taken into consideration is his mood, attitude, motivation to resume sexual life, level of performance anxiety, preoccupation with the symptom, expectations and fears of treatment, quality of his interpersonal relationship, as well as degree of his partner's interest in resuming a sexual life, her health status, the couple's interval of abstinence, life stresses, so on, so on, so on. So simply giving an erectogenic drug without considering the impact of all these and similar factors may be insufficient to overcome the amalgam of medical and psychosocial obstacles and for the relapse prevention. So my friends, to sum up, neither psychological therapy nor pharmacotherapy can be undermined their respective roles, but alone they can achieve a little, but together they create a synergistic result. The psychosocial therapy is crucial in even the 100% organic cases of sexual dysfunctions because there is a mind behind every body and every human being is continuously influenced by several mutually overlapping systems around him. Therefore, an integrated therapy or IT incorporating biomedical, psychological and social factors is the mantra for resolution and relapse prevention of sexual dysfunctions. This may call for collaboration with experts from different disciplines, including clinical psychology and social work. I think it is imperative for the CSEPI to invite family therapists, couple therapists, and other psychologically oriented therapists to educate us on these aspects and to be educated in turn by them on sexual aspects. So with these couple of remarks, I concluded and thank you very much for this opportunity.
Thank you, Dr. Pusha. It was especially, you touched all the literature and divided into 3 parts, and your IT technique is really taken up well. Once again, I thank you for your beautiful presentation.
Sir, hello. Requesting Dr. Pusha sir to kindly please minimize your or close your screen sharing.
Okay. I think I have stopped sharing my screen.
Yes, thank you, sir. Thank you, sir.
Speaker is Dr. Prasanna Gadre. Yeah, welcome.
Yeah.
Sir, please accept the bouquet and the e-movement.
Thank you. Thank you very much. I'm honored.
On behalf of the organizing committee. Thank you. Yeah. Dr. Prasanna Gadre is MBBS, DVD, DNB family medicine. He has got 27 years of practice of sexual medicine, aesthetic medicine, and counseling psychology. Clinical observership in genitourinary medicine and teledermatology in UK and USA. Authored 3 books on skin sexology. 1 book on how parents should talk to kids as regards to sex and sexuality, which has received copyright by Ministry of Intellectual Property Rights and HR Parliament of India. Congratulations. Maximum Hints hits for podcast Sex War Bol Bindast on Swedish podcast company Story Tell app, and devised a channel and an app on sexual topics on YouTube and Go. Once again, congratulations. You've got a lot of IT technology adapted to our sexuality. So please go ahead.
Thank you.
What is
Yes. Okay. I'm sharing my talk. Yeah. Able to see?
Yeah. Yeah. Very
okay. Yeah, so I'm integrating my presentation with the theme of our conference, and that is integrate is to handle with care and unite to make whole. And actually the word comes from integer, that is tangere and touch deals with skin and definitely with sex. And the etymological meaning and origin of the word enjoy in French is to take pleasure, delight, and rejoice. And in Latin, it makes the sense of making use or taking benefit. And these two things would be having bearing on my future slides. So why people enjoy sex? The through line of integration is to know the intent as to why one enjoys sex and integrate that with the therapy which we offer to the sex client patients. So why do people enjoy sex when they are doing the sex and whatever they are doing in the sex? And to integrate the chain, I would say that the motivations or the intentions of enjoyment of the sex would lead to the sex choices, which would lead to the acts of enjoyment, and every act has obviously consequence. And in today's world, we should not prescribe, or rather we should have a descriptive approach rather than prescriptive approach for our patients. And at each point in the chain, we can introduce the remedial measure or the therapy. Say, for example, to eliminate and minimize the consequences, that is the sexually transmitted diseases, we can offer condom or ask them to modify the act, that is have a non-penetrative sex in case of multiple partners, undo or totally stop the smoking for erectile dysfunction, change the choice, have alternative, just like women on top position during premature ejaculation, and sex during the second trimester of pregnancy, and of course dispute or question the basic intention of enjoyment, where certain males have in their mind, or they equate that to express their chauvinism and maleness, they would like to have sex with n number of women. So 100 people, folks or patients were subjected directly to this question, okay, as to why they want to enjoy the sex. And after they answered on their own, they were subjected to 50 different words or choices, which form the 11 families, which I will tell you eventually, and ultimately the two fundamental groups as to why people enjoy sex. And they are sex as an end in itself, where people enjoy, where the sex is the ultimate goal or a destination or final station or terminus, and sex as a means to an end, where they are actually using the sex as a process or a journey to enjoy some different goal. So what are they? So in people who enjoy sex, where sex is end in itself, they would like to enjoy the sex itself or its attributes, say for example, togetherness, nudity, seeing each other's body and having that ultimate santosh, trupti or orgasm. While in case of people who are using sex as a means to an end, they are having hidden agendas, ulterior motives, and they are actually not enjoying the sex per se, but they are enjoying the benefits, advantages, or the payoffs which they get after the act of sex. So these two are the broad classification with the 8 families. On the left-hand side, the E group, sex to be enjoyed as an end in itself, sexual, psychosexual, emotive, social, cognitive. So where enjoyment was in the French scenario, and the M group, or in the Latin way, biological, somatic, psychosomatic, social, psychosocial, financial, and historical, political, and others. So every group I will now also tell what is the therapy. Yeah. So let's start. So this was the questionnaire, the 50 words. On the left-hand side, again, sex as an end in itself. Art, just like we are having art for the sake of art, these people enjoyed the sex for the sake of sex and used to get sex high and nothing else. So they were desirous only of sex. while in people of enjoying sex as a means to an end, actually they were overusing, misusing, or abusing that act, okay, for altogether different purpose. So blue color and red color, that is what we are supposed to remember. So the red color, so some people enjoy it as a curiosity for, say, premarital individuals. Some people are deprived of sex. Example, they are geographically separated, or their partner is not willing to have sex. So they are having reduced sex anger, and that's why they are enjoying. For high eagerness index, people become promiscuous, and sometimes people get stimulated by seeing porn or erotic scene. And in case of sexual dating sites or utilitarian approach, they offer sex to each other. Now, sex, again, enjoyed as an end in itself with these causes. Sometimes they want to have a stint, okay? Or they enjoy the aspects like nudity, touch, togetherness, intimacy, love, recreation, pleasure, sensuousness. Many a times it also acts as a self-esteem booster, feeling loved by the partner or endorsement of love. माने ये अगर किया तो माने अगर ये सब किया तो बहुत अच्छा प्यार हम महसूस कर सकोगे और आजमाएंगे. Then boosting of the mood and definitely to fight depression and having adventure or thrill. You are able to see the slide, na?
Yeah.
Yes. Yeah. So in case of depression, sometimes people are having diabetes and blood pressure just because their sexual life is totally has gone to doldrums, okay? And we should ask that. And sometimes it can lead to many sexual problems, as we know. And of course, for adventure and thrill, okay? Then variety and novelty seekers of positions of partners for aesthetic setups they want, right from bathroom and kitchen to the field, okay, and farms. Then they want to enjoy it for the romance and foreplay, stress, tension, I told you, experimentation, especially in premarital people, whether they are able to get the erections, whether they would be able to satisfy their partner, so on and so forth. And also for self-expression. Just like we are having different talents and art, say for example, dancing or painting, where we are expressing through our art. Similarly, some people want to express themselves through the act of sex. And for them, what should we counsel is, as the legal, medical, social, and the marital consequences, ask them to have safety precautions, and they can use different outlets of expression like sublimation, which Freud has told. And of course, since they could be having, if they are having multiple partners, then they should go for mutual masturbation, non-penetrative sex, sexual toys, and of course, sexual hygiene protection, and protect them from STD. Now coming to the people who enjoy sex as a means to an end, okay? Family number 4, where biological, animalistic, organic, okay, payoffs are there. So females are interested more in the sex as a means because they're interested in procreation and maternal instincts. For people, for the couples of non-consummation of marriage, they are more interested in the coitus rather than the act of sex. And for the infertility, when they are told the 14th day of evolution, actually that becomes the Friday the 13th day for them. And by hook or by crook, they want to come over these two things to tell the good news and to the world, to their in-laws, to their parents that they are male, that they are females, and that they are having the potential to conceive. Of course, in case of maid guarding, this is more common in premarital boys. This is also common in the alpha males in animals, where the boy wants to destroy the virginity of the female or the girlfriend so that the other boy doesn't go steady with her. Yeah. And of course, hormonal imbalances can lead to hypersexuality. And in porn addicts, we all know that neurobiological stimulation is actually there. The dopamine reward pathway, right from nucleus accumbens to stria ventricularis and caudate nucleus. So what are the therapies for those women who are enjoying sex only for procreation? We have to tell them that now start enjoying at least and only for recreation. For non-consummation of marriage, telling them that non-penetrative sex can also be enjoyed, and building and maintaining relationships and bond is important. For the infertility couples, ask them to segregate the recreation and the procreation part, and tell them that yes, they can use IUI, IVF, and adoption. Even if worse come worse, they don't get conceived anytime, because as you know, almost sometimes 40 to 60% of the couples do not have any reason. It's an idiopathic infertility. And of course, they are very much frustrated and depressed, and rational emotive behavioral therapy and self-esteem counseling is what is required for these people who want to enjoy that but are unable to enjoy. And for those alpha males, okay, we have to tell them that don't objectify the females. Yeah, telling the women that you should know martial arts to protect themselves from the sexual assaults, and to teach them, this is very important, the two types of love, where one capital L love is enjoy the emotion love, but they should also have the small L love, that is verb love. Many people just know the emotion love, but they should do this verb love, okay, noun and verb. And of course, how to care, share, and have the romance. And as regards this, those who are obsessed with the sex, they can be given anti-obsessive therapy for hormonal imbalances and addictions, de-addictions are there, treat accordingly. And for the victims of addiction, who feel like servants or slaves of that addiction, okay, wo gulam ho jate hai us addiction ke, so they are having a lot of guilt and shame, and that should be addressed in the counseling and treatment. So this is one more group, the body-centered sex psychosomatic payoffs, typically elite intellectuals who read from the magazines that after having and doing sex, they would get brightness of skin, they would look sexy, fit, youthful, and that would be protective for all these organs. And what they require is endorsement from a sexologist and the permission lending from the illicit group. Now, these are another reasons, reason 31 to 39, okay, as a commitment, some women want to do, or some men, as a marital duty, they are doing it, okay. These are all sex as a means to an end. As a power game, this is used in social and spa, and even in marital scenarios. I will tell afterwards with an example. Social emotional blackmailing in cyber sex bullying and cyber sex is known. Pressure and force, if husband wants sex, I have to submit and give sex to validate their genders in case of males obsessed with EDS and penile lens. Peer pressure, I shouldn't be chucked out of the group. Some are touch hungry and they want to enjoy the hugs and kiss and embrace and touch. They are more wanting these things rather than sex, and they want the intimacy. And as per the neuro-linguistic programming, they want to do it as a body phenomena. They are very kinesthetic people. Okay, they would like to cook. They would like to go for a rock climbing and mountaineering. Okay, कुछ भी हो, लेकिन वो जो energy ज़्यादा है, तो वो utilize होना चाहिए. So even through the sex, they want to do that. And these were the questions all asked to the patients. And of course, for the reputation and the social status, telophilic girls are the young girls who are interested in the senior citizens who are having a lot of money and reputation. So what are the treatments? Yeah, so we should, for these people, we should tell them that remove the cognitive errors and arbitrary equivalences in their mind, teach them relationship dynamics who are just doing it as a duty, okay, in the marriage. And yes, so this is typical that give me materialistic pleasure and 24-karat gold, the spouse will tell, and she gives the sex to the husband, okay, and teaching the relationship dynamics and healthy use of power and remove the gender bias. Then sex to show peers that I am not odd man, but a brave macho man with ram or penis. For this, and I can go to the prostitute, okay, are mujhe kya kam samajhte ho kya aap? So for these individuals, we should teach them self-respect and how should they be socially assertive and sexually assertive and say no to the peer. Okay, value pressure is would definitely counter the peer pressure. And of course, know the limits of relationship, personal space, and both should be taught that men use girls only for sex. For those girls who want to enjoy it for reputation and friendship, this was a typical movie, sex as a ladder for getting status, reputation, sab kuch mil sakta hai mujhe. And sex, yes, to express the anger, hatred, contempt, and aggression. So we know that sometimes rapes and sexual harassment and exploitations, okay, means to an end. Okay, sex as a means to an end is done with this purpose. Revenge affairs, we have talked about jealousy, aggression. And the treatment for them is that typical Amitabh Bachchan's famous sentence that no means no from the movie Pink, and taking the help of lawyer, forensic medicine experts, sociologists, and telling them as regards consequences and negative sexual destinies. So negative sexual destiny is where the female victim will go either in a mortuary or if she is sexually assaulted then in the hospital. and the victimizer will go in the police station or the court. So these are the people we have to take their help. And then what? People who do sex for the financial purpose, to earn money by commercial sex workers, having jobs, favors, promotions, and goodwill. So many movies and dramas are there on these topics, to earn livelihood and stability, and sometimes blackmail. So just curious of sexual favors so that I get promotion, and just for that cake, okay? And people reveal what sexual favors they perform at the work to get ahead. So for them, the treatment is counseled to have clarity, offer rational alternatives, and tell them as regards legal and medical consequences. See, that's what I told, that the newer generation, unko prescriptive approach nahi chalta, ye karo, aisa nahi. We have to tell them, we have to cafeteria approach, that if you do this behavior, this would be the consequences. Now think of it. So sex powers, games, favors. I once slept with a childhood friend, so he would take me to the Hawaii. And even this is common in case of the post doctorate research. This is common in universities, where the teacher is asking the student for sexual favor to write or to sign the thesis, and vice versa. Okay. So these are the different things. I had one girl in my clinic who told me that her father had never hugged and cuddled when she was daughter. And that now she goes to the senior citizens and tells them that you just give me a fatherly cuddle and a hug, and my body is yours. I'm not interested in sex, but if you want, I will give it to you. So it is called as a sexual barter. So such sexual games are very much told very beautifully and nicely. Every sexologist should read the book Games People Play by Eric Berne, and where he has told that games are a compromise between intimacy and keeping intimacy away. Very nice book. And of course, sex was used in the history for ages together to form alliances between the kings, and the princess, or the prince would have sex and marry the XYZ princess, to increase the territorial boundaries. And now this is also done in corporates. And the male spy and the female spy, called as sparrows and ravens respectively, they use it for the espionage, that is in spying at international level, where they can have sex with enemies to get the secret formulas and documents, political, international, military documents, so on and so forth, and of course the astrological and spiritual causes. Okay, so and some people say, just like that, I am having sex. This astrological one, funny lady had been to my clinic, where she said that my Venus, which is a god of sex and romance and love, is very powerful, and hence I am having multiple partners. So she was doing nothing, but actually that was her belief, but it was rationalization and projection of her belief to some XYZ thing in astrology. But that is what people give reasons, okay, funny reasons. And of course, as regards
the last 2 minutes, sir.
Yes. And of course, as regards espionage, that's a fundamental ethical question, whether sex should be used for spying at international and national level to get the different secrets. So just like James told as regards 50 Shades of Grey, I have told in an integrated way the 50 reasons of enjoyment, okay? And finally, divided into two groups, that sex as a means to an end, the M, and sex as an end in itself. In philosophical words, it is said that sex as an end in itself is called as a posteriori, and sex as a means to an end is called as a priori. And the final question is, what about you? Okay, my friends, why we are enjoying sex? We should ask ourselves, find out to which group your patient belongs, and is there any basic incompatibility in the couple you are treating? Say, for example, husband is enjoying the sex as an end in itself, but wife wants it as a means to an end. Thank you so much.
Very nice, Dr. Prasanna Godre.
Thank you.
Opening 50 formula. Though it's a basic instinct, sex is a basic instinct, but you have given it, classified it into two, and basically you added all the ends of the nature and nature presentation very beautifully in a short time. Thank you very much.
Thank you so much.
Yeah.
Yeah, stop sharing.
Yeah. E-memento, please.
Yeah.
Yeah, please accept e-memento and bouquet
Yeah.
the organizing committee.
And thanks for the opportunity.
Thank you.
Okay. God bless all of us.
Yeah, next topic is it's sex and obesity by Dr. Ameya Deshpande. And the problem is slowly, gradually rising like water under the mat. So it is more evident in urban areas, but in rural areas, it is still picking up. So it is going to be a big problem, especially with the obesity-prone foodstuff available outside. And we are going to be enlightened, and light is going to be thrown on this topic by Dr. Ameya Deshpande, and who is MBBS GMC Nagpur and MD Internal Medicine GMC Nagpur, certificate course in infectious diseases management Mumbai. So this young man is going to make us wise on this topic, this upcoming problem of India. It is already there in developed countries. So welcome, Dr. Ameya Deshpande.
Good afternoon, everyone. Thank you for the introduction, sir. Now, my topic is obesity and sexual dysfunction. I am thankful to CSEPI and my father, Dr. Sanjay Deshpande, for this wonderful opportunity. In a world where the food supplies are intermittent, the ability to store energy in excess is essential for survival. But however, in the current scenario, because of the nutritional abundance and the sedentary lifestyle, this system increases the adipose energy stores and produces adverse health consequences. So the magnitude of the problem: globally, more than 1.9 billion adults are overweight and about 650 million are obese. 2.8 million deaths have been reported as a result of being overweight or obese. So in India, India is not an exception. We are in the front line when obesity is concerned. So more than 135 million individuals are affected by obesity. So now the question is, after the COVID pandemic, are we heading towards an obesity pandemic? COVID-19 has introduced the concept of lockdown, work from home. So many IT personnel, school children are just sitting in their home, working from home, and they're eating a lot of junk food. Now, in the 18th, 19th century, the people were dying from famine, starvations. They used to, they required an effort for eating, for the generation of food. But now the food is just a click away, thanks to the Zomato and Swiggy. So yes, we are heading towards an obesity pandemic. Now, obesity is defined as state of excess adipose tissue mass. The intra-abdominal and abdominal subcutaneous fat is more dangerous than the fat in other sites like buttocks and lower extremities. The mechanism for this is mainly unknown, but we can relate to the fact that the intra-abdominal adipocytes are more lipolytically active than other sites. So the evaluation of obesity. It is very essential to take a proper obesity related history, family history, then personal history, any addictions. Then we have to do the physical examination of the patient. There are many endocrinological syndromes which are associated with obesity and hypogonadism, like Prader-Willi and etc. So we have to also have an assessment of comorbid conditions, because obesity is many times related with diabetes, hypertension, cardiovascular disease. So we have to thoroughly assess any comorbid conditions if they are present. We also should have determine the fitness level of the patient. Like every patient is different, so we have to evaluate from patient to patient how much fitness the patient has, and is he ready to adopt any lifestyle changes. So the measurement of obesity, we all know BMI. So this is the classification of obesity on the basis of BMI. So more than 30, we can call it as obesity. Between 25 to 30, the patient is overweight. And 30 to 35, we can call it class 1. 35 to 40, it is class 2. And more than 40, then we can call it as an extreme obesity or class 3. So in Southeast Asians, the cutoff is between 23 to 27 for overweight. And more than 27, we can call it as obese, especially persons like Indians. So waist circumference, as we all know that BMI is not a very good parameter, because if a person is very muscular, then we can have a falsely elevated BMI. So the better parameter is waist circumference. So in men, it is more than 90 centimeter. In women, it is more than 80 centimeter. Waist to hip ratio is also one of the good parameter. In men, more than 1, and in women, more than 0.9. We can call it very significant. So when we talk about obesity, there has to be a mention about metabolic syndrome. So according to the National Cholesterol Education Program, Adult Treatment Panel Guidelines 2001, metabolic syndrome is 3 or more of the following: central obesity, that is waist circumference more than 90 centimeter in men, more than 80 centimeter in women, triglycerides level more than 150 milligram, HDL less than 40, blood pressure more than 130 by 85 mm of Hg, and fasting plasma glucose more than 100 milligram per dl, or if a patient is previously diagnosed as a type 2 DM. So these are the obesity related disorders. Like I don't want to dwell in the detail, but obesity can affect almost every system of the body. Seriously, we can have hypertension, congestive heart failure, coronary artery disease, type 2 DM, PCOS, polycystic ovarian syndrome. Then the respiratory patient can have dyspnea, obstructive sleep apnea, hyperventilation syndrome, asthma. Patient can have gastroesophageal reflux diseases, CA colon. Many malignancies risk is increased because of obesity. Then neurology, patient can have stroke, dementia. Patient can also have hypogonadism, and psychological factors. They are the forefront symptoms the patient can have. Obesity and diabetes. Obesity is a very major risk factor for diabetes, and almost 80% of the patients with type 2 DM are obese. So if the patient is a mild obese, he has twofold risk of diabetes. Patient if he is having moderate obesity, he is having 5-fold risk of diabetes, and if severe, then he has almost 10-fold risk of diabetes. So obesity and insulin resistance. So insulin resistance and hyperinsulinemia are the pervasive features of obesity. The insulin resistance increases with weight gain and it decreases with the weight loss. It is strongly linked to intra-abdominal fat, as I have said earlier. Insulin itself downregulates its receptors. Free fatty acids are increased and it impairs insulin action. Several circulating peptides are produced by adipocytes. So you can see in the graph, it is between obesity and insulin resistance. So there is hyperinsulinemia in the more obese patients, and so they are also having more insulin resistance. So now coming to the topic, is obesity affecting your sexual life? Like there is when we consider any layman, a layman thinks that if some person is obese, he must be having difficulty in his sexual life. So is it true? We will see in the further slides. So sexuality and intimacy are essential elements of a marital relationship. Good sexual life, good sexual quality of life contributes to physical, psychosocial, and emotional well-being of a person. So most overweight person think about themselves. Am I less attractive? Am I less sexually interesting? Am I incapable of developing a satisfying romantic relationship? So these are very general questions obese persons come to in his daily life. So what is a sexual dysfunction? The WHO defines sexual dysfunction for an individual as the inability to participate in a sexual relationship as he or she would wish. In the DSM-4, sexual dysfunctions are defined as disturbances in sexual desire and the psychophysiological changes that characterize the sexual response cycle, causing marked distress and interpersonal difficulty. So obesity and erectile dysfunction. It is said that a good erection is a gateway to men's health. Erectile dysfunction is a very sentinel symptom in diagnosing an occult cardiovascular disease or a peripheral vascular disease. So erectile dysfunction is a very important disease as far as obesity, diabetes, hypertension, dyslipidemia is concerned. So obesity increases the risk of ED by almost 30 to 90%. There are various studies, and so there is a very large range given in the various studies. Obesity is a very independent risk factor for ED in men. 79% of men presenting with ED have BMI of more than 25. BMI in the range of 25 to 30 is associated with almost 1.5 times the risk, and in the range of over 30, it is associated with more than 3 times the risk than in the normal persons. So the occurrence of erectile dysfunction in patients with obesity is caused by a number of complications which are characteristic for an excessive amount of fat tissue. For example, cardiovascular disease, diabetes, dyslipidemia. Erectile disorders correlate with the occurrence of obesity at any time during the patient's life. Obesity leads to erectile dysfunction in a considerably greater extent than aging. As far as aging is concerned, as the patient ages, the risk of ED increases. But if there is the patient is obese and is having any more comorbid conditions like diabetes, hypertension, then the risk increases considerably. So the mechanisms responsible for the independent influence of obesity on the erectile dysfunction are hormonal imbalance, endothelial dysfunction, insulin resistance, psychological factors, and physical inactivity. So the pathogenesis. Obesity can cause erectile dysfunction by damaging the blood vessels with what we call as endothelial dysfunction. It can also decrease testosterone and also cause a state of generalized inflammation in the body. Obesity can cause endothelial dysfunction due to associated hypertension, diabetes mellitus, hypercholesterolemia, hypertriglyceridemia, and inflammation. These are like the tires of a car. If any one of the tires is damaged, the car is going to stop. So all this hypertension, diabetes, hypercholesterolemia, obesity, these are all intertwined with each other. So in a well-studied and it is well-studied and accepted that obesity often leads to diabetes as well as atherosclerosis-related hypertension and cardiovascular diseases, which can cause ED. As I said earlier, obesity appears to damage the endothelium, that is endothelial dysfunction. And when the lining is damaged, the penis cannot get enough blood flow to produce and sustain an erection. This is one of the flow chart. Obesity, there is adipose tissue activation, dysregulation of adipokines and cytokines, various inflammatory cytokines are secreted, there is endothelial dysfunction, insulin resistance. Apart from that, there is low testosterone, there is development of metabolic syndrome and cardiovascular disease. So all this is a vicious cycle, and this all leads to the development of erectile dysfunction. So I wanted to throw some light on obesity and testosterone. The relationship between the obesity and androgen deficiency is very complex and multifactorial. Numerous epidemiological studies have established an inverse relationship between obesity and testosterone levels in healthy men. So testosterone is divided into three types. 45 to 50% is bound to serum hormone binding globulin. Almost that same percentage is bound to albumin, and 2 to 3% is free testosterone. So the free testosterone and that bound to albumin are the biological active ones. So SHBG decreases with increasing obesity in both men and women, resulting in a consistent decrease in total testosterone measurement, although the free or bioavailable testosterone may be within the adult reference range. So low SHBG levels are also associated with insulin resistance. Obese men have increased adipose tissue, and therefore the aromatase activity is upregulated. So more testosterone is converted into estradiol. So the urinary estrone and estradiol production rates is directly proportional to increased BMI as the testosterone gets converted into the estradiol. There is also a reduction of the luteinizing hormone secretion. The increased estrogen levels modulate pituitary LH response to gonadotropin releasing hormones. So LH action is also affected by increased leptin, and therefore the decreased LH action on the Leydig cells results in decreased secretion of testosterone. So this is one of the scatter diagrams. As you can see, as the BMI increases on the x-axis, there is decreased level of dihydrotestosterone, testosterone, free testosterone. So this correlates with what we have postulated earlier. So obesity and premature ejaculation. So premature ejaculation is the most frequently reported sexual problem among men. Many studies have been done to calculate the risk between obesity and premature ejaculation. So actually the patient who suffered from premature ejaculation, they had less BMI, that they were more lean. So various studies like the Anderson et al. And Goxie et al., they had studied the prevalence of obesity and premature ejaculation, but they found that the patient with premature ejaculation had actually BMI on the lower side. So there was no relationship was found between obesity and premature ejaculation. So coming to the female sexual dysfunction, the prevalence of female sexual dysfunction among obese men has ranged from 50 to 86%. Study by Kolotkin et al. Indicated that higher BMI was associated with higher impairment of sexual quality of life in women. David B. et al. Documented that extreme obesity also led to impairment of quality of life. So this is the flow chart. Obesity, they can lead to various female sexual dysfunctions like hypoactive sexual desire disorder, female sexual arousal disorder, orgasmic disorder, dyspareunia, and vaginismus. So obesity basically increases the incidence of dyslipidemia and the prothrombotic state. Diseases can cause reduced genital blood flow, secondary to atherosclerosis of the iliohypogastric or prudental arterial bed, causing vaginal wall and clitoral smooth muscle fibrosis, thus resulting in vaginal dryness, dyspareunia, and impaired sexual arousal. So Abedin et al. Conducted study on 204 participants, out of which a total of 25% had female sexual dysfunction. So the prevalence was almost 12.3% in the study. Of the sexual dysfunction, sexual desire was the most common problem reported by the participants. That almost 23 participants reported the problems associated with sexual desire. Satisfaction and sexual pain disorders were noted to have significant associations with the overweight and obese groups. So the management, I would like to enlist the management of obesity, because all the persons are actually well versed with the treatment of ED, premature ejaculation, and sexual dysfunction, and the esteemed panelists have already given lectures on that. So the management of obesity, so mainly lifestyle modification, that is diet therapy, that is advised if the BMI is between 25 to 30 and the patient is not having any comorbid conditions. So we first go with diet therapy. So the most important in the diet therapy is calorie deficit. So many times you have to start with a calorie deficit of 500 to 750 kilocalories per day. In some conditions, that is a very low calorie diet, that is almost 800 kilocalories per day, is also advised, but strictly under medical supervision. We have to stick to a diet of decreased sodium. That is, the sodium in the diet should be less than 2300 milligram per day. That is 2.3 gram per day. Physical activity is very essential. Almost it is advised, almost 150 minutes of physical activity per week has been advised. That is almost 30 minutes per day. So it should be strictly followed. And then behavior therapy, that is advice about lifestyle modification, addictions. It is very essential for the management. So pharmacotherapy, it is considered in patients with a BMI of more than 30 or more than 27 with some obesity related diseases. And if the obesity is refractory to lifestyle modification, then there are many drugs in the market. There are centrally acting anorexant, that is phentermine, mazindol, benzphetamine. They act on the arcuate and ventromedial nucleus of thalamus. So they cause satiety and they decrease the hunger of the patient. Then there are 5-HT2C receptor agonists, that is lorcaserin. There is one GLP-1 analog, liraglutide. GLP-1 analogs are recently in the market because of they are used in the treatment of diabetes mellitus. So liraglutide is a very important drug. It decreases the intestinal peristalsis, it decreases the glucagon, and it also acts centrally on the hypothalamus, arcuate nucleus of hypothalamus, and it improves the satiety. So these drugs have been started using in the market. Then bariatric surgery. Bariatric surgery has been very popular. We see many politicians going for the bariatric surgery. So it is considered for patients with a BMI of more than 40 or more than 35 with serious medical conditions. So the surgeries include absolute gastrectomy, gastric banding, Roxin via gastric bypass, and biliopancreatic diversions. So the take-home message: weight loss can surely do wonders. Many of the studies have been done in which the patients were advised weight loss, and they were successful in doing that. So the weight loss was associated with the improvement in almost 30% of patients with erectile dysfunction. So thank you for the patient.
Thank you, Amiya Deshpande. So he has given us various modalities of treatment, and also he has warned us the BMI should be not more than 27. And let us all note this, because of the post-COVID era, we are all likely to develop obesity in our patients also. So let us take this point as a gift from the organizing committee. The wonderful topic has been sent through us. So thank you, Amiya Deshpande. Please and the e-memento. And I thank organizers for giving me this wonderful opportunity of being the chairperson of wonderful topics and wonderful speakers. All of you, congratulations. Thank you.
Thank you, Amiya, for an excellent talk. It's a very proud moment for all of us, father, son, as well as all the managing committee of CSEPI. So kindly accept an e-bouquet and e-memento from the Managing Committee of CSEPI, the 37th National Conference of Sexology. Thank you. Thank you. So now, at the same time, I would like to thank the chairpersons, Dr. Sudhakar Babu sir, as well as Dr. Nageshwar Rao for chairing the session. Thank you, sir. And kindly accept.
Thank you very much. Thank you. Welcome.
Organizing committee. Thank you. Now we move on to the last part of the academic session of day 2 of the 37th National Conference of Sexology. It is a panel discussion, and the topic is after age of 50 years, women's perspective of male sexual problem and men's perspective of female sexual problem. The panelists for the panel discussion are Dr. Vinay Gupta, Dr. Gehlot, Dr. Saroj Gumasteman, and Dr. I invite the moderator for this session, Dr. Ajit Saxena, sir.
Thank you very much.
Yes, welcome, sir. Welcome, Dr. Ajit Saxena, sir. And I hand over the mic to Dr. Saxena for further proceeding. Thank you.
Dr. Raj, thank you very much.
Good evening, Dr. Saxena.
Good evening to you. Good evening. Am I audible?
Sir, please unmute yourself.
I'm unmuted.
Yeah, I'm unmuted.
I'm unmuted.
We can hear you. We can hear you. Ajit, we can hear you.
Sir, we can hear him, sir. We can hear him.
Hear you, sir. You are not audible.
Excellent.
Piyush, please see what is the problem.
We can hear him, sir.
Okay. Thank you very much, Dr. Deshpande. And at the outset, I must congratulate you, Dr. Venkat Ramana, Professor Narayan Reddy, and Dr. Padmini Prasad, along with the other organizing team, for putting up such an excellent performance. We've had a lovely weekend of sexual discourses. You know, for some of us, this is the only sexual excitement that we've had for a long time, thanks to the corona pandemic. I'm Ajit Saxena, and I work as a consultant urologist and andrologist at Indraprastha Apollo Hospitals, New Delhi. And perhaps the biggest misconception that a man has is the perception that there is much power in an erect penis. But you only go to ask an electrician, and he will tell you that the power lies in the socket and not in the plug. Let us take another example. While men get worried to death about the length of their penises, this is the third least important thing on a woman's mind. Ladies and gentlemen, the third least important thing for a woman. Yet, we carry on this misconception of a mighty penis. So, what does a mature woman want? I have an excellent panel today to discuss this topic. Sadly, one of our star panelists, Dr. Saroj Gumaste, is sick. And madam, we wish you all the success. Get well soon. Sanjay, can I start my slide?
They have to stop the sharing, stop sharing.
Sorry about this. Okay, now we are getting there. Sorry. Sorry, just a minute.
Sir, you go for the slideshow. You go for slideshow, sir.
I'm not getting inside.
You click on the slideshow, sir.
I'm not. Oh, yeah, now I got it.
This is there, sir.
Finally. Thank you very much for the patience. Now, as I said, one of our star panelists, Dr. Saroj Gumasta, is actually in the hospital, sick, and we wish her a very speedy recovery so that she can bounce back soon. My next panelist is Dr. Mithun Bhartia, who is a living example of how indulgence in sexual activity affects the growth of hair. You see in this photograph, he's got a lot of hair, but when he comes on, see what's happened. When I talk of sexual activity, I'm talking about his professional activity. He's a star in Guwahati and indeed the whole of Northeast, and he's got a very busy sexual practice. Welcome, Dr. Mithun Bhatia. May I now invite Dr. Vinay Gupta, who left a lucrative practice in surgery for sex. He's a renowned sexologist from Bilaspur and Raipur. But one thing I'd like to ask Dr. Vinay Gupta right now is that surgeons are very sterile people. How come you got indulged in sex? Dr. Vinay Gupta, you have to unmute yourself.
Okay. Hello. Good evening, sir.
Good evening.
First, I am thankful to the organizing committee of CSEPI who has given me this opportunity to participate in this panel discussion. I am especially thankful to Dr. Sanjay Deshpande, Dr. Venkat Ramanna, Dr. Reddy, Dr. Brahmbhatt. No doubt it's a very interesting virtual annual conference, and we have attended this conference more sincerely as compared to this routine conference. Sir, I am practicing andrologist sex counselor at Bilaspur, a small place from Chhattisgarh. Basically, I am a surgeon and my wife is a gynecologist. 25 years back, I wanted to help my male infertility patients, and I have attended various workshops of Dr. Rupin Shah at Mumbai. And at that time, because conception problem is also very important to achieve this one of the cause of infertility. So at that time, that was the era of intrapenile injection and this penile prosthesis. So when I have introduced myself as a male infertility expert, and I started this treating patient of sexual dysfunction, a lot of patients from sexual dysfunction, because nobody is there to practice sex and nobody wants to call themselves to be a sexologist. I entered this field and lot of patients I used to get. And 20 years back, I started this intrapenile injection just to support my patient, because inducing erection in your clinic is very, very supportive for your patient. Whenever your patients come with sexual dysfunction, apart from counseling, I did improve my counseling skill under the guidance of Dr. Vasta, Dr. Narayan Reddy, Dr. Vitthal Prabhu. And then whenever patients, whether it's young patient or old patient, whenever they come to your clinic, apart from counseling and improving the social problem, interpersonal problem, when you induce erection, either by giving this bimix, it's
I
a
see
lot.
you are one of the first persons to get a Rigi scan as well.
Yeah.
Welcome. My last, but not the least, to keep a sane discussion, we have Dr. Gehlot. He's a psychiatrist of formidable experience. And guess what? He spent 34 years and 1 month, all of the time in the Indian Railways. Dr. Gehlot, welcome to this panel discussion. But tell me, how come you stayed in the Indian Railways for such a long time? Was it the plethora of sexual dysfunction due to diesel?
No, in the railway set, the employees are working for the 24 hours. Mostly they are on the travel, and mostly they are on the shift duty, and there are many professionals working in the diesel set, working in the furnace, and many are problems they are feeling. So there is a lot of sexual dysfunction in the railways also.
Welcome. Now, my first question is going to be to Dr. Mithun Bhartiya. Dr. Mithun, before I ask you a question, how have you been feeling after coming back from UK and getting straight into sexology over the years?
He has been writing that if he is not promoted as a panelist, he won't be able to join here.
I thought we were all promoted. Dr. Sanjay, could you look into that, please?
Yes, I'm transferring him.
Okay. Meanwhile, Dr. Sanjay or Dr. Vinay Gupta, let me ask you a question. Because the other day you discussed about a 50+ diabetic patient who came with an infected prepuce and multiple cracks and painful retraction. Tell us more about this case.
Yeah, it's very
Case is a
common.
typical example of male perception and female perception. Yes, go ahead.
Yeah, it's very common. 50+ patients used to come in our clinic having this painful intercourse, maybe due to uncontrolled diabetes, and even non-diabetic also. The main problem is with lubrication, because 50+ women is having this due to menopause, this lack of lubrication, vaginal elasticity is their problem, and due to infrequent intercourse, their barrel becomes shrinkage. So in this way, this is the mutual problem after a particular age, which may affect one's quality of sex. And these patients require counseling as well as lubrication, good lubrication. And sometimes this patient may develop secondary ED also.
Good. Now, Dr. Gehlot, it was a simple problem of lubrication that resulted in all this sort of problems. Would you say that this is a common problem after the age of 50?
Yes, sir. This is a lubrication is the common problem, because due to the hormonal deficiency or under physiological reduction, there is less lubrication. So this is the common phenomenon.
Apart from lubrication, what do you think are the problems after 50 years in women?
Yeah, just join, sir.
On women, okay, I will. So
desire problems.
Women aspect. Actually, मैं man का expected. What is the man expected?
Okay, tell us about that.
Women expect many things from the one man, but men expect only one thing from many women, that is sex.
Right.
Dr. Saxena, Mithun has joined now as a panelist.
Okay.
Yeah, good evening, sir.
Good evening to you.
Good evening. Technical issues.
Well, welcome to the show. As in your absence, I was mentioning to the audience that what a lot of sexual activity can do to a man's hair. In your photograph, you've got a lot of hair, but here the hair is reduced.
Yeah,
when I talk of sexual activity, I talk about your professional activity. You've got a lot of following in Guwahati, and not just Guwahati, in the whole of Northeast. So we have a lot of experience in the field of sexology. How did you divert from endocrinology to sexology?
Yeah, so I think that's a very interesting question. I think if you ask me, I was in England, I was doing endocrinology training. And then we had a few patients come to see me. Maybe I remember a 65-year-old couple would come and see me and ask me about that they were having problems with their sexual life. So as a trainee, I didn't know much. I, asked my boss what to do. And my boss said,
Was
"Look,
your boss a male or a female?
my boss was a male. So he said, there's a sexologist who does a clinic. You refer him to the patient to them. He's not going to do anything, but at least the patient is off my head. So as a trainee, I did that once. Again, another couple came in. You become more inquisitive as a trainee. So I went to Jeff, who used to do the clinic, and I said, Jeff, I want to learn. He said, yeah, you can learn, but you see, the problem should not come to me. I should not get a complaint that you are missing your jobs and coming here to learn. So as long as you carry your belief, you do your activity, you can sit in my clinic. And so that's how the journey started. And then he sent to me to Oxford for training, and the whole gambit of the game started. But yeah, so it was a diversion, and I'm very happy in my life I took that diversion, I should say, because most of diabetic patients have this problem. So it's really, it gives me a bigger arrow in the armamentarium to fight against diabetes, and actually explain them that this is important and hear them out. I think hearing them out is very important, because nobody hears them out. This is what I felt.
Excellent. Now, while you've been having technical problems, we've discussed about the male's perception of a female sexual dysfunction. But here's a female, 57 years of age, who comes to you with a look of desperation on her face. It's all distress written all over her. And the reason is that the man, her husband, has been having progressive erectile dysfunction over the last 2 years. This woman blames herself for it. She says, because I'm no longer attractive, because my breasts are sagging, I've got wrinkles on face and neck. That's why this man has lost interest in me. And what's worse, he has seen this man ogling the smart young neighbor many times. So she feels very despondent. How do you tackle this problem?
I think that's a very good question, sir. I think there are certain facts I would first divide the question into, because there are myths, perception, reality, and an approach to this problem. See, we live in India, which has got a wider socio-economic condition, as well as the education level varies from people. Still, a lot of people believe, or are made to believe by their so-called husband or their family, that a woman is responsible for the male child, and which allows the man to decide to have another marriage, to have a male progeny in their generation. So that is the myth. People are born, people are driven into them, a lot of these myths, and people use it to their advantage. The perception, as you rightly said, is that I should be responsible for my husband's sexual arousal. And if I'm not physically attractive, as you've said, the inadequacy is mine. It's not upon the husband, because he might use as an alibi to have selective erectile dysfunction, not actual erectile dysfunction, and have sex with other partners which are there. The reality, however, is that the true ED needs to be evaluated for various reasons: psychiatric, hormonal, lifestyle, and physical. And so the approach to this patient is it should be a shared consultation. Both the partners need to come in the clinic, and the person's ideas, concerns, and expectations. Her ideas that she's not physically attractive, that's why the husband is doing, that has to be put to bed rest, and ask the patient's husband's answer should be recorded. This is a very interesting conversation, because you have to be very delicate in what the husband says in front of the wife. But I've often find that when they are there together, a lot of these approaches are settled then and there what is there. In terms of their expectation, I think a lot of time the expectation may not be a sexual life. The expectation may be a compatible life, but it depends upon what both of them wants. As you rightly mentioned when you had started your discourse, that it is not the time or the duration, it's not the frequency that is important, it's the happiness that is important. So I think the couple, when sat down together, I think a little bit of crisscross question, the question taken from her to be answered by the husband, to see what his perception is. It would be interesting to know whether he has the same perception or not. If he doesn't have the same perception, then a lot of things are settled then and there, because misconceptions often stems from non-dialogue. from non-communication in our country. And I think that would be, I would say, how to approach this patient.
Excellent. Now you brought out a very good point or points in this case. One is shared care. That has been the theme of this conference, and you just reiterated what everybody's been talking about in this conference.
Yeah,
Now,
so I agree, sir, because at the end of the day, we are like a policeman in the clinic. Our job is to, tell the traffic to go left, right, and center, but the car actually has to move itself. So the partners actually have to take the onus and move around. Our job is to make sure, things are moving in the right direction, and there to guide. If people ask her, "Bhai, ye rasta kahan ja raha hai, wo rasta kahan ja raha hai," we can tell them. But they have to do the journey. Our job is to signpost and support them. And I think that's how I look at diabetes as well. So that is perhaps the job of us. We should not try to be very patronizing to our patients. We should let them lead the way they want and suggest and help and guide when needed.
Dr. Gehlot, your comments.
Dr. Mithun has said very correct that the perception should be evaluated, that ED may be due to the cause related to men's with physiology, pathology, psychological and issue. There may be many issues. It is not mainly due to that woman is aging or she is not attractive. Although men's perception are different, men's also every time he wants that women should be attractive, her body image should be good, breast should be firm, round, skin should be shiny, wrinkle free, plastic, all things he wants.
Is this what a man over 50 years would want?
Yes, but that he wish are not always completed. Every man can wish whatever he like, because man wish is only one wish. He wish from many women and single wish. He want only sex, and women want many character from one man. So this is the saying, sir.
Ajit sir, if I may add, when I went to England,
yes,
I was searching for my first job. So you have to apply as a job to become an attachment, as an observer. So there was a guy who was our mentor, and I asked him, "Sir, मैं इस hospital में apply करूँ या उस hospital में apply करूँ?" He said, "Baba, if you think you want to marry Deepika Padukone, that is not the point. Deepika Padukone must be ready to marry you."
Absolutely.
So you must and wish you have the and we all wish and we all get.
Yes, yes.
But Deepika Padukone is also not a perfect person. Everybody has flaws in life.
Yes.
So let us a good enough husband and a good enough wife. You should be, and first you should be a good enough husband to become to expect a good enough wife.
Excellent. I think you hit the nail on the head. The man's perception and a woman's perception are they're totally different.
Yes.
And we need to know what is it that man wants and what is it that a female wants. But that we'll come back to that a bit later. May I ask Dr. Vinay Gupta, this case that we discussed about this 57-year-old lady, was that a one-off case, do you think, or is it very common in women to blame themselves for their partner's sexual problems?
No, it's not very common. The main thing is emotional intimacy and interpersonal relation. That is also should be taken into consideration. If it's a sort of case of extramarital relation, and 50 plus is no bar. Even a patient of 75 and 80, one of the oldest patient was 80 years old and he was coming to me for treatment, and his wife of 75, 76. So it's not only physical attraction, it's rather personal intimacy and emotional attachment. That is more important for having good sex. And sex is not penetrative. In this case, sex can be just enough sex, or unrealistic sex, or a non-penetrative sex. Emotional intimacy and good interpersonal relation is more important, in my view.
Correct. Dr. Gehlot is agreeing with you. You want to add something?
Yes. There should be a psychological bonding should be there. and intimacy should be there, not only for the sex, but there are other things, psychological and touching, caressing, etc.
So one thing is becoming clear. After 50 years of age, it is not just sex that a man wants.
Yes.
He wants more comfort,
intimacy, touching, hugging,
communication,
and psychological bonding.
Right.
They are more important.
Now, I have a very interesting article. What do women want in a penis? And this appeared in the University of Zurich article. It appeared in the Journal of Sexual Medicine. 105 women were asked to look at the penis for the length, girth, position, shape of meatus, shape of glands, scrotal appearance, penile skin, appearance of pubic hair, and overall cosmetic appearance. And do you know what they said? The least important was position and shape of meatus. So whether a person got a hypospadias or got a normal meatus, it didn't matter. The appearance of the scrotum did not matter. And the third is the length. Third least thing that a woman thinks of. So what are the most important criteria that a woman looks for in a man? The cosmetic appearance of the penis. Not just the pubic hair, but also the body hair. The girth and appearance of the skin. The girth matters, not the length. And the shape of the tip. Very interesting, very, very interesting. Any comments from our panelists?
During
carry on.
intercourse is the performance and pleasure and mutual satisfaction is more important rather than size. And as far as male is concerned, sexual myths is also there even at the age of 60 and 70. Penile size anxiety are there. If there is abstinence and wet dream, then they say it's they are going to harm us. Even the heart syndrome. So this type of misconception is always will be there. So main thing is counseling of couple, that is more important. Counseling of male, if he is not performing well due to his myths, then he should also be counseled, just like in young age or in premarital counseling. But because in these days, a lot of young people who are indulging in this premarital relations, and most of the time they used to perform nicely. They are become patients. Most of the number of patients in our OPD is failure to perform with casual partner or friends. So this is just due to myths and misconception.
But sir, they are having performance pressure. But I think after 50, the performance pressure is not the issue. The more issue is the physiological, because organic problem are more in women and men due to hormonal and other factors. Comorbidity also there in men, women also. So that is more. Psychological is less, organic is more, but psychological is related to the organic problems.
I am talking about the couple who is having regular relation, married couples having 30 years. Suddenly when they used to perform, fail to perform, then such type of myths may be there. This is one of the cause of their situational failure. They are not comorbid, they are not diabetic. So this also happens in this age.
But we are discussing mainly a 50 plus issue.
50 plus, mature.
So I am talking about that. I am not going to young people, young generation.
50 plus is not old. 50 plus is not old. End of sex life.
No, but is it 50 plus is not old, but they are in the graph. You see graph going to upside. Then a point comes when it goes to downside. So 50 is the age when the graph is reached its highest level, and now it is going to down. Whether in the case of male, because in the case of male, testosterone is going to low, and there are many diseases, dyslipidemia, hypertension, diabetes, obesity, and many more things. And same thing in the women, they are deficient in the estrogen and testosterone. So due to low estrogen or testosterone, their desire and libido is decreasing. And secondly, their organs, just a breast are sagging, skin has no elasticity. In the vagina, there loss of less pubic hair, less subcutaneous fat in the mons and labia. Labia is not incorporate doing when he is doing penetrative sex. So So labia is not separating. You know, in the young woman, the labia becomes engorged and it opens to receive the penis. But when the woman reach the menopause, his labia is not engorging. The penetration is difficult, and it is difficult for the man. The man is always not having good erection, and labia is not opening. So this is also a problem to the man, and problem to women. The woman is getting sexual pain during the intercourse.
Right.
Thinning of the vaginal lining, and due to estrogen.
Let's see what the endocrinologist has to say, Dr.
Yes.
Mithun.
Yes. So all the problem are there.
So
yes, agree.
जब सूरज डूबता है तो उसके रेज काफी इंक्रीज होते हैं, थ्रिव होते हैं. You get, before सूर्यास्त होता है उससे पहले you will see there's a lot of light. So my view is not that people's desire go down if they go before. There are physical problems, there are hormonal problems which can be addressed, but not the desire component. The desire component definitely remains, and in fact, I would say that the desire component is higher because of inadequate answer to the whole thing, or inadequacy of fulfillment of the whole thing. The desire definitely remains much at a higher level. Now, all these hormonal issues can be fixed up. If required. It is not very difficult to fix up. Estrogen deficiency, local can be there, HRT can be there. For male, if required, testosterone can be used as well. But I think what I've lately seen is an upsurge. We can call it an arbitrary number of 50, or we can call it an arbitrary number of 40, whatever. I don't think we can define age. But I have seen in my clinic, the referrals have gone up higher because the women have dragged their husband in the clinic, okay, or have sent their husband. Lately, I've seen last 6 months or 1 year, because previously the perception was that they feel that they have to live with that, the inadequacy of the husband. And now, when they realize, when people are coming out more educated, getting well informed, they're aware that certain treatments are available. So they want the treatment to do that. So that exactly implies that a desire has not failed. Definitely not failed. However, as you guys have already said, there are certain problems that happen, and then those can be easily overcome. Now, if you look at diabetic patient, which sir had, you guys had brought up a case earlier, bad diabetes control is a breeding ground for yeast infection. And when you have yeast infection, there is fissures in the skin, be the foreskin, be the male, be the female, and sex can be very painful at that time. Secondly, sexually transmitted disease. If the partner you feel has got multiple partners, or is using selective ED as a pretext for doing what he wants to do, he is harboring sexually transmitted disease as well, and that can also have a relationship of performance as well. But as all said and done, be it 50, after 50, or around 50, emotional stability or emotional relationship is important, but physical relationship is also important, and that can be overcome by a couple coming together in the clinic. And what I generally do is that I speak to the couple separately as well in the clinic, when after speaking to them singularly or together, because very often the story changes, or they want to say something when they are not been able to say, or do not want to say, to hurt the feelings of their partner. And then it is up to the clinician to then manipulate the whole clinical scenario for the benefit of the patient. So as I said, so I use this again, and for menopause, there is a saying in hormone, women in the winter of life should not be denied the summer of life by not giving them hormone replacement. I think they have a duty to actually enjoy the autumn of their life as well.
There is a corollary to that.
I will add.
As women age, it's like an old wine. It matures.
So what I want to say is that overall your physical fitness is more important. Or if you are comorbid, then age is not issue.
Then
if you are comorbid, you are physically fit, even up to age of 60, 70, or 80, you can have normal sex. At the same time, what I have seen, this testosterone level doesn't affect desire, because some of our patients, in my experience, even the patient of Klinefelter syndrome, he is having this atrophic testis. His testosterone level was less than 10, less than 20, but he was performing normal sex. He usually come to us for infertility problems. So hormone is low level of hormone, lack of desire is more due to this socio and interpersonal and situational problem rather than this andropause and all these things.
So communication is the most important thing.
And I say,
Dr. Mittal,
already mentioned testosterone. One thing which I will like to highlight is assays of testosterone are not extremely good in wherever we are practicing pan-India. I'm making it a pan-India statement. The best way to actually do testosterone assays of free testosterone is by equilibrium dialysis, which does not happen. So I think I am very, very circumspect. I would only do a testosterone testing if I've committed and I've told the patient before that it is like thyroid. अगर आपका deficiency है तो पूरा जिंदगी लेना है. तो अगर आपका testosterone deficiency है 3 महीना लेने से अपने आप बनने नहीं लग जाएगा. It will be for life. So that counseling I do first before I embark on the journey of checking, because then you are in no man's land. And because 50% of patients, you tell them you need testosterone for life, they will back out. So I don't kind of test. And if I do the total testosterone, I do it with SHBG. And there's a score that which you can find out on the website, which you can equate with the albumin, the actual free testosterone.
And then you have to calculate the free testosterone.
Even then with PADAMS questionnaires, if it is more than 3-4 questions are there with the patient, and patient is having this poor performance, not responding to PDE5 inhibitor, and if he is understanding it, well-educated patient, if testosterone level is low and we give the shot of this Sarnas for 3 months, 6 months, he is responding well. A few of my patient is at testosterone therapy for a long time. They must be 62, 63. So in that way, it is helpful in selective patient. Even free testosterone, sometimes it is not being done properly. Even the testosterone, getting this testosterone estimation is very difficult. But in that way also you can put this patient under your supervision, doing this regular PSA and all those. This patient can be benefited.
I think the only problem becomes medico-legal, sir, rather than anything else. Giving testosterone injections without actually seeing the testosterone assays to be low, and subsequently I would like them low in 2 occasions, because everybody can make a mistake. We all have made mistakes in life. The pathologist could also have made a mistake. The typist could have made a mistake. So I would like 2 levels to be done first when they're confirmed low before I embark on that journey. Because you see, the landscape of testosterone replacement keeps changing. Today you might, everything is fine. Some trial will come out about cardiovascular unsafety. So that keeps changing. So you have to be not on sticky grounds.
No, but when there is a borderline low, if it is remarkably low with even total testosterone, we can start this testosterone replacement with a trial. And when the patient is responding well, we can continue it under our supervision.
No,
when is it borderline?
I think the main important thing is lifestyle modification.
Yeah.
Yes.
And with that, you can give testosterone for a little while. I don't know if Dr. Mithun agrees with that.
Dr. Saxena,
yeah.
We have 5 minutes left.
Okay.
Well,
Thank you for
I digressed a little bit. Let's get back to our.
Let's get back to
what we were trying to say. I think, if I have to do my closing statement, I think let's not be ageist in our approach. I think nothing changes much. In fact, I would say desire goes up after the age of 50 because of lack of output that you can get with that raised desire. So desire is higher. Hormonal problems can be fixed. We can have different avenues or different discussions how we reach that ultimate goal, but things can be sorted out. But more important is that the couple needs to be heard together, and then it's a shared care that we can come to the point. That would be my closing views.
Shared care and couple examination. That's what Dr. Mithun says. What about Dr. Vinay Gupta? What do you?
Sir, I will suggest this. Recently, I have started this just like sildenafil test, just to boost up the confidence of our patient, whether he is a senior patient or young patient. This NLFL induced erection test. NLFL, give NLFL. NLFL, it is short acting, and patient can go home after this 4 or 5 hours. And if you induce erection and give him confidence, every suggestion, every counseling in all age group will be more beneficial.
Good. Dr. Gehlot?
I will say that after 50, many things can be controlled by lifestyle modification, exercise, yoga, and diet modification. We can improve hormones can also be improved by the specific diets and this exercise. And we can correct the comorbidity, treat the comorbidity so that sexual function can be improved. So suppose if somebody having diabetes and his sugar is not controlled, then his sex function also deteriorates. So you should control this all comorbidity and lifestyle modification, and that automatically will improve the sex in men and women both.
Gehlot sir, we use it as a bargaining chip also to get the diabetes control often, and that often really.
Yes. No,
Yeah.
I do it. And last time in my clinic, a person ages 69 years came with his wife. She was having 67 years. The couple come for his ED, treatment of ED. The man was very overweighted. It was having 20 kg more weight. And when I investigated, he was having uncontrolled diabetes, dyslipidemia, obesity. So I told him, before I can't treat your AD, before you control your weight, you control your diabetes, you control dyslipidemia, I can't sow the seed.
There you go. We are talking about integrated care once again. That's what is required.
Yeah.
Now, I'll just finish by quoting a paragraph from Sex Beyond 50. May not be in the prime men, but still have a strong sexual appetite. Men over 50 years of age, what do they want in bed? Someone who is confident about their body, their sexuality, and their experiences. So what does this book have to say to women? What should they do? Well, use hands more, initiate sexual more often, non-judgmental, emotional satisfaction, show desire and trust. These are the salient features mentioned in the book Sex Beyond 50. And insofar as women are concerned, we've talked about that. Anyone wants to add anything?
No, I think you've covered it well, sir.
We've covered everything. And since time is short, we could have gone on and on, but thank you very much, Dr. Gehlot, Dr. Vinay Gupta, Dr. Mithun
Thank you,
Bhatia.
sir.
We have had a lovely discussion and keep it up.
Thank you. Thank you.
Back to you, Dr. Sanjay.
Thank you, Dr. Saxena. You are, in fact, the specialist in conducting the panel discussions. I know in a lot of conferences and programs, you conducted the panel discussions so nicely. And it was wonderful to listen from all the three panelists. Sir, can you close this? Can you stop your sharing screen?
Sharing. Thanks once again.
Thank you, sir. Thank you, Dr. Saxena, Dr. Mithun.
Over to you for the valedictory.
Yes, sir. So the floral bouquet to all the panelists.
Thank you.
And
Thank you, Sanjay.
These are all e-bouquets and e-mementos. So kindly accept.
5 o'clock.
So it was a wonderful session. Dr. Mithun, sorry for the trouble, but I can't do anything because I think many times physical conferences are better. You can call the person and ask him to sit for some time, but during these technical errors, you are helpless. So I'm very sorry for that delay.
But we made it.
So hoping to meet everybody of you in February, because we will be having our midterm conference of sexology by Council of Sex Education and Parenthood International in Goa.
Sure.
What we missed
Very good.
this time, we'll be planning in Goa in February 2022, and again at Delhi in August 2022 under the able leadership of Dr. Sood. So let us meet again physically. That will be the most enjoyable thing, I think.
Let's hope so, sir.
Yes, we are eager to meet physically.
Yes. Physical relationship is more important than anything else. At the message,
we are eager to meet physically.
So in the short moment, we'll be starting our valedictory function. I request everybody to stay. I'm calling our guest today, Dr. Dilip Gode. Sir, join होता? Hello, sir. आता सुरू होईल. You please join. Okay, thank you, sir. Sir, you please start your video so that we can see you. Yeah. Okay. So welcome, Dr. Dilip Gode. I think most of the surgeons know him, and there are two surgeons here, Dr. Vinay Gupta and Dr. Ajit Saxena. Yeah. So Dr. Dilip Gode is a reputed surgeon in Central India. Presently, he is the dean of Datta Mege Medical College. He was a vice chancellor of Datta Mege Institute of Medical Sciences, deemed to be university at Wardha. He is the ex-national president of Association of Surgeons of India.
Yeah.
He is the ex-national president of Association of Minimum Access Surgeons of India, AMASI. Actually, this 37th National Conference of Sexology was organized by CSEPI with Andrology India, Indian Andropause Society, and Men's Health Society, and Datta Mege Medical College, Nagpur, and Datta Mege Institute of Medical Sciences, Wardha. They were our co-partners. And I am very much thankful to Gode sir that he was instrumental in getting all the sponsorship and all the collaboration from Datta Mege Medical College as well as Datta Mege Institute of Medical Sciences. So I welcome him, and I request Gode sir. Yes, I request Gode sir to guide us for our future journey. Dr. Gode sir.
Yeah, good evening, all the distinguished members, the distinguished organizing chairman of this conference, the organizing secretary, delegates, and all the guests here. That's a real honor for me to be here this evening. I could not be there for the inaugural function yesterday because of some problem in my college. In fact, I must thank Dr. Sanjay Deshpande for giving us this opportunity to be a partner in such a very, very important conference, which majority of people, like in patients, this specialty is so much of a help to those people who are really distressed for no reason. And once I believe there is some consultation from your specialty, people from your specialty, they are, I mean, just free of their worried symptoms and all those things. So it is a great time for us that we are the partners here. And I can understand, I was just listening to the last panel discussion. I could not be a part of the entire conference, but I was listening to some of the very important lectures. They were of real, of a high quality lectures in this conference. And Sanjay had been telling me, sir, come once in a physical conference. And really, I look forward to your conference in Goa. Sanjay, I would myself register for that conference and be a part of it. And would really like to see or like to listen to all the lectures. I mean, it's so interesting. In our country, I mean, talking about sex, it's itself a taboo. And, but people suffer just because they don't come out and they don't tell what they are feeling it, and all bad things happen out of this. So I believe that your society is doing great service to this nation and would continue to do so. not only to our nation, but to our patients. That's very important. So I wish all the best to all of you. Sanjay, thank you very much for inviting, and all the delegates. You must have enjoyed the conference, and I believe that you must have taken some take-home message ultimately. I mean, that's an outcome of the conference. You need to take some take-home message. And else you attend a conference, whether it's surgical, whether it's a medical conference, there are so many doubts among the delegates are clear, and probably that's the platform, and that's the thing why we organize such conferences. Only thing this time, because of this online conferences or e-conferences, we are truly missing the fellowship, which is so important for to be a human, is to have a fellowship. That's the difference, in fact, between a human and other species on this earth. So that's missing, and probably hopefully by next year end or this year end, we should be all again together in conferences, enjoy deliberations, enjoy each other's fellowship, and look forward to being a delegate for next conference. Thank you so much, Sanjay, for inviting me, and all the best to your conferences, and all the best to your society, and thank your society too for being a partner with Datta Mege Medical College. And if any delegate from your society is in Nagpur, Sanjay, please invite them to our college. Let them be our guests there, and take the advantage of their knowledge so that we could arrange some guest lectures, something like that. Thank you very much once again.
Thank you, sir. In fact, I would like to tell all the audience here that Gode sir is my, you can say, friend, philosopher, and guide. Though he is a senior, but he is always friendly, always guiding us. I can share you that we have the roots common from Wardha, and the chamber which I sit in now from last 20-25 years was also previously owned by Dr. Gode. So it was a very nice coincidence that we are working together, and sir was the chief guest for today's validity function. Thank you very much, sir. So, yeah, Dr. Padmini, are you here? Our honorary secretary.
Yes, I am there.
Yeah,
I am there.
so I am requesting you to do the honors. The most favorite job of all the president, all the secretaries, is to propose a formal vote of thanks. So I request you to formally propose a vote of thanks, so we can end on a very happy note again to meet at Goa in February 2022.
It is my pleasure and privilege to do the pleasant job of thanking each and everyone who was a part of the great conference. So congratulations to CSEPI as a whole, and special congratulations to Dr. Sanjay Deshpande. I also thank Dr. Dilip Gode for his participation and his good message filled talk. So thank you very much, Dr. Dilip Gode. And I also thank all the chairpersons, all the speakers who were all part of this, and the best audience that we had, who were there throughout the conference and who attended with all interest and curiosity, and so much of a knowledge sharing sessions we had. And I thank all the pharma partners who were there, digital partners and pharma partners. And thank you all. And those who were sick, unfortunately 2-3 people were not well during the conference. I wish them speedy recovery also. Thank you very much for all the wonderful things that we had. We'll go back with good memories, and we hope to meet you all physically sometime later, at least in Goa. We hope that no other wave, third wave, fourth wave, or no other wave comes back. Thank you very much.
Thank you. I will add that thanks to Zydus and thanks to DigiShield, who were our digital partners and who made this conference, virtual conference, successful. So thank you all. Thank you, Padmini Madam, also, because honorary secretary's job is that nobody thanks her.
No, it's okay. It's okay. If all are happy, that is our thanks only. If everyone is happy, go back. Yes.
So thanks to Honorary Secretary Dr. Padmini Prasad also. Thanks to Dr. Venkatramana and to Dr. Narayan Reddy because these two persons, they are always, they stand behind me for any work, any endeavor, any program. So thank you all the chairpersons, all the speakers, all the delegates, our chief guest today, and thank you all CSEPians. Basically, they always are in support. They register.
All encouraging delegates.
Yes. So thank you.
Thank you
wish
very
you
much.
all the best coming Navratri and Diwali.
We will meet in Goa.
Let us meet in Goa.
Yes,
Have
sir.
a
Goa
Thank you very much.
and Delhi.
good fellowship.
Yes.
Thank you, sir. Sir, namaskar. Good day, sir.
Bye.
Thank you. So we'll end here.
Yes, sir.
Thank you.
Thanks, Dr. Ajit Saxena. I was listening to the panel discussion also. It was so nice. Inputs were there during the panel discussion, last discussion.
Thank you.
Yeah.
Thank you very much
Thank
for your appreciation.
Thank you
So
very
nice to hear
much.
feedback.
Thank you. We are all living with good memories. Thank you, Dr. Sanjay.
Thank you.
Bye.
Thanks a lot for the very nice conference.
Yes, sir.
Thanks,
Thank
And
you.
it
Thank
was-
you, each and everyone. It was a
It
very
was-
Thanks, Dr. Anand Jawar. Thanks, Gailot, Dr. Gailot.
Yes.
Thank you, madam.
Thank
At
you.
least we enjoyed seeing each other and talking to each other, though
Yes,
virtually.
that is
But
a-
you can see face to face each other.
Yes.
So that is
That's
also
a
good feeling.
Yes.
So that at least we had. Okay. Thanks a lot.
Thanks,
you. See you,
Piyush,
guys.
from DigiShield. Piyush, are you there?
Have a nice evening, all of you.
Yes. Thank you.
Thank you, Piyush. Piyush was
It
managing
was-
all the show. So we're troubling him because the delegates had some problems of joining and all. So he was constantly in touch with me. And
No,
thanks to
it
Mr.
was
Raj
all very
also.
smooth.
Yeah.
No, we did not have
Luckily-
any problem. It was very smooth, and so many times reminders were sent, and it was very easy to join. There was absolutely no problem. We should really
Luckily-
congratulate them for so much of pains which were taken.
Luckily, it was virtual conference, so I could attend even being in Dubai.
Yes.
So that's a good.
My colleagues who were there in Nagpur, Dr. Kush Junjunwala, Dr. Vijay Upadhyay, Dr. Sarita Ugemuge, Dr. Archana Deshpande, and Mr. Raj Panchadhani, all they were my backbones, you can say. They were continuously working from last 2 to 3 days to make this happen and to make this successful. Thank you to all of them, and thank you to all of you.
Thank you.
Thanks a lot.
Thank you.
Thanks a lot.
Yes. We'll leave now. Thank you.
Yes.
Yeah.
We'll leave.
Bye. Again to
Bye.
meet.
Hello, Prasanna.
In Sanskrit is a punaragamana yacha. So again we'll come and enjoy
Yeah.
the fellowship.
Yes, we
Yeah.
enjoy. Come back and enjoy.
Yeah.
Thank you.
Yeah.
हाय कैसे हो? हाय कैसे? बस happy with again. Can you say 500 please downstairs? हाँ अभी तुम्हारी वेट कर अभी आप आएंगे तो थोड़ी देर में पापा को बोलिए oh sorry पापा को हेलो सर घर पे से जाके
घर पे जाना। कितनी बड़ी फैमिली है आपकी? लाइफ कितना? 30 बहुत बड़ी चीज है पेंटिंग, 100 की बस करनी है। और अभी इसकी तरह अच्छा, मेरे को यहाँ ब्रीथ की पेंटिंग लगी हुई है ना, आप देखना, वो मुझे एक पेशेंट में अलग सा है ना, आपकी गए कहाँ पर? अच्छा, उस आगे तो आ जाओ। ठीक है, नहीं नहीं, पेट्रोल मैं अपने काम कर रहा हूँ, पेट्रोल मैं नॉर्मल नहीं नहीं, ये तो मैं अपने काम कर रहा था बच्चे देख सकते हैं। हाँ, get something for the boy. Okay, after all. 10 बजे ज्यादा ना मजा आएगा। हाँ, मैं 12 बजे करीब मंडे 2 बजे पता नहीं। ठीक, ओके। हाँ हाँ, बदल लूंगा आप यार। जरा विनीत से मेरी बात करो, विनीत से मेरी बात करो, विनीत से हाँ मेरी बात करो। अच्छा नहीं ठीक है, ठीक है, ठीक है, मिल गया काम। गया। अच्छा ओके हाँ फिर वॉइस में मॉड्यूलेशन में फर्क है अगर ठीक नहीं कोई खास नहीं बस ठीक था नेशनल कर पा रहा हूँ वो है अब इसमें 2 स्टैंप लग रहे हैं एक एसएमपी का और एक मेरा आप बात कर लीजिए हो जाएगा ना आप नीचे क्या ना एक्सरसाइज करना बंद कर दो और कोई दवाई कुछ मैंने उसको कहा था मैं शाम को दे दूंगा तो आप लगा देंगे ना पहली बात तो ये आया उसमें टिकट भी नहीं होनी चाहिए इंसान को बात नहीं करते यही कहना आप इंटरेस्ट दिखाओ सब। इसको इसलिए दिया था कि वेबसाइट के लिए। नौकी की इंग्लिश क्या होती है? What? नौकी। God permission. नौकी परमिशन है। 2190 कल करवा दीजिएगा 28.9 is the last date. Y3 का 0.44 है वो 2190
फिर अगर आपको मैच देखना है तो आप यही कराओगे
हाँ ऐसे भी ठीक है
कुछ करने को नहीं होता लोगों को बढ़ा लो भाई क्या सोच रही है मैच चल रहा है बैक टू बैक
दो तीन मिनट में पहुंच रहे हैं अब 2-3 मिनट में पहुंच रहे हैं तो क्या मना है ऐसे मैसेज आए तो अच्छा लगता है You were the last man but the best of the lot.
किसने कहा
Dr. Fayyaz from Mumbai.
but the best of the आपने अपना कुछ कितना छोड़ा होगा ना
वो तो एक नहीं बहुत सारे
कैसे कैसे
You're always the best.
किसने लिखा
Fayyaz हैं Mumbai.
भैया ये नाम नहीं सुना
इसमें तो different kind है
पर ये केस में मुझे ज्यादा हो गया काफी लोगों ने सुना जरूरी नहीं कि नॉट के होंगे कि सबसे लिखते होंगे अगर इसको बुलाने आप नीचे जा रहे हैं उनको भेजना नीचे आ
Hello. Sorry, I had a webinar.
इससे शॉपिंग बाबूजी आप नहीं सीखा बिना लिमिट शॉपिंग करेंगे आपके कार्ड है जो इसके फायदे ये है कि रिस्क कम होता है और अगर फ्रॉड भी हुआ तो बैंक को बोलते हैं एक्सपेक्टेड नॉट द लिमिट लिमिट फॉर सेट है आरबीआई कहता है शानदार करते हैं sodium bicarbonate can be balanced with potassium bicarbonate to give you baking powder. You'll find this in the kitchen as cream of tartar. Rahul, you remember what sodium bicarbonate is also for? Yes, baking soda. Right.
Hello? Hello?